Good morning, madam. All. Fine. ये भी कर फोन कर ये जाने दो 2 मिनट के लिए आशिम जा रहा है गुड मॉर्निंग एवरीबॉडी गुड मॉर्निंग ऑल
Good morning, Satish. You are looking like a dawn.
actually I caught the eye flu last night, so I have to wear the glasses to protect others. I'm so sorry. So
You got a what?
eye flu, viral flu in the eyes.
Eye flu.
And this is
Conjunctivitis. Eye flu.
This is extremely contagious, you know. Even if you look into the eyes of a person who has flu, you immediately catch that. But don't worry, you can't catch, you are far off. Don't worry, you can't
Well, I'm
catch
very
all mine.
impressed that you're still here and going to be dissecting for the next 8 hours. A lot of dedication, that is.
See, I'm still wondering whether eye flu is really viral or it's just too much whiskey, Satish. Yeah, I think so.
Professor Harvey, it is extremely contagious, so don't worry, you can't catch.
Both conditions are contagious.
So everybody, you're all welcome to this webinar, and the mastermind behind all this academic activity is none other than our own Professor Dharambir Sethi, who has been, someone who has revolutionized the sinus surgery, not only in our country, not only in India, but everywhere. I remember the times after my post-graduation when I came in contact with him and learned the basic of sinus surgery, right from holding telescope in the right way till all advanced approaches of endoscopic sinus surgery. And he had been kind enough to have allowed me to his workshops, his center, in Singapore General Hospitals, and everywhere. And I have no words to, thank him for everything what he has taught me. So, Dr. Sethi, you are the one who is, pulling everyone into this advanced knowledge to this science of endoscopic sinus surgery. And I am indebted to you for everything you have given us. For everyone, Dr. Sethi had conducted probably more than 50 workshops in our country. Every year he would come and travel in different parts of India to teach this science of sinus surgery. And I call him, I am not wrong, Dr. Ashim Desai is here, Dr. Ashish Bhumkar is here online with us. We call him as the father of endoscopic sinus surgery in our country.
That is true, actually.
He has propagated knowledge selflessly in this field, which was in infancy in the, I remember the times in year 2000 when hardly, couple of people were doing sinus surgery, that too not very extensive and not very concept-oriented work. Then the man whom I really worship for strengthening our knowledge and giving further concepts to the sinus surgery, Professor Richard Harvey. I remember his book, once he published, Concepts of Sinus Surgery, Understanding Rhinosinusitis at the Molecular Level. I was thrilled. Initially, when I started book, the first day I slept after the second page. But believe me, the kind of information he brought into that book was amazing, beyond the thought process of anybody who is, treating this chronic rhinosinusitis, considering as a surgical entity. This is a medical disease which has a definite, underlying pathologic process, pathophysiology, which a lot of people still don't know and considering as a surgical entity. So surgery has a big role. And once it comes to surgery, we have to carry out in a very, very particular fashion to prevent complication, because this is hardly any, safety margin with lot of skull base, orbit, and surrounding structures in close proximity. So Professor Harvey gave a lot of insights into understanding this disease and strengthen our work on chronic rhinosinusitis. And still, honestly, believe me, I don't leave any single publication, article, any work. His even editorial. He has been chief editor for many journals in the world, many prestigious journals in the world, and I don't leave any single word he publishes. That's the kind of knowledge he has, the kind of information he has, and we have no words to thank you for delivering all this to the world. Thank you, Professor Richard Harvey, for being with us today. For everybody who are watching, Professor Harvey was in Singapore for some important, assignment, that is pure research work at the molecular level and developing biologics into practice for chronic rhinosinusitis. And on our invitation, on Professor Sethi's invitation, I tell you, he has been here with us, sparing his valuable time for us. Thank you so much. We have Dr. Jain, who has been, the backbone behind organizing this event and many other Singapore events. He is a prominent, rhinologist. He has done phenomenal work in allergy and sleep and many other things. Thank you, Jain, for involving me again and giving this opportunity. Then my two brothers, Ashim and Ashish, who are, that is the God has been kind enough to give me these brothers in my life who have revolutionized my life. Ashim, we all know, is the master surgeon, master otologist on the planet. Believe me, I have never seen an otologist like him. Besides, like father, like son. And he has gone even beyond, and he is now doing a lot of work and a very, sought after faculty in rhinoplasty and sleep surgeries. So Ashim has always been a backbone in our practice, in our workshops. I tell you, whenever we organize workshop and Ashim is there, we are so relaxed. We keep all difficult cases, all, cases we don't know ABCD about them in otology for Ashim only. So in our workshop, you see the past videos and, past courses, Ashim has never been doing a simple case, doing all difficult cases and teaching us and taking it to a next level. You can see on screen the Master Ashish Bhumkar, the man who has revolutionized external ear surgery and pinna reconstruction. Pinna reconstruction is an art. He has been a thorough middle ear surgeon, renowned middle ear surgeon, and he went into this field of pinna reconstruction, which had been the part of, the baby of plastic surgeon. What he has revolutionized is the hearing reconstruction added on to pinna reconstruction, which plastic surgeons do not know ABCD about it. Plastic surgeon would reconstruct the pinna everywhere in the world, but not the hearing. So he's the one who has revolutionized this science and doing same stage hearing as well as pinna reconstruction. And this is something, always a treat to watch him operate. Thank you, Ashish, for being with us so early morning in India. It's 7:30. Yes. I know we started 10 o'clock Singapore time, but this is 7:30 in India. So once again, you're all welcome to this webinar. And we are here at the state-of-the-art GNU, the Jaipur National University in Jaipur, which is a state-of-the-art university, one of the top and the prominent universities in this region, and which is growing like anything with a lot of association with the international universities, including Harvard and many, for the exchange of knowledge for their students and for their betterment. And this course, I am indebted to certain people in my life for this anatomy and dissection courses. Dr. Sethi, can you recognize someone? Focus. Can you recognize someone?
Of course. Nice to see you, ma'am.
Madam Neelam Bafna, for everybody, whatever I am today, I owe to Madam for many reasons.
Oh my God.
Madam had been professor and head at the prestigious SMS Medical College. After retirement, she is now the emeritus professor of anatomy in this university. And still continuing her passion of teaching. And Madam has always been kind enough to provide us cadavers whenever we need it. You know, so many workshops we have done earlier in SMS, JNU, and many other workshops, and she has always been, backbone in providing all cadavers, temporal bone, skull, so many things, whatever we wanted. Even in the night in the dissection hall to dissect and, practice some other approaches, she has never refused for anything. Even we have done more than 30 cadaver dissection courses with her, with more than 20 cadavers simultaneously at one time. So many hands-on cadaver dissection courses we have done with Madam, and Madam has, never refused for granting anything to us. Thank you so much, Madam, for being very, very special in our life. And whatever anatomy knowledge, believe me, whatever I'm having is purely because of Madam. Thank you so much.
Okay.
Dr. Sethi, you remember Colombo?
Yes, I do.
Dr. Sethi,
Ma'am, are you going to sing a song for us?
Old songs you sang, in Ganga. It's really very nice to hear the old songs from your side. When are you coming to Jaipur?
जब आप बुलाएंगे.
अरे जल्दी आइए. Okay, carry on, bhai.
Thank you, sir. And getting on to our work today, so we are going to, we are going to start our first session with the endonasal dissection. Endonasal dissection. We'll start with the basics of endonasal anatomy. Are you getting the endoscopic picture, boss?
Yes, we are getting a lovely picture. It's perfect.
Excellent.
So this cadaver,
Done a CT scan of the cadaver?
not really. This cadaver, Ashish,
Yeah.
is donated by none other than our Jain community organizations.
Oh, okay.
I told you in our previous dissection,
Hmm.
our Jain community is committed
Maximum
to
dose.
provide bodies for the teaching and training purpose. And this is over 200th body they have donated in our dissections whenever we wanted for our courses. They provide us, and more than 40,000, Jain people have, consented to donate their bodies
Okay.
for teaching and training purpose. So I'm thankful to them
Yeah.
for this unique help for this teaching and training. So this person is 90 years old, died 10 days back. The body was kept in deep freezer, and yet this is very, very fresh. You can see the tissue.
Yes.
It is not formalized. And again, thanks to Madam for taking care of everything to have kept in the freezer, checking every day, adjusting the temperature needed. And that's how we are getting the fresh body like we wanted.
Fantastic.
So today we'll follow and propagate what Dr. Sethi has taught at the concepts of sinus surgery. See, this is on the left side. If I look at the endonasal anatomy at a glimpse, see this, when I push my endoscope inside the nasal cavity, this medial structure is the nasal septum. Laterally, the most prominent structure anteriorly is the inferior turbinate, and underneath the turbinate is a meatus in the lateral nasal wall. Inside the nasal cavity for sinus surgeon, the most important area is the lateral nasal wall. Madam, lateral nasal wall. So here in the lateral nasal wall, there are lots of prominences and depressions which are very important as far as the sinus surgeons are concerned. So underneath this turbinate is the meatus. This is inferior meatus. And see, the inferior meatus is a hollow structure except one important anatomy in the roof of the inferior meatus. Can you see this?
Yes.
Moving. This is the
Absolutely.
wall of Hessner through which the nasolacrimal duct is opening into the meatus. And the location is, look at carefully, this location is around 1 centimeter from the head of the anterior head of the middle turbinate, 1 centimeter from here, and the topmost part of the inferior meatus, the superior most part of the inferior meatus, where this nasolacrimal duct opens. This is
Yes.
very important to the people, relevant to the people, gosh, to the people who are still doing inferior meatal enterostomies to prevent damage to the nasolacrimal duct. So, if you are doing inferior meatal enterostomy, for us it is obsolete. But still, if you are doing, never ever try to go high up, never ever try to go too anteriorly, go little behind and inferiorly without damaging the nasolacrimal ducts. That's the only important structure in this region of the inferior meatus. Then as you go behind, if I go behind straight, the most important thing where we go is the choana. See, this is the choana. That's the choana. Here's some polypoidal lesion inside this. In the choana, the most important structure is the Eustachian tube, the Eustachian tube torus and the orifice anterior to it. And behind the torus, this is nasopharyngeal musculature, and behind that, this lateral recess, which is going laterally behind the Eustachian tube,
No,
is the
this
fossa
in the
Rosenmuller.
nasopharynx now. That's the
That is
nasopharynx.
ending towards the parapharyngeal space. So that is the Eustachian tube and the surrounding anatomy in the nasopharynx. When
Satish,
it come out, yes, boss.
have you ever come across an aberrant internal carotid artery that presents in the nasopharynx?
Yes, many a times. I remember 4 or 5 times, and once in nasopharynx, but in oropharynx many a times. Many a time, and that's a very important, relevant, question from Dr. Sethi. We have to be very cautious about it. As the parapharyngeal carotid artery, and when the carotid, the common carotid gives off internal carotid, it is not uncommon to see the loops and kinking and so many bands, abnormal curvature of the carotid artery before ascending towards the skull base, towards the carotid foramen in the temporal bone. But the peculiar thing about that is, as it is given off in the parapharyngeal space, close to its origin, the kinking and loop are very common. That means in the lower parapharyngeal space, that means lateral to the tonsil. So while doing tonsillectomy, while doing oropharyngeal, procedures, we have to be very careful where the carotid artery mostly is aberrant, could be very, very close to the tonsil. Sometimes even we have seen just medial to the pharyngeal mucosa. But as it ascends up towards the carotid foramen, it straightens up. So rarely you will find carotid artery in the midline or aberrant in the nasopharyngeal parapharyngeal space, in the upper parapharyngeal space. So almost always it is the lower parapharyngeal space where you can anticipate an abnormal kinking, looping carotid artery, but not in the upper parapharyngeal space. That's very important, and we have to be careful. We should always follow the, if you are doing any major procedure, the contrast scan, particularly contrast MRI or CT angiogram, which can tell you exactly the course and relationship of the carotid artery to prevent damage. More than that, sometimes you may find, transmitted pulsation, which can warn you if it is too superficial underneath the mucosa or bulging anywhere in the pharyngeal cavity. So, coming back from the nasopharynx, there are so many, depressions and elevations. So, the most important area for the sinus surgeon coming to is this middle meatus region. You can see there are lots of prominences and depression. If I come from the medial wall, lateral wall, anterior to posterior, the most important and the first prominence is the nasolacrimal duct, the prominence of the nasolacrimal duct. I will open up and show you later. Then after this is a very important, anatomy, which is a mobile structure. See this, the only mobile structure in the entire lateral nasal wall, posterior to anterior, is the uncinate process, which is a very, very important anatomy for the sinus surgeon. And this corresponds to one of the initial steps in the sinus surgery, where you need to remove this uncinate process to look further laterally and up. So this uncinate is a very, very important anatomy, and this inserts above, most likely to the lamina papyracea, and sometimes even medially. If the agar is too big, it can be pushed medially to insert on the turbinate or even at the skull base. So you should be very thorough at your CT scan to know the upper insertion of the uncinate. But most likely it is, following, it merges with the medial wall of the Aganegi and follows the lateral turn of the Aganegi to insert on the lamina papyracea. Then it follows inferiorly and follows behind. See this, the horizontal part of the uncinate, which goes beyond posteriorly for variable distance to end either into the inferior turbinate or to the perpendicular plate of the palatine bone. So that's how the uncinate is. Behind the uncinate, the next prominent structure is one of the most prominent anterior ethmoidal cell, that is bulla ethmoidalis. And between the uncinate and the bulla is a two-dimensional space that is known as hiatus semilunaris. We call it hiatus semilunaris superioris. This is a two-dimensional space which opens laterally into a three-dimensional space. This is three-dimensional space that is in fundibulum, into which laterally opens the maxillary sinus ostium. So you will
Satish,
never
just a
find
minor correction. Satish,
Yeah.
just a minor correction. I think it's hiatus semilunaris inferioris.
inferioris, you call it inferioris.
Yes.
Maybe we call this space between the turbinate and the bulla to be the hiatus semilunaris inferioris. So maybe we can
Yeah, just
correct
a-
this. As the boss is always correct, this could be, if you call it inferioris, we will call it inferioris. So this is hiatus semilunaris and the infundibulum into which the ostium opens. If you find any sort of opening in the lateral nasal wall in the middle meatus here, looking like ostium, is never a natural ostium. That is always accessory ostium and fontanelle with no intervening bone, only two layers of mucosa on either side. So then going further behind, at this bulla we have heard, this bulla inserts on the lamina papyracea in the immediate lateral relationship, and we have to be very careful while dealing with this. While dealing with uncinate as well, and we take it as an advantage, this uncinate is in immediately lateral to is the medial orbital wall or the lamina papyracea. So while doing uncinectomy, you reach out to your lateral limit of the dissection, endonasal dissection, or the sinus corridor immediately after this removal of the upper part of the uncinate. I'll show you when we remove the upper part of the uncinate how close we are to the orbit. Sometimes we are very, very close. You have to be very, very careful to prevent an accidental entry into the orbit. Now, behind the bulla, this is, see this, medial to this. There's a very, very important anatomy in the nose lying in the sagittal plane. This is middle turbinate, and this is the first part of the middle turbinate. Middle turbinate has various components, various parts, and the first part is lying in the sagittal plane all the way. So this is very important. This first part insert anteriorly onto this frontonasal process, and as we go behind, it inserts onto the cribriform plate at the junction of medial and lateral lamella. So this is the first part of the middle turbinate. And this space between the middle turbinate and the bulla, as like what Professor Sethi said, is the hiatus semilunaris superioris. This bulla is an important anatomy. And see, Dr. Sethi described in his technique, as he exploited this, relationship, what God has given us, this anatomy, this bulla goes up to insert on the skull base. And what he propagated in the sinus surgery to help sinus surgeons preventing damage to the anterior ethmoidal artery as intact bulla technique for the frontal recess work. I will show you exactly what he has taught us. The intact bulla technique means as this bulla extends to the skull base, anterior ethmoidal artery courses behind that attachment. That's a very important information which he exploited and included in his sinus surgery technique, which helps surgeons to dissociate the fear of damaging the anterior ethmoidal artery while doing the frontal sinus work. So most of the time, this bulla extends to the skull base, and if you follow it and work anterior to its attachment, the anterior ethmoidal artery is automatically away from it. I can see the Jhansi ki Rani Madhuri, Dr. Madhuri on the screen.
Hello,
Good
Dr.
morning,
Satish,
madam.
the king of all. Good morning. Good morning. Happy to be here. Yes,
Thank
yes,
you.
yes.
So
Nice
of you.
to be here. Thank you very much. Thank you.
Thank you. So we have just started, madam. I am discussing only the endonasal anatomy. So far,
Okay.
what we
Satish,
see.
Satish,
Yes, boss.
I'd like to introduce Dr. Tebin Wong. from South Korea who has joined us. Is here.
Welcome, sir.
Nice to meet you online, Dr. Satish. I'm looking at your marvelous work.
Thank you.
Looking forward to learning a lot and discussing.
Thank you so much, sir. We would be.
You know, Satish,
obliged to
he's
have
very
your
impressed. Satish is very impressed that the dissection is being done in Jaipur and being transmitted from Mumbai to Singapore, and there is absolutely no lag. It's the reception here is incredible, beautiful. He's very impressed.
Credit goes to one and only Dr. Sethi.
No. It's your IT people and yourself.
I am his disciple in the
I am
way.
simply a moderator.
Whatever he orders, it is executed. That's it.
Thank you.
Thank you, sir, for being with us. So, further on, adding on to the anatomy, what we see. So, this is bulla. This is first part of the middle turbinate. And this middle turbinate is a very, very important structure. And its three-dimensional structure adds on to the stability of this structure. This is a very, very important structure for the endonasal surgeon. And if the middle turbinate is unstable, it can give problems post-sinus surgery. So we have to be very careful to, respect this middle turbinate. This middle turbinate has three parts. The first part we have already seen. The second part, see behind the bulla. It turns laterally here to insert on the lamina papyracea and known as basal lamella or the ground lamella. So this space between the bulla and the middle turbinate is called retrobullar recess. Sometimes it is prominent. If the bulla is atrophic, this is more prominent. If the bulla is hypertrophic, it is less prominent, sometimes even fused with the bulla. So this is retrobullar recess, and this is the second part of the middle turbinate, basal lamella. And this is a very important anatomy. Physiologically also it is very important, as all sinuses which are anterior to this basal lamella drain anterior to it, and all sinuses which are situated behind the basal lamella drain behind it, like post-ethmoid and sphenoid sinus in the sphenoethmoidal recess. So this is a very, very important anatomy, and physiologically also it is very important. See, this science of sinus surgery developed on the basis of the work, the phenomenal work what Maser Klinger and Professor Stamberger did in 70s. And that led to this, understanding of this concept and accepted worldwide. You open up the natural ostium of the sinuses. You don't need to go and work anything inside the sinuses for the inflammatory disease to establish the ventilation and drainage. That's it. You need to establish the ventilation and drainage and allow the sinuses to come back to their normal physiology once you establish all this. So this is ground lamella. All sinuses anterior to it drain anterior to the ground lamella, like the frontal sinus, anterioethmoids, maxillary, and the post-ethmoid and sphenoid drain behind into the sphenoethmoidal recess. So this is middle turbinate. Now this was the second part. The third part of the middle turbinate, again you see, this is lying in the axial plane and going far behind, even up to the roof of the nasopharynx. So the turbinate has three parts in the sagittal plane, coronal plane, and the axial plane. And if you respect and don't damage it, it adds on to its stability. Is very important in the current scenario, wherein the main part of one of the important part of the treatment of chronic rhinosinusitis post surgery is to deliver topical steroids into the depth of the sinuses where actually the inflamed mucosa is. And if this turbinate is floppy, if it happens to block the ethmoidal axis, then that purpose is defeated. So we have to respect this middle turbinate, and there are many maneuvers I will show you later which can be done to help this middle turbinate remain stabilized. So this is all about the basic anatomy in this region. Our sinus surgery, like what Professor Sethi has taught us, begins with the maxillary sinus work, begins with the uncinectomy. And as we have seen, the anatomy of the uncinate we have discussed. This is the upper part of the vertical part of the uncinate, and there's the horizontal part of the uncinate. In the beginning, once this concept was stabilized, this uncinate process people would remove using a sickle knife from its attachment from the lateral nasal wall. We can still do it. But the problem is, doing this way, we reach the medial wall of the orbit very close to, particularly when the, maxillary sinus is hypoplastic, the orbit is very prominent. You can get an accidental entry into the orbit very early in the course, and that is something, disheartening for the surgeon. So what Dr. Sethi has propagated, see, look at my instruments. What I'm using is a reverse biting forceps. Just introduce your forceps, open it up, engage in the hiatus semilunaris, turn it little down. This is a very important step, to turn it down. Turn it down so that you stay away from the nasolacrimal, system, and advance it. Bite through, advance it until you reach the hard bone. If you come across the hard bone, you need to stop. Because if you come across the hard bone and bite through, you can bite through the nasolacrimal system, and that's a disaster. See what I've opened. So this step is known as infundibulotomy. What I've opened is this three-dimensional space that is infundibulum, into which the maxillary sinus os opens. So this step is known as infundibulotomy, as I have uncovered the infundibulum and see laterally, curve section, is the maxillary sinus ostium opening into it. That's a very, very important anatomy, and we should not be confused at all with the accessory ostium from the natural ostium. So natural ostium is well hidden and opening into the infundibulum. So 40. What I can do, see this lower part of the uncinate, I can fracture it. Gently using my ball probe, I can fracture it. I can use a through biting. I can use a micro debrider and create a middle meatal antrostomy. See this? Using my shaver, using my micro debrider, I can block. So I can create a middle meatal antrostomy in no time. So this middle meatal antrostomy is, this is the last part of the uncinate, the part of the uncinate which I have removed. This is middle meatal antrostomy. How is the picture there, sir? Is that clear?
Excellent. Excellent, Satish.
Okay. So the first step I have carried out is, or what I'm carrying out, is the middle meatal antrostomy.
Oh. There seems to be a fungal
Give me a
bone in there.
wash. Give me a wash.
Allergic fungal sinusitis, Satish.
It looks like some pathology inside.
Yes. So the important part here is that the natural ostium is always obliquely placed and the accessory ostium is vertically placed. So that's another point.
I
Because
remember Dr. Ashim Desai's presentation once about the failures in sinus surgery. And I remember in one of the conferences, he emphasized for almost 10 minutes on the importance of this natural ostium, accessory ostium, how the recirculation phenomena, takes place if you don't communicate the natural ostium and all that. So this is very, very important to learn this art. See the maxillary sinus, which looks like having some fungal disease, really fungal disease. Looks like. Can you see?
Yes, absolutely.
Dr. Satish?
Yes, madam.
Yesterday I was at a station where students were working. I could see, can you highlight the area where to create the space in middle meatus by pressing the middle turbinate? They were pressing at the vertical attachment, anteriormost attachment, which is slightly dangerous. Can you tell everybody how to do that?
Space in the middle meatus.
Yes. How to press it
that's a very
medially, middle
important
turbinate.
point. Madam has brought, very, very important point. See, I told you in the beginning, this middle turbinate is attached superiorly in the anterior part to this frontonasal process, and in the posterior part superiorly, it is attached to the cribriform plate at the junction of medial and lateral lamella. Sometimes you have a paradoxical turbinate, and sometimes you need to acquire more space. So what you do generally, what we do in our practice, the micro fracturing the middle turbinate. And this should not be done too high to give a fracture at the level of the cribriform plate and a CSF leak. This should be done gently lower down at the level of the ground lamella here, See this, what I've given, micro fractures. And then, keep some Maracel or something in the nasal cavity to keep this turbinate medialized. See this, this is more medialized now to keep it along the nasal septum. So the important point which madam has brought to the notice is we should not be, very, very careless in manipulation of the middle turbinate. We have to be very, very respect to the middle turbinate. Rather, the thing which middle turbinate wants in the entire sinus surgery is the respect. So if you want to do any kind of such medialization, you have to be very, very careful doing it more and more inferiorly at the level of the ground lamella to keep the turbinate medialized, not superiorly. Now, coming to the middle meatal antrostomy. See, this is in my opinion, is a regular middle meatal antrostomy. The size of the middle antrostomy, the desired size is dictated by the pathology inside. If I have a huge pathology like this fungus, which requires more and more, topical steroid douching, more and more surveillance, bigger pathology like AFRS, AERD, I would always enlarge it and create a mega middle meatal antrostomy. So you can enlarge in various ways. See what I'm doing here. I can still enlarge the medial wall behind and flush with the posterior wall. See this?
Yes.
I can flush with the posterior wall. People call it type 2 kind of a middle meatal antrostomy. And this will allow more and more introduction of the topical steroid into the sinuses, a better visualization of the, the sinus from, even in your outpatient department, you can have a good visualization with a 0 degree. If you create a big antrostomy, the main reason is surveillance and introduction of more and more topical steroids. See this mega middle meatal antrostomy.
Yes.
Then
Satish, point out the region of the Sphenopalatine as you go behind.
Yes.
Yeah.
Very important point. What Ashish has raised is the level of the Sphenopalatine foramen and the artery which comes out of it. See this. This is very important once you flush posteriorly. See this? There are two important anatomy that you need to keep in mind to pick up the Sphenopalatine artery at this point. What I'm trying to show. See this? Sphenopalatine artery will, in the later part of the dissection, see, this is the posterior wall of the maxilla. Behind the posterior wall of the maxilla is the pterygopalatine fossa medially, here in the medial aspect. Yes,
Satish, Dr. Dunn would like to make a comment, Dr.
Yes, please, sir.
Sorry for bothering, but so you mentioned about the augmented approaches to the maxillary sinus, right?
Yes,
so
sir.
You've done the posterior enlargement. You can do the mega antrostomy inferiorly, but anteriorly you have the lacrimal duct, right? You have the lacrimal bone, so that's your limitations. So have you tried doing a translacrimal, like not the pre-lacrimal, but the translacrimal, just opening the lacrimal bone, removing the lacrimal bone, and you'll have, I think, a much more reach and reach into the maxillary sinus. Have you tried that before?
Yes. So once you have raised this important point, we do 4 kinds of procedures for this maxillary sinus work, for what you are trying to say. Number 1, this is mega middle meatal antrostomy. Number 2, what we can do is the lateral wall lateralization, pyriform aperture lateralization. I will show you how to do it. Very simple technique. And many a times, that comes when you have a enlarged inferior turbinate, hypertrophic inferior turbinate, and you really don't want to disturb the turbinate and do a turbinectomy or turbinoplasty. We do lateral wall lateralization or pyriform aperture lateralization. I will show you immediately. The third one is the pre-lacrimal approach for more lesions into the maxillary sinus. And what you can do, this is a nasolacrimal process. That's the only obstacle, major structure in this region are limiting us. So in that pre-lacrimal, we make the incision at the pyriform aperture and remove this bone anterior to the lacrimal, as well as if you want to remove some anterolateral part of the bone, go head on into the maxillary sinus, remove the pathology, come back and suture this, mucoperiosteum again. You just punch out the bone, go head on and suture this mucoperiosteum again. In the last week, I demonstrated one of that in the Nagpur, where we did an odontogenic cyst. So we marsupialized it with a pre-lacrimal approach and sutured it back. Another more extensive technique is the modified Dankers. What Danker, described from the sublabial. I'm going to show you the modified Dankers. In the modified Dankers, you remove the entire medial wall and part of the anterolateral wall, whatever you want. And you cut this nasolacrimal duct sharp close to the roof. In that, when we do pre-lacrimal, when we do this Danker is, when we need a long-term follow-up, surveillance, we do modified Dankers. Like for tumors, juvenile nasopharyngeal angiofibroma, inverted papillomas, and many other tumors where we need a long-term follow-up to look for the so-called recurrence. We do a Danker so that you can see without 0 degree in our OPD. With pre-lacrimal, once you close this, you cannot follow up. You have to see through the natural ostium again. Fourth is, you can, with this opening, if I have a disease somewhere far anterior and laterally in the maxillary sinus, I can come from the sublabial route here. I can make a sublabial antrostomy with a 4 mm trocar and cannula and push my debrider, red 40 debrider from the sublabial antrostomy, and with a 70-degree view from the inside, you can actually somersault your debrider blade anywhere in the maxillary sinus to have a 360-degree reach out. So that is another way, the fourth way. So if you want me to show you, like you have asked, about the lateral nasal wall lateralization, pyriform aperture lateralization knife, I can show you in a minute, and that's an amazing technique.
Sure. Professor Satish, I think you've summarized very clearly your algorithm, like your graduated approach to the augmented approach to the maxillary sinus. So I think in not a very big case or a tumor case, but a small like inflammatory cases indeed, when let's say like you have a fungal ball in the maxillary sinus, sometimes there's a residual fungal debris in the anterior part or in the alveolar recess. It's quite difficult, actually, quite cumbersome, and some nuances that you have even when you're doing a lot of irrigations. So I think you're demonstrating right now the lateral lateralization, or I call it just a translacrimal approach, where you just take out a little bit of the inferior portion of the nasal lacrimal duct bone, and then you just transpose, just move the lacrimal duct. And you have a very good approach. Just a simple adjunct when you're doing a common FES, I just wanted to
recommend
what
I'm going to show you is the pyriform aperture and the lateral wall lateralization, and when you can do it in your clinical practice. See, when you do septoplasty, sometimes you have a prominent lateral nasal wall, prominent inferior turbinate is still obliterating your nasal airway, nasal passage, and you don't really feel like doing turbinectomy to give more raw areas and all that. What you can simply add on, see what I'm doing? I made an incision on the lateral nasal wall just above the attachment of the inferior turbinate. Can you see? Are you watching carefully?
Yes, very well.
And see this bone. I will punch out this bone. See how much this lateral nasal wall I am going to lateralize in a minute. Yeah, slowly.
So you've engaged the punch on the pyriform aperture.
Yes. And see, I'm punching out this bone.
So you are punching out the inferior turbinate bone?
Not really. This is the bone. This is the maxillary bone, and this is the nasolacrimal duct. See this? This way, I'll uncover the medial inferior part of the nasolacrimal duct. See this bone I have removed? What I'm trying to do without giving any morbidity, see this?
So, Dr. Satish, how do you know that you're not going to injure the lacrimal duct?
So I have limited myself on the bone. See this bone?
Okay.
Nothing else than bone.
Fractures at the nasolacrimal duct now.
Yes.
Yeah, but
Satish, the only thing here is that just there you can see the anterior superior alveolar nerve. So, like, I think, this is a great approach. But just in that tissue, you could see it. There's the canal that's coming up now. I agree with you. The nasolacrimal apparatus is never a problem here. It's very robust. You can manipulate it, cut it. It doesn't make any difference. You know, the only thing you do if you cut the nasolacrimal duct is you lose your valve effect. You know, you can get some air regurgitation. But
I understand your concern, boss. Let me tell you.
But the minute you remove this bit of bone, you will, in a certain group of people, pick up the anterior superior alveolar nerve, and it does create a little bit of dysesthesia around the teeth.
Point that out, Satish. Can you point out the nerve?
Yeah. So what Professor Harvey has pointed out, a very important point, which I am coming to. See now, what I have done, I removed this lower part of the medial wall of the nasolacrimal duct. And now what I have achieved, debrider, I come to the inferior alveolar nerve point. See now what I have achieved, I am enlarging my anterostomy more anteriorly.
You're going to go through the nasolacrimal?
No, nasolacrimal is behind. I am enlarging my anterostomy. See now more anteriorly. See this? The level of anterostomy is shifted anteriorly.
Yes.
And this I will reposit back. I will reposit back. What you have achieved, see this? Your lateral nasal wall is shifted more laterally. Can you see?
Yes, very well. Very well.
Many a times you have a prominent turbinate. You actually don't need to do a turbinoplasty. Believe me. You can get away doing this. See my nasolacrimal duct is here anteriorly. I have not sacrificed. And see my anterostomy level now. It's shifted more anteriorly. Can you see?
So can you point out the nasolacrimal apparatus?
Yeah. So nasolacrimal apparatus is right here. This is your, duct above. See this? And this is the lower part of the nasolacrimal duct. This is nasolacrimal duct here. What I have done, I have shifted almost 7 to 8 millimeters anteriorly. And since I removed this bone, this has shifted my turbinate and the lateral wall more laterally. So now what happens?
Satish, just in case we might be a little bit more anterior than where we think, just dissect I think that might be a bit more pre-maxillary tissue in the front there. Can you just get a dissector and dissect anterior to the bone? Are you able to sort of? I might be wrong, but I look at that anatomy and I think.
Yes, your point is right. Let me come to what Professor Harvey is trying to say about the anterior superior alveolar nerve. See, we studied this anterior superior alveolar nerve not for this. We earlier studied this anterior superior alveolar nerve. I will show you the branches. When we do Dankers and raise this, mucoperiosteum from the anterolateral wall, there are multiple branches of the anterior superior alveolar nerve. 2 or 3 main branches this side and 1 main branch medially will come across. And you know what happens? By doing this, you sacrifice the branches of anterior superior alveolar nerve, and ultimately patient develops some numbness in the upper canines and upper premolar for time being. But you go through the papers, particularly from Rosenberg's paper, if you know, these anterior superior alveolar nerve has multiple interconnections. In about 8 to 12 weeks in his publication, he described, owing to the multiple branches, ultimately the reinnervation takes place, and ultimately there is no permanent deficit as far as the anterior superior alveolar innervation is concerned. So there are multiple, numerous interconnections between the branches. I will show you when I remove the anterolateral wall bone. So that's how the anterior.
I agree, Satish. I think that's you've read a really good point there that. A lot of the anatomy here, whether you transect the duct, transect the nerve, it's unlikely to cause significant long-term morbidity. But it's just one of those things for people to remember that when you do it, if people need to be on the lookout for the fact that you might give them a bit of numbness for a while, they may get a bit of air regurgitation when they blow their nose up through their lacrimal system. And these are all fine, but and I don't think they bother people long term, but it's
No, but
I
you
think
raise a
often
very valid
educating
point,
the patient about it,
Satish, just to be clear, can you put
Yeah.
a ball probe into the nasolacrimal duct so that we know
Yeah.
where exactly it is?
Yes.
Yeah.
Yes. See this. I
a
will
small
cut
ball
open and
probe.
show you. I will cut open and show you later. This is the bony nasolacrimal
I got
duct.
it. I got it. Yeah.
And this is the nasolacrimal duct per
Yes,
se.
yes. Got it.
So what we have achieved with this approach, see, this is amazing, game changing in our practice. I tell you what we have achieved. Now see the lateral, the nasal space on this side, and see the nasal space. What we have achieved, we have lateralized the nasal wall. Can you see?
Yes.
So
Yes.
whenever you have a prominent, very hypertrophic bony inferior turbinate, you can lateralize this for permanent, purpose, not the time being lateralization, and it opens up the nasal space like anything. Number one. Number two, when you have a prominent middle turbinate which can fall laterally and obliterate the middle meatal antrostomy, what we have achieved, we have shifted our middle meatal antrostomy far anteriorly for almost a centimeter. Can you see? Even a floppy turbinate cannot obliterate it.
Anteriorly and inferiorly, yeah.
Yes, can you notice?
Yeah.
Even a floppy, bigger turbinate cannot obliterate it. Number three, for far anterior and far lateral maxillary sinus disease, wherein even with your 70-degree and regular instrumentation, in the massive maxillary sinus disease extending far anteriorly and inferiorly, even with your curved instruments and 70-degree, you don't reach out. Now shifting this, see where my instrument is. I have shifted from here almost a centimeter anteriorly. Shifting this anteriorly has opened up the gateway with 70-degree. I can reach out the anterior wall so easily. Most importantly, we have not given any morbidity at all. We have done in hundreds and hundreds of the patient. It heals up. It doesn't leave any raw area. See this turbinate, mucosa will come up over here and heal it. And this is shifted anteriorly. So this is amazing. This 1 centimeter shift in the lateral wall opens up the gateway to the maxillary sinus like anything.
Anyway, beautiful demonstration, Satish. Maybe we can move on now with the rest of the dissection.
Okay.
Can you also drill out this area, Satish? Just remaining.
Yes, you can, but you can punch out because you want a chunk of bone removal.
Okay.
A chunk of bone comes out very easily with our chisel and hammer.
Okay.
Now, coming to the next part of the dissection, what we have done so far is removal of the lower part of the this uncinate process, which was extending far behind. I told you it ends up either in the inferior turbinate somewhere or to the perpendicular plate of the palatine bone. This is perpendicular plate of the palatine bone. Now, coming to the Ashish's question regarding the Sphenopalatine artery. See this. This is perpendicular plate of the palatine bone. And what I'm doing, I'm trying to elevate this mucoperiosteum of it. See, behind is the middle turbinate, the posterior attachment of the middle turbinate. And if I elevate this, we all know the Sphenopalatine artery comes off behind the posterior wall of the maxilla from the pterygopalatine fossa into the nasal cavity. So once I elevate this mucoperiosteum, this medially projecting bone, can you see this? That's a part of the perpendicular plate of the palatine bone, which is projecting far medially as a crista. See this? I'm removing this periosteum, and this will lot of nerve fibers be damaged. See this? Can you see this bone, prominent bone now? Much better. This is crista. That's a ethmoidal projection of this perpendicular plate of the palatine bone. And that is a very important anatomy to pick up as our sphenopalatine courses out of the foramen just behind it. Can you see the sphenopalatine artery?
Beautiful.
Yes, absolutely clear. Very nice.
See this. This is coming off as a continuation of internal maxillary. I will remove this mucosa. Elevate this. This is the posterior wall of the maxilla. That's a very important, anatomy when we do JNH.
Yeah.
It
is very well protected within the bone, so you cannot when you widen it.
It comes out. Yes. See, this is the perpendicular plate of the palatine bone. This is the the posterior wall of maxilla. Behind that in the anterior plane is the artery. And this is the projection of this perpendicular plate of the palatine bone. See this projection?
Yes,
And
yes.
just behind that, that's the sphenopalatine artery. And see, this is just above the attachment of the middle turbinate. That is just about the attachment of the middle turbinate. That's a peculiar location you can pick up. And in intractable epistaxis, you can punch out this part of the bone here and clip this vessel. Why I'm saying you can clip this vessel here as well. But sometime you may not find this vessel here in the trunk. This is sphenopalatine artery. Having come so medially, it is most often branched. So whenever we advocate the sphenopalatine artery clipping, you need to punch out this particular perpendicular plate of the palatine bone and clip this vessel as a main trunk as it comes out of the pterygopalatine foramen. Because here it gives numerous branches. For your information, this gives a very prominent branch which runs behind this middle turbinate on the anterior face of the sphenoid, behind the superior turbinate here to arborize the nasal septum. That is the nasal septal branch, which is the basis for the Haddad flap. The another branch it gives off to the middle turbinate here, which is the basis of the middle turbinate flap. And another very, very important branch it gives off inferiorly, goes to the inferior turbinate. That's a very important branch, which becomes the basis of the lateral nasal wall or the inferior turbinate flap. So there are three branches, main branches from the sphenopalatine, which it gives off. It goes in the turbinate. That's a very important point. Many a time we get cases after turbinectomy, with a sphenopalatine artery bleed. So this branch to the inferior turbinate enters the turbinate from 1 centimeter anterior to the posterior most edge of the turbinate, the inferior turbinate artery. And that is where you need to bipolarize it. Otherwise, it can be a source of, massive bleeding. So this is how the sphenopalatine artery is looked upon, and you see all the branches. Ashish, does it answer your question?
Satish, yes, thank you so much. Yeah.
So this is about the middle meatal antrostomy. There's piriform aperture and the lateral wall lateralization, sphenopalatine location. Now, coming next, the next step in the sinus surgery is the removal of the upper part of the uncinate. See this upper part. This is upper part. There are many ways to remove it. You can use a through biting. What I'm doing is, see my curved probe. I'm going behind and up, and fracturing it off the lateral wall. See what exactly I'm doing. This is a very, very important step. I can remove with a through biting. I can remove with my shaver. This is a very, very important part of the dissection when you remove the upper part. See this, what exactly where I am? That's the medial wall of the orbit. See
Lamina.
That is lamina preparation. The moment you remove the upper part of the uncinate, you are at the lateral limit of your sinonasal corridor. Immediately. See this? So this upper part of the uncinate removal is very, very important. And you have to be careful not to damage the orbit. So the best way is go behind, fracture it out anteriorly, and remove this uncinate either with a through biting or with the, with your shaver. Now I'll change here to the 70 degree for the regions what Professor Sethi has taught us.
Satish, Narayan has joined us, so let's welcome him. Hi, Narayan.
Hi, good morning, sir. How are you? Good morning, Madhuri, Ashish.
Hi, Narayan.
Hi, Satish. Hi, everyone.
Champion skull-based surgeon, Narayan Jaishankar. Amazing. Narayan, nice to have you.
Yeah, thank you, Satish, and thank you, everyone, for having me on the panel.
So,
Thank
Dr.
you. Now,
Satish,
see. Yes, madam.
no, so, Dr. Satish, there's a question. When
Yes,
you're
please.
using 0 degree, do you intentionally keep slightly the uppermost part of the uncinate intact before using the 70 degree, or you clear
yes.
it completely?
Yes. See, here I want to show you something. See, this is a very important anatomy, and this area has always been a challenge. And a lot of surgeons done a lot of work to improve the access to the frontal recess. PJ Wormold has shown the axillary flap technique, and he has done thousands and thousands procedure. What he does in this, that you make a flap like this based on the middle turbinate, attachment here. Raise this flap here and punch out this bone. Punch out this bone to have access to the frontal recess head on. Then we have phenomenal Richard Harvey being here with us, who had described the Caroline's window. Caroline's window is again a direct access to the frontal sinus. What he has done in that, make an inverted flap based inferiorly, elevate this mucosa and drill away with a 0 degree. With a 0 degree, this bone is forming the anterior wall of the frontal sinus. See this, the obstacle is this bone. In sinus surgery, once you come to the frontal sinus work, there are lots of challenges. And one of the biggest challenge is this beak. So Professor Richard Harvey described his own technique, that is Caroline window, in which he makes an inverted flap like this, raise it and drill away this bone to enter into the frontal sinus head on with a 0 degree. That's an amazing approach.
Okay.
One can do easily. You can watch Professor Richard Harvey's work, his videos, and you can learn very easily.
Yeah, Satish, we had a beautiful demonstration by Richard Harvey this morning on Caroline's window, where he demonstrated
I've seen his videos
modified Lateral
more than
approach.
50
Amazing.
times.
Brilliant technique.
And he has shown that Caroline window video, believe me, unedited. 42 minutes video I've seen almost 50 times. His, the diligence, how he creates the flap, inverted flap, and how he goes head on into the maxillary sinus, overcoming this biggest, obstacle to the frontal sinus, that is this beak. So there are many ways. Professor, PJ Wormal showed the axillary flap and remove this. Professor Richard Harvey in a much better way, the Caroline window, the straightforward. A lot of people have described, what happens, even if you do a reasonably good frontal sinus work, many a times your solution doesn't reach the frontal sinus, and again the frontal sinusitis. A revision, surgery to the frontal sinus is 100 times more challenging. So if you do a good opening to the frontal sinus, it is not only important intraoperatively, but for the post-operative irrigation solution to reach inside. A lot of people have described removal of this middle turbinate uncinate complex to give a wide access, and they call it a 0 degree visualization of the frontal sinus. The whole aim is to visualize the frontal sinus with a 0 degree so that your solution, your douching solution, reaches in the depth of the frontal sinus easily. And what I'm describing here with same with a 70 degree, which what Professor Sethi has taught us years and years. What I'm using here, see, I have removed the upper part of the uncinate, only the part of it is remaining, a little bit here. Now, what you see here, this is, bullite modalis above the aganegi. This uncinate joins the medial wall of the aganegi to insert on the lamina papyracea. Now, what we do here, upturn through biting, what we advocate here, we always teach on CT scans. See, I'm punching out, I'm opening this axilla more and more. Let me show you something which you can do in your practice very easily. Punching out this axilla and with a 70 degree, that's the advantage of 70 degree. Let me tell you why we use 70 degree for this purpose. 60 degree. See this? 70 degree. Why? What are the challenges with the frontal sinus surgery? There are lots of challenges. Number one, the fear of orbital injury. See, the medial wall of the orbit is here, and with your 70 degree, you can always keep an eye on the medial wall of the orbit so as not to transgress. Entry into the skull base. We all know this turbinate is attached above to the cribriform plate, and staying lateral to the turbinate keeps you safe. With 70 degree, you can keep your both lateral and medial limit in view. At the same time, I'm opening up the axilla and showing you the anterior limit, that is beak. See, this beak forms the floor as well as anterior wall of the maxillary sinus. See this beak, the thick beak, the thickest landmark in this region. The beak is the thickest landmark in this region. And see, if you follow your lateral and medial limit and stay in the midline at the level of the axilla, you feel the beak, follow the beak, where the beak ends has to be frontal sinus. Whatsoever the anatomy, abnormality, cellularity, whatever it is, if you follow the beak, you have to be in the maxillary frontal sinus, nowhere else. This is the simplest approach we have been following in a practice to deal with the frontal sinus. And then in this particular cadaver, this is the simplest of the anatomy to go into the frontal sinus. So 70 degree enables us the visualization. You see, the Professor Sethi's technique. You take care of all the three challenges. Orbit is always in your view. The skull base, you always have a turbinate in view, not to cross it medially. And you have this bulla intact to protect your anterior sphenoidal artery, because 98% of the time this bulla goes to the skull base. See, it is attached here to the skull base and anterior sphenoidal artery courses behind it. So with this 70 degree, keeping all the landmarks, medial, lateral, anteriorly B, and posteriorly this the bulla, you can enter into the frontal sinus without any fear, direct entry into it with a 70 degree without drilling or doing anything to the beak. So this is
Satish, can I just say that everything that you say there is exactly what I say when we do it as a Carolyn's window.
Yes,
it is just in reverse. So instead of the orbital wall, you are finding the periosteum. There's your lateral limit.
Yes.
I always talk about keeping the middle turbinate root on view. That is your medial limit. And then when you drill the bone out from the front, because you're coming from the outside, the front or the beak wall, which is what you are showing from the inside, you keep that intact until you've removed all the bone, and then you can enter the frontal recess. It is almost exactly the same, Satish.
Absolutely.
It's same principles, but just doing it from the outside. The only problem I would say, Satish, is that none of my Indian friends, do much Carolyn windows right now, because it's not what Sethi taught them. And it is so hard to get them to change. They said, but Sethi told me 20 years ago that I must do this. And I'm like, in India, it is possible for me to change their opinion.
But boss, we love your Caroline window approach like anything. We love it.
So, but that's done with a 0 degree, right, Richard? You don't need a 70 then. It's a head-on. It's with a 0.
Yeah, you can do with a 0 degree also. You need to drill out. See, to reach head-on into the frontal sinus, you need to drill out this obstacle.
No, hold on. For the Indian audience, we have to put on that Sethi just said something that's really important, is that all our concepts do slightly change when we have different instruments and things. I mean, I am so lucky in my career. I've had powered drills and things that, oh my gosh, yeah.
We didn't have anything at that time. So the only way to look at the frontal recess was with a 70 degree and punches.
So Dr. Satish,
Yes, madam.
question, how many times in your life surgical situation have you required the need of this navigation? How many times are you unable?
See, I've been using
Importance of
navigation for more than 17 years. But
Yes.
once in 3 to 6 months, believe me.
Okay. In
We
which
do
situation?
complex cases every day, but see, navigation is something which strengthens your anatomical localization. It is not a substitute to what your anatomical knowledge is. So in cases of distorted anatomy, in cases of revision surgeries, in cases of, with a lot of, surrounding skull base orbit descent, and you really want to be more, oriented, you can always use navigation. It's up to you. So
Okay.
it is something, it depends upon your expertise and your teaching. Sometimes it's an amazing teaching tool for junior colleagues. If your junior guy is operating and you have given navigation, you are more safe. You are more comfortable at your heart that he's not going to damage so easily. And more importantly, you can teach the CT scan better on the navigation than anything else.
Yeah.
So that
Let me-
navigation is useful. No doubt about it.
Okay.
Yes.
Satish, let me pose this question to Richard, because you can see everything with 0 degree so well. So when do you use navigation, Richard?
So Sethi asked me, when do we use navigation? I must say, I have the machine in the room and I load the scans on the machine because you get a nice 3D view and triplanar assessment, but I almost never register it. And it's because, yes, almost never registered. And I have it there just in case, but I can't remember the last time I actually even registered it now, because it's so landmark driven, my surgery. And a little bit, you have to be that way as a surgeon. The machine can never dictate things, because what happens if some sparks come out and some smoke comes from the machine and you can't get it running? I mean, are you going to cancel the operation? I mean, as a surgeon, you have to have landmarks, anatomical landmarks. That said, there's a couple of conditions in which it may be where it's an IGS-driven procedure. Like, there's the odd time where we may make an eyebrow incision and go directly to a posterior table fossa defect. And so I'm almost making like a trephine under IGS to target a lesion. And like neurosurgeons do, that then becomes an IGS-driven sort of approach. But in sinus surgery, almost never.
Okay.
Yes. So that's how the kind of expertise Professor Richard Harvey has. He might do navigation sometime, but probably I know he doesn't need it. His anatomical knowledge is so sound, and he can sense the abnormal anatomy so easily. So for a person like him, the navigation is not so required so often, but yes, it is useful to say.
Yeah, but you shouldn't use it as a crutch. Yeah, that's the thing, Satish. I think it's lovely to have there. I think if you're a junior surgeon starting off, great to have it in the room. It helps you reinforce your anatomy. But I see some people who almost develop a technique that relies on the IGS, and the way that they determine whether their ethmoid cavity is complete is running the IGS probe along the top of their surgical cavity, or their IGS registered shaver along the top of the cavity, and that's how they say it's done. They don't really find the ethmoid roof and all the partitions are removed and see the mucosa come off the turbinates onto the ethmoid roof, down onto the orbital wall. Like, if you can't see that anatomy at the end of the case, you're probably doing some sort of incomplete procedure, Mike? Yeah.
Yes.
Satish.
Thank you.
Satish, at this point, since you're at it, you've already talked about the localization of the frontal sinus, frontal recess. Can you also describe to everyone what is Draf type 1, 2, 3, and 4?
Okay, that's what I'm coming to. See, our obstacle to the frontal sinus is this beak. Now, what Draf has revolutionized, how to overcome this obstacle by drilling away this bone and open up a gateway, head-on entry into the frontal sinus. So what exactly are the Draf approaches? See, this beak forms the floor of the frontal sinus. Frontal sinus is right over here. This forms the floor as well as the anterior wall of the frontal sinus. The Draf is described drilling of this beak in various ways. So if I drill away this beak all the way anteriorly, keeping the outer skin as a lateral wall and the anterior skin as an anterior wall, and remove this beak, with a 0 degree, I have a head-on access to the frontal sinus like this. See, this beak is sometime over 2 centimeters thick. In this also, the beak is very, very thick, more than 1.5 centimeters thick. And imagine if I drill away this beak, I have a direct head-on access to the frontal sinus. So he defined the Draf into various categories. What I have done is Draf 1. I've already reached out to the frontal sinus ostium.
Yes.
Draf 2A, what he has defined is removal of this beak till the medial limit, keeping is a medial limit you are keeping as a inferior turbinate, and open up the ipsilateral frontal sinus floor completely. That's the floor of the frontal sinus. If you remove it, this will directly open into the nasal cavity. If you remove this till the turbinate or till the septum in the midline, removing the medial floor as well, this is Draf 2B. And if you carry out the same on both sides with removal of the intersinus septum and upper part of the septum to give it a common cavity, which what Lothrop described 100 years ago as an open approach, is modified endoscopic Lothrops to give a bilateral frontal sinus marsupialization into the nasal cavity. That is Draf 3. And now there are lots of modifications which we have been using in our practice, particularly 5 modifications I always use in my practice. See this? Excellent camera. There are 5 modifications which I use in my practice of the Draf. The one is when you do the Draf 2B, still you have a restricted access to the lateral part of the frontal sinus. You have a restricted access. See, to the lateral aspect of the frontal sinus, ipsilateral. So what you can do a septotomy and come with a 70 degree to the most lateral aspect of the ipsilateral frontal sinus. That is known as modified hemilothrops. The regular Draf 2B, septotomy, and coming from the opposite side with a 70 degree with an angle to the most lateral aspect of the frontal sinus. We have done this, and you can reach out to the most lateral aspect. You know, earlier when the Draf was introduced or the sinus surgery was introduced, any pathology beyond the mid-pupillary line laterally was not accessible by the regular endoscopic approaches. Now there is no bar. You can reach out even to the pterion through the endoscopic technique with angle instrument, angle debrider, angle, extended approaches. So this modified Laterals is one of them. If you want to drain the opposite sinus through the same frontal recess without violating the opposite frontal recess, sometimes you don't want to reach to the virgin field, or there is some pathology which is, there is some scarring which is obstructing there, limiting your opposite frontal recess. So what you can do with this kind of a Draf on this side, you remove the intersinus septum as well, along with a septotomy that is modified subtotal Latrops. Got my point? So you can drain the opposite frontal sinus through the same side by removing the intersinus septum. That is modified subtotal Latrops. The third one, modification, is when you have a disease on the frontal recess in the frontal sinus one side, surgeon has gone earlier and given a lot of scarring, knee osteogenesis, and some orbital entry, fat prolapse, and ruined that area completely. And going back into the same field may invite more complications. So in that scenario, what you can do, leaving that ruined frontal recess, go to the opposite virgin side. Go to the opposite virgin side, do a Draf 2B, and remove the intersinus septum to drain the frontal sinus to the opposite side. That is modified mini Latrops. We do sometimes.
Yeah.
The fourth one is a modified central Latrops, when you have a pathology in the central with both frontal recesses normal. This is sometime for the tumors, this is sometime for the CSF leaks, and for other regions. So you don't need to drill out the frontal recesses on either side to violate, and just remove the upper part of the septum and drill away the intersinus septum, and the central part of the frontal sinus is giving, we call it as a modified central Latrops. And fifth is an orbital transposition. I will show you once I do a Draf, and we have a laterally loculated pathology in the frontal sinus. Lateralized loculated mucocele, pyocele, which is not communicating to the frontal recess. In that situation, either you go external, but the external will not re-establish the normal physiology to the frontal recess. The only answer, the best answer in our opinion, is to do a Draf 2B and orbital transposition. I will show you after do the Draf 2B. You remove the medial and the superior wall of the orbit, the bone, and push the orbit laterally and inferiorly, keeping the periorbita intact, and you can reach out even to the pterion. So these are 5 modifications to the Draf we do in our practice, endoscopic. We do in our practice, and I will show them all once I do the Draf. So this is the the regular sinusotomy, and there are various modifications of the Draf which you can inculcate in your practice to optimize the frontal sinus surgery results. So 5 modifications of the Draf, and those are very, very important. Now coming back to the the sinus part, what we have left, what we have done is frontal sinusotomy. Now see what I show you here. This is the bulla ethmodalis. This is a aganage, the small one. And see what is there. This is suprabular cell. Can you see the bulla going to the skull base below?
Yes.
See, this bulla is reaching to the skull base below my instrument. See that?
Yes.
That is frontal sinus. And what is this suprabular cell? And if I remove this, you open up the suprabular cell. That's a very, very important anatomy for the regions I tell you. See, you can see all this on your CT scan earlier to plan your surgery. Got a 0.5 mm CT scan on DICOM and seen all, all planes and 3D, and you can get. Now see what you have opened up. This is the frontal sinus anteriorly. Can you see the scalloping inside? And this is your suprabular cell and the suprabular recess.
Right.
The shallow suprabular recess. Sometimes this recess is very deep to give a supraorbital extensive pneumatization.
Yeah.
This is orbit. This is orbit, and this cell, if it is pneumatizing above the orbit, the roof of the orbit, that is the frontal bone forming the roof of the orbit, that is supraorbital pneumatization, that is extension of this suprabular recess. And see the bone which is separating. See, anteriormost is frontal sinus, immediately caudal and lateral to that is supraorbital recess and pneumatization. And this party wall, if you have sometime we have seen, we have a bigger supraorbital cell than the frontal sinus itself. And we can break this party wall. See this? 60.
Yeah.
We can remove this party wall to widen the frontal recess, frontal sinus. Can you see this?
Yes.
We can remove this party wall completely, sometimes needed whenever the supraorbital is the obstacle, or limiting the ventilation and drainage of the frontal sinus. So what you can do is remove this party wall. See this, the supraorbital and the frontal sinus much better now.
Yes.
So this
Satish,
supraorbital pneumatization, yes.
supraorbital pneumatization or extension can cause the anterior ethmoidal artery to become mesenteric,
Yes,
rather than being in the bone.
That's a very important point Madam has raised. See this supraorbital pneumatization. First of all, pneumatization of the anterior ethmoidal skull base. More it is pneumatized, more the anterior ethmoidal artery is going to be prominent. The reason being, the anterior ethmoidal artery runs through the thickness of the anterior skull base. It comes out of the orbit, running in the thickness of the skull base, anterior ethmoidal skull base, and then enter into the cranial cavity. More the skull base is pneumatized, more the artery is going to be prominent, because more the bone is going to be thin. And this supraorbital particularly has a very important relationship with the anterior ethmoidal artery. The reason being, supraorbital recess, where it ends caudally, is the point where the anterior ethmoidal artery leaves the orbit. Bigger the supraorbital recess, more caudal is the anterior ethmoidal artery push. That's a very important relationship. I have seen the very, very big supraorbital recess and the anterior ethmoidal artery pushed far behind. So this is very important. See the supraorbital recess and frontal sinus. So there are various cellularities in this region which can compromise the frontal outflow drainage. From laterally, it is the supraorbital recess which narrows the frontal sinus outflow from laterally. Medially and anteriorly, far anteriorly is the intersinus pneumatization, intersinal septal pneumatization, intersinus septal cell, which if bigger, we have seen the bigger intersinus septal cell, then the much bigger than the frontal sinus itself, and that narrows the frontal sinus drainage outflow from medially. And again, you have to remove the party wall and widen the outflow. You see Dr. Sethi's presentation, I have seen many times on the frontal sinus, draining and treating all these variety of cellularity in this region. I've seen him doing Draf, doing supraorbital cell drainage and removing the party wall, removing the anterior cell, this intersinus septal cell party wall, suprabular cell. All these variations, you must be used to identifying such variations on the CT scan and then executing. Now, with this, yes, madam?
No, fine, perfectly fine.
Okay, so this is your medial wall of the orbit. This is your turbinate. This is your sinus, subfrontal sinus, supraorbital cell, supraorbital recess, suprabular cell, supraorbital recess, and this is going right over the frontal sinus. Now going behind. This is your bulla. This is called Sethi's technique, intact bulla, which I've been following for almost 20 years from now, what I learned from him. See, this bulla goes to the skull base. See yourself where it is going to. Can you?
Yes.
What I'm doing now, going behind the bulla,
You do it with 70 degree or 0 degree?
Yeah,
bulla?
70.
Okay.
I love this 70 degree. See, I tell you, I can make it 0 degree anytime. This is such a versatile endoscope. I can do the entire sinus surgery with this.
Yes,
you can make 30 degree, 70 degree, you can make even 120 degree, which you can't do with a 0 degree. So see this, I am going behind the bulla. See what I have done, simply fractured. I know my ethmoidal artery. See, this is the upper attachment of the bulla to the skull base, and ethmoidal artery is going to run behind this. What a protection. What a protection God has given us. And this man, Dr. Sethi, has picked up and involved as a landmark in this sinus surgery, which has revolutionized. See now, I have fractured the bulla, the upper attachment to the skull base, and I am now removing to show you. I have not seen the anterior ethmoidal artery yet. I have not bothered about the anterior ethmoidal artery yet because we have a very solid landmark to protect the anterior ethmoidal artery. See this upper attachment of the bulla? Can you see the attachment of the bulla where it is going to?
Yes.
See this now. After partial removal of the upper attachment. This upper attachment of the bulla is going to the skull base there. And can you see some vessel behind?
I think that's the anterior ethmoidal artery.
See how it is protecting. See, this is what Dr. Sethi has revolutionized my practice on this frontal recess earlier. Shattered the fear completely. As long as bulla is intact and reaching to the skull base, don't bother about the anterior ethmoidal artery. Reverse. Go behind, go anterior to the bulla and do anything, whatever you want to for the frontal recess. And see, when you do with a 70 degree added on, you're with 70 degree, when you work at the frontal sinus, your trajectory is far anteriorly directed. See this? And your ethmoidal artery is far behind and deeper right on the skull base. So when it comes to measurement, see, this is the you know, the end of the beak. From the end of the beak, if I'm working here for the frontal sinus, for anything here, drilling or here, the anterior ethmoidal artery is almost more than a centimeter behind. See this anatomy. The anterior ethmoidal artery is more than a centimeter behind. See what I'm doing now. I'm using my reverse blade, the so-called adenoid blade, which I always condemn for using for the adenoid because it is a rear-facing blade. And with the 70 degree, it becomes a front-facing because the first principle of microdebrider use is to keep the cutting edges in view. And see, with 70 degree, it becomes, you know, under your vision. See, I removed the upper attachment of the bulla. Could you see?
Yep.
Yes.
Yep.
Through cut. And see now your anterior ethmoidal artery is in your view. Can you see very clear or not?
Very well.
So what I want to further, you know, pass on what we learned from Professor Sethi is to understand this attachment of the bulla, follow this, keep it as a landmark, and shatter your fear of anterior ethmoidal artery while working in this region. That's an amazing gift he has given us, and we have always followed this technique to, you know, carry out the work more efficiently, fear-free, and this is what the anterior ethmoidal artery is. So now, in order, what we have seen, that is frontal sinus per se, the supraorbital cell, supraorbital recess, shallow one. At the caudal part of the supraorbital recess, this is what Madam had pointed out. Supraorbital recess importance. Once you see the supraorbital recess, immediate caudal relationship with the anterior ethmoidal artery. See now, and this is running in the mesentery. Can you see? There is no bone covering. This is running in the mesentery. You can see, and behind that now. See now the another anatomy. This is your, what is this? Ground lamella. Could you see this?
Yes, Satish.
This was the first part of the turbinate. That's the second part turning. And that's the attachment of the ground lamella going to the skull base. Can you see?
Yes, very nice.
So
Satish, can you show us how the artery enters from the orbit into the ethmoid cavity?
Yes, boss. Yes, boss. See now.
Yes, the entire course of the artery and also what you would do to prevent injury, and if there is an injury, how do you avoid that? I mean, what do you...
Okay, let me show you. First, what Professor Sethi has pointed out. See, I am removing this medial wall of the orbit to show you something. Removing this medial wall of the orbit just for the sake of demonstration to show you how this artery is coming out of the orbit. The course of the vessel, let me tell you the course of the vessel in detail. This is a branch of ophthalmic artery. I'll show you later in the dissection at the skull base. The ophthalmic artery origin from the carotid artery. The first subarachnoid branch of internal carotid artery, the retrograde branch is the ophthalmic artery with the major vessel to the eye. See now, I remove this bone medially, and can you see something? The fat anteriorly, and what is this? The medial rectus muscle underneath the fat. As I go behind, where my instrument is, see the muscle superiorly. Can you see here? Superior to it.
Yes.
It's superior oblique. At the confluence of superior oblique and medial rectus. See this?
Beautiful.
At the confluence of superior oblique and medial rectus, see some structure which is coming out. Can you see
Yes,
this vessel
very
coming
nice.
out of the orbit?
And you can see the canal as well.
See
You
the
can see the
canal.
canal.
This vessel originating in this orbit as a branch of anterior ethmoidal artery.
Mhm.
The first compartment is the orbit. Then it leaves the orbit here and run in the skull base towards the cranial cavity in this canal known as orbitocranial canal, along with a small branch nerve. That nerve is a branch of nasociliary nerve. See the thin nerve fiber underneath the vessel.
Yes, yes, very nice. You
Appreciate the
can see
thin
the
nerve
nerve.
fiber. That is
You
anterior
can see the nerve
ethmoidal
fibers.
nerve, which is a branch of nasociliary nerve, which is a branch of V1. And it lives in this canal. Here the bone is dehiscent because of the pneumatization of the this supraorbital cell. And then it enters the lateral lamella here to enter the cranial cavity. Now see the importance of understanding this anatomy. This nerve leaves the orbital cavity to enter the roof of the anterior ethmoidal skull base. The fears, why we are scared of this small vessel? This is a tiny vessel of less than a millimeter diameter, roughly 0.9 millimeter. We in our practice deal with much bigger vessels. The Sphenopalatine down there, the carotid artery there. Why we are scared of? We are not scared of the bleeding. We are scared of repercussions of injury to this vessel. What are those? Number one, look, understand the anatomy. This leaves the orbit here. During dissection, suppose this vessel is happen to get transected. Periosteum chota wala. During the dissection, if this vessel gets transected close to the exit from the orbit, suppose this vessel gets transected here with your instrument, whatever, and it happens to retract into the orbit, what can happen? We all know this orbit is a closed cavity all around with 7 bones forming the orbital walls, except the anterior wall, which is fibrotendinous. If this vessel retracts into the orbit and keeps on bleeding, in a minute's time, it can fix the eyeball with this extra accumulation. Minute's time, because the orbit cannot expand beyond a limit because it is surrounded by bony walls all around, except anteriorly, through which it can bulge to a certain extent. With extra accumulating blood, even a 5 ml extra blood can compress. Now it can lead to a disaster of visual loss. If not handled promptly and efficiently, can lead to a permanent visual loss. That's the biggest repercussion of this injury. Injury to this vessel at this exit, close to the exit from the orbit. So we have to be very careful on this side while working in the sinuses. Sometimes you have a massive disease, sometimes you have a polyp, fibrosis. You don't really identify the vessel, where exactly you are running. Never ever walk close to the orbital wall. In the middle of the course, even if the vessel is transected, vessel is injured, nothing is going to happen except little bit of the bleeding. If you have any surgicel, gel form, gauze, cotton, whatever, you just pack for a while, the vessel goes in spasm and nothing happens. If you have a suction bipolar, you can cauterize and get rid of. The second repercussion is where it enters the lateral lamella. See this. This turbinate, I told you, it attaches anteriorly to the lateral wall here, and posteriorly it goes up and insert. See this turbinate. See now this turbinate. This turbinate insert on the cribriform plate at the junction of this lateral lamella and the medial lamella. And this vessel, this perforates, this vessel enters the lateral lamella to enter the cranial cavity, the third compartment. The first was orbit, second is the compartment is the sinus roof, anterior ethmoidal cavity, and third is the cranial compartment. And here, this vessel enters after perforating it, and that region is the thinnest part of the entire skull base. Suppose you are working in this region and happen to injure the vessel. If I am using my shaver or anything, happen to injure this vessel quite medially, that force is good enough to damage the lateral lamella, because this is a very, very thin bone lined by the single layer of dura inside, and that's the lateral lamella. See, even the thinnest, force, a slightest force can injure the lateral lamella and you get a CSF leak. So the concern medially is the CSF leak, concern laterally is a retraction into the orbit and give an orbital hematoma. So the bottom line is, when you are walking in the roof, you are not able to identify the artery, massive disease. Best to work in the middle of the course from medial to lateral wall here. Even if you inject the vessel, you can control the bleeding, which is hardly any concern. That's the value of understanding this vessel. I will show you when I show you the Draf, how this vessel comes here. This vessel enters the cranial cavity in the olfactory fossa and come anteriorly. There it gives a branch to the fox cerebri, the anterior falcine artery, and comes back up in the nasal cavity again. See, in the nasal cavity, upper part of the nasal cavity, it comes back and it supplies the uppermost part of the nasal cavity, not on the lateral as well as the medial wall. This entire upper part of the nasal cavity is supplied by the branches of the anterior sphenoidal artery, and it arborizes the upper part of the septum, lateral nasal wall, and joins the Sphenopalatine to form a rich anastomosis with the Sphenopalatine branches, the septal branch of the Sphenopalatine. And here, our Professor Paul Casanova has exploited this anatomy and developed a new flap based on the anterior sphenoidal artery. We use in our practice quite often for certain indications. My prime, give me 0 degree. My prime indication for that flap is to cover the raw area after the Draf if you want to. And second is to close the septal perforation. We have 20 techniques to close the septal perforation, and this is one of the, simplest technique one can use, knife, to close the septal perforation. What you can do is, see this. This is your anterior part of the turbinate. The anterior sphenoidal artery comes out here. So make an incision just anterior to the head of the middle turbinate. Here, down, 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 down. And you can even take, because of the anastomosis with the Sphenopalatine, even the entire floor you can take. The second incision you can make a 1 centimeter behind the upper part of the turbinate, and then again a parallel incision. And this way you can take the entire floor like this completely. Completely you can take this entire floor, even the inferior meatus if you want to further know. This anterior incision you can extend to the posterior wall of the septal perforation. If I have a perforation 2 centimeter here, this anterior incision I will take to the posterior wall of the septal perforation. Then after elevating this flap, what you need to do is simply advance it anteriorly and suture. Amazing. You can close up to 2 and 2.5 centimeter perforation without any hitch with this flap. What you can do added on to this flap, on the opposite side, you can go to the floor and raise a 4 flap to, cover from the opposite side. And so 1 flap from above, 1 flap on below, and you can cover the septal perforation easily any point of time. This is the gift from Paul Casanova, Professor Paul Casanova, who had developed this flap based on the anterior sphenoidal artery. So the anterior sphenoidal artery, after leaving from here, comes into the, after the intracranial course, comes back again in the nasal cavity. And from here, it goes, after supplying this, it goes off outside the nose at the dorsum of the nose. At the dorsum of the nose, at the junction of the nasal bone and the upper lateral cartilage, it comes out of the dorsum, and here it gives the external sphenoidal artery to end right till the tip of the nose. So this is amazing, course of this vessel we need to understand, and this can be used for various purposes. Yes, boss.
Yeah, amazing. I'm sure you could keep talking for a week, Satish. You're amazing. The voice just goes on and on. It's amazing. But Satish, can you show people where Aldo Stam's S point is? Because like as a practical thing, I think we go looking for bleeds, but when they're from the anterior sphenoidal artery, it's amazing in my career how accurate Aldo was with the S point.
Yes.
Can you show them? Do you know what I mean by that? Maybe it's not. Are you familiar with the S point?
Yeah. Can you elaborate a bit, please?
Yeah. So Aldo's S point is, if you look up between the septum and the middle turbinate. Yeah, just there. In this area here, as you described it, the anterior sphenoidal has all those branches that come down onto the septum. As you described, we utilize that supply for the anterior sphenoidal artery flap. But this is where you will see telangiectasia. And I can see Dharambir nodding his head because he acknowledges that the anterior sphenoidal artery, we come from this area. and Aldo called it the S point. I actually just clicked to me that it's the stam point, but but I call it the S point. It is the place to look for
in epistaxis.
In ethmoidal epistaxis. Yeah, and it's often exactly like you see down low in the septum. It's just a little tiny cholangiotatic vessel or a little vascular lesion. Just really important. And while you're talking about anterosmoidal artery anatomy, it's a good one to talk. Now, just last one of all, you said there's 20 ways to close the septal perforation. And if that was a list of preference for me, there 1 to 17 is the anterosmoidal artery flap. And then the bottom three are other things.
Yes, actually, 2 years ago, Aldo gave a very nice talk on this platform, SARC. I think it was SARC 2020, I think. And I might still have the recording of that. So I will post it. It was on the anterior ethmoidal. Very nice presentation.
Super. And Professor Aldo Stem was supposed to join today. He had consented. He has always been kind enough. But he's on outing today, and where his internet even is not working. So he texts me in the morning that he is unable to join because of the, he's out of from his house in the hilly area, and the internet is not working there. Otherwise, he would love to join. He has always been, teaching us by various means in our webinars several times, and each and every point, what he emphasizes is a take-home message. Thank you very much, Professor Harvey, for bringing up this important S point.
And he also told me that he invited you to South America in next year, I believe.
Yeah. Thanks to him for inviting me.
Dr. Satish, good morning.
Yes, boss.
Wonderful.
Good morning, boss.
Morning. Just please put some point on the axillary flap and axillectomy, because it is now at this level.
He mentioned that.
Axillary flap, I mentioned, boss. That's what's propagated by the legendary Professor P.J. Wormold initially. And the advantage was that in the initial period, you raise the axillary flap, punch out this axilla, and you can reach out the frontal sinus even with the 30-degree. Now in the era of 70-degree, we don't feel like doing axillary flap, but there is no harm in it, and you can cover the raw area with the flap itself. So it's a very good technique what Professor Wormold has propagated, and he has always shown this, and this is very, very fascinating as well.
Sethi didn't go enough to Australia. He kept coming to India. That's why.
Now, coming further, what we have done so far is the maxillary sinus, the frontal sinus, anterior ethmoidal skull base, anterior ethmoidal artery, the medial wall of the orbit. Now, the rest of the sinuses are behind this ground lamella. See, so far what dissection we have done, all these sinuses drain anterior to the ground lamella. Now the rest of the sinuses drain behind the ground lamella, and the most important being is the sphenoid and the post-ethmoid sinuses. Now, if you remember what Mosher has mentioned 100 years ago, ethmoidectomy is the easiest way to kill a patient. Means what he meant? Post-ethmoidectomy. While doing post-ethmoidectomy, if you are not oriented, you can do a disaster. The reason being, while doing post-ethmoidectomy, if you are not oriented about entry into the sphenoid sinus, you can go on and damage the optic nerve, carotid artery, or anything if you are not oriented. So post-ethmoidectomy is one thing where you have to be 100 times careful. And what we follow, our technique, which I am going to share with you, while doing post-ethmoidectomy, we have to be very much oriented for the beginning of the sphenoid sinus and then accomplish the post-ethmoidectomy completely. What I am going to do is straight. See this. This is ground lamella. I'll make an entry into the post-ethmoid into the ground lamella. So what level you can make an entry? Let me show you something. See this landmark. This landmark of orbital roof, we call it as a maxillary line. See this orbital roof level? This, believe me, is a life-saving landmark sometime for the reasons I will tell you. Now I enter into the ground lamella at this level. Only at this level. That is maxillary line. Medially at the junction of the first and the second part of the turbinate. And see, I keep going medially, removing this. See, now the post-sphenoids have been opened, but I don't intend to do the post-sphenoidectomy at this point, because one of the post-sphenoidal cell may go further beyond the sphenoid sinus, and if I'm carried away, I can damage even the optic nerve and carotid artery if I don't realize if I'm not oriented. So to stay 100% safer side, what we follow, just open up the ground lamella like this and stay medially. See now medially, now this is the nasal septum and this is the superior turbinate. Can you see very clear? Nasal septum and superior turbinate. See that I'm removing the lowermost part of the superior turbinate. Can you see something behind?
Yes, you can see just medially, you can see the sphenoid ostium.
Can you see something behind the sphenoid sinus ostium?
Yeah.
And see, this is cadaver, no disease, and you can see the ostium very clear. Sometime with the polyps around, you don't see clear. This anatomy very clear, the sphenoid sinus ostium very clear. So now what I have done, I am not intended to do the post-sphenoidectomy before. I want to see this landmark of sphenoid sinus ostium first, and this is my maxillary line. If there are a lot of polyposis, you are not able to see the maxillary sphenoid sinus, take the reference of the maxillary line and look for the sphenoid sinus close to the nasal septum, always not close to the superior turbinate. Flush to the nasal septum using section periosteum to enter into the sphenoid sinus, but never above the level of this maxillary line. Why I'm saving this as a life saving? This ostium is never along the floor. This is more close to the roof.
Yes.
If you are not oriented and if you don't take the reference of this maxillary line, and if you are going above, see, if I try to go and open the sphenoid sinus ostium above, I will be very soon breaching the planum and get a CSF leak and a disaster.
Yeah.
So when you look for the sphenoid sinus, two things to keep in mind. One, not to go above the level of the maxillary line, and second, go flush to the septum.
Yeah, hug the septum.
Flush to the septum, and once you have seen the sphenoid sinus ostium, now I will carry out my post-sphenoidectomy, staying anterior to it. Staying anterior to it means I can remove all these partitions, staying anterior to it without going deep to it, because in any given abnormal situation, whatsoever it is, in the extreme, in the rarest of the rarest situation, the optic nerve carotid artery cannot come anterior to the sphenoid ostium. Yeah. I will never go here. I will never go here deep and dissect anything. I will never cross this limit of the sphenoid ostium. If after entering into the post-sphenoid and see the sphenoid sinus ostium and don't cross this limit and accomplish the post-sphenoidectomy anterior to it, I can never damage the optic nerve carotid artery, whether there is NOD or not. Forget about the NOD. Don't look at the NOD. If you follow this technique, staying medial to it. Now, once I have done all the work and staying anterior to it, now I can enlarge the ostium. And see, there are many ways to enlarge it. I can enlarge using a punch, sphenoid punch, Stemberger punch, microdebrider, Kerrison punch, staying on the anterior wall and flush it till the lateral wall. See, the lateral limit of the post-sphenoid is orbit. See, the lateral limit of this widening of the sphenoid sinus is the lateral limit of the, the post-sphenoid. And see this, that is lateral wall. And I can here now, see this under vision. Yes. This is not the right tool. Yes, I can remove this party wall between the post-sphenoid. This is the party wall I can remove with the punch. In the live surgery, I would remove this with a punch. You can use the drill if it is too hard and widen the sphenoid sinus to the limits. Limits means medially till the nasal septum, laterally to the limit, superiorly flushing this septation between the post-sphenoid and the sphenoid, but not inferiorly. If I'm, going too inferiorly, I can damage the septal branch, which is coming, which is coming on the face of the sphenoid sinus. This is how it completes the full house sinus surgery. You can see full house sinus surgery means you have opened up all sinuses till limits. See the interior of the sphenoid sinus with a lot of prominences and depression. This is so important, and in our next part of this dissection to the skull base, I will show you all the importance of understanding these landmarks. In the midline, this is the sella. This is the sella. The below is the clival recess. And there are prominent, most important being, this is the paracellar carotid. The anterior band of the cavernous carotid artery, opticocarotid recess, the lateral one, the impression of the optic nerve, carotid artery, the anterior band of the cavernous carotid, paracellar carotid, and that is the paraclival recess. That the paraclival prominence of the, the vertical paraclival carotid artery. So the cavernous carotid at various courses, we will see each and every in very soon. So now I am removing this, floor of the bulla. Now this was all functional surgery where you have to preserve the mucosa to serve function. That's why we call it functional endoscopic sinus surgery. If you remove the mucosa, then it is not FESS, then it is MESS, mess. So always preserve the mucosa in a regular sinus surgery to preserve the mucociliary function. Yes.
So Satish, just to avoid the injury to the branch of sphenopalatine, if we have to go inferiorly in the floor of the sphenoid sinus, we can push the mucosa down, bare the bone, and then remove and take a bite.
Yes, that's a very important point, Madam, has emphasized. If you really want to, many times we have to widen the, remove the anterior wall. So what you can do is, see this mucoperiosteum contains the branch of the sphenopalatine. Can you see the branch? Can you see the branch running?
Yes, very clear.
Can you see the vessel itself?
Yes.
See the vessel itself in this mucosa, mucoperiosteum. So what she is emphasizing, elevate this mucoperiosteum, elevate this, and then you can punch out this bone to further widen the, the anterior wall of the maxillary sphenoid sinus like this. Okay.
Yes.
And
yes.
this is I will come to the flaps, then we'll discuss more about this. So this is something about the full house sinus surgery on this. Now, since the skull base requires a midline approach, so I have to, accomplish the sinus surgery on the other side. We have discussed a lot about the sinus surgery in detail on this side. So we can continue our discussion.
Show it with a 70 degree. Show the entire skull base once.
Yes.
70 degree. You can point out to the posterior ethmoidal artery, the region there.
Yes. That's a very important point. Ashish, the important thing is, like anterior ethmoidal artery, which runs through the anterior ethmoidal skull base, which is pretty thin. It makes the artery prominent. And if it is more cellular, more pneumatized, it makes the artery further prominent, like this in mesentery.
Yes.
Unlike this, the posterior ethmoidal artery runs through the thick posterior ethmoidal skull base. That is, you won't find the posterior ethmoidal artery as prominent as the anterior ethmoidal artery in your practice. See now the entire skull base, right from the posterior table of the frontal sinus up there, you see the ethmoidal skull base, posterior ethmoidal skull base, and the sphenoidal skull base, that is planum. That is planum here. So, what is the tentative location of the posterior ethmoidal artery if it is not prominent? See this. Let me show you. Let me elevate this mucosa. Can you see the optic now?
Yes.
That's the prominence of the carotid artery.
Yes.
See, this is carotid artery, so prominent. Many a times you will find the dehiscence of this bone over the carotid artery in up to 15-20% cases when the sinus is too pneumatized. That is carotid artery. See this bone, thin bone, very thin bone.
Yes.
Lateral opticocarotid recess. That is the optic nerve, the optic canal.
Yes.
And here, what is the level of the anterior ethmoidal artery, posterior ethmoidal artery? There are many ways people are relating to it. A lot of people relate the anterior ethmoidal artery and posterior ethmoidal. The posterior ethmoidal artery is 12 millimeter behind the anterior ethmoidal artery, but that is never constant. Sometimes there could be middle ethmoidal artery as well. So the constant location, in my opinion, the most constant location for the posterior ethmoidal artery is relation to the optic nerve. This is optic nerve. The posterior ethmoidal artery is 5 to 6 centimeter anterior to the optic nerve. That is the most constant location. Millimeters. Yeah. Millimeters you can think of. Now let me show you. See this. That is the posterior ethmoidal, lamina. Posterior ethmoidal lamina. That is the anterior ethmoidal artery. That is, I'm using 70 degree for your information. See that below is the level of the optic now. And removing this bone. All bone, just for the sake of demonstration how the post-sphenoidal artery is leaving and what level. See the optic now below here?
Yes.
Yes.
Very nice.
See few millimeters, and this is optic now, few millimeters anterior to it. Can you see the vessel?
Oh,
Yeah,
yes.
very clear.
Okay.
Yep.
So the most constant location for the post-sphenoidal artery is
To relate
few
it to the
millimeters anterior to the optic now. Can you see in the same canal?
Fantastic. Yeah.
Very clear now?
Very, very
Very clear.
Yeah.
This is
Oh.
almost always 5 to 6 millimeter anterior to the optic. Now that's the most constant location. Rather than taking the reference of anterior sphenoidal artery, the best reference one can think of for the post-sphenoidal vessels is this. And we coagulate these vessels in one of the skull-base approaches, transcribiform approaches, where the tumors above the cribiform you can deal with from below by means of internal craniotomy, and then you need to coagulate both these vessels, and that is advantage as compared to transcranial approach, as these vessels are the principal supply to most of those tumors sitting on the cribiform. So the location of these vessels understanding is very important. And one more thing I'll mention about the anterior post-sphenoidal artery. Like we mentioned about the anterior sphenoidal artery, if it retracts into the orbit to give orbital hematoma, can lead to a disaster of permanent visual loss. And there you can pick up by the sudden proptosis. There is a clinical indication when you're operating your assistant or you note a sudden proptosis, and you take the measures accordingly immediately. What happens with the post-sphenoidal artery? In the unfortunate incidents, if the post-sphenoidal artery happens to retract into the orbit, this is so posterior, even the proptosis will not happen. You will not even realize that what you have done. You have done a massive damage. The artery is retracted into the orbital apex, and the orbital apex being a narrow space, even the slightest accumulation of the blood can be good enough to compress on the optic nerve, which is in the close vicinity there as compared to the anterior sphenoidal artery. So without even giving proptosis, with a post-sphenoidal artery retraction and bleeding into the orbital, can lead to a permanent visual loss much faster, which is not even appreciable. By the time the surgeon realizes, the permanent visual loss happens to take place, and that is a disaster. So you have to be more careful about the post-sphenoidal artery. So Ashish, your question was valid, and we need to be careful about at the level of the post-sphenoidal artery.
Yes.
Okay.
Satish, extensive polyposis, we have to remove the ground lamella, it is damaged. Then how you manage the middle turbinate stabilize? How you stabilize the middle turbinate?
Yes. So middle turbinate lateralization, you have to prevent, One technique I have already told you, the microfracture. Another one, this anterior, widening of this maxillary sinus, that is lateralization of the floor. Third is bowdlerization. See this turbinate? With my shaver, I can make the opposing surface of the turbinate and septum raw and keep them in place with a Marocell pack for a day or two to invite adhesions to keep that in place. Fourth one is a partial turbinectomy. Fifth one is a suturing. You can take a suture through and through the septum and turbinate to keep in place. The suture should be inferior, not superior, to obliterate the olfactory space. So there are many ways to deal with that. That is not a challenge anymore. Now going to the central part of the skull base, I need to go. I need to go in the midline. I need to develop the midline approach. And for that, I need to accomplish the sinus surgery on the opposite side. And I will reverse. So I will really accomplish it fast. We can carry on with the questions. We can carry on with the expert comments. I will finish off in 5 minutes, and then we'll move on towards the skull base. So
you want to show the draft? You want to show the draft too?
Yeah,
I will see on that side.
You want me to show on that side only? Okay.
Yeah. Finish on that side.
Let me show you first. So in Draf is an amazing approach. What the says, what I'm doing is removing this. This is much easier in the live surgery to take care of this mucosa by means of cobblator. You can make a flap, like Professor Richard Harvey makes a flap for the Caroline window, like this kind of inverted flap he makes. So you can sacrifice, you can preserve this mucosa, you can line with the surrounding anything. Now in the era of irrigations, steroid irrigation, the chances of restenosis are less and less. So depending upon how you are used to, how you have developed your technique. You can take a call of, flap elevation, sacrifice, whatever, quickly. So I'm sacrificing to go quick. We have to show a lot of things. So I see what I'm doing is exposing this. What I'm exposing this beak and the uppermost part of the turbinate, septum. So right.
So Richard, where did the word Caroline come from? Is she the neighbor across your window?
I just asked him that yesterday.
Okay.
Yeah, we have fellows every year, and we like to name something after all the fellows. So
That's very kind and generous of you. Yeah.
Oh yes, must never be self-serving. So Carolyn was our fellow. She works now at Burlington and the University of Vermont. This is where Don Leopold worked before he passed away, and so she has taken over Don Leopold's job in Vermont. Okay. And she was a fellow, and he helped us produce some of the the work around it. Similar for Ritter's triangle, when it comes to the block of bone you drill out when you're coming in from outside, is a Ritter Sansoni. He is a fellow now, works Nashville, Tennessee.
Okay.
Ritter's triangle. Yeah, it was the triangle we're talking about before, and we showed in the lab. It's in it like book chapters, I guess. Yeah, because it was. Because it's like all those things. When you're teaching all the time, Dharambir, sometimes your students point out really important things to you. Like we described the outside-in Lothrop many years ago with David Chin, but sometimes defining exactly the bone you need to be drilling, it's not until the student says, "So you mean here?" And they talk about to him it looked like a triangle, and I was like, "Yeah, it absolutely does." And so that became Ritter's triangle.
Thank you.
Hello. So
yes.
Coming to the Draf. So Draf, I have uncovered this is the biggest the thing which you have to be careful in the Draf procedures is the skull base. See, this Draf surgery is done in the most, I would say, the safest region where there is the thickest one, and you need to drill away this bone with no important structures in the vicinity. The orbit is below, the skull base is far off there, the skull base is behind. So what we do, see, I'm raising this flap there. This is my turbinate, going behind to define my posterior limit where the skull base begins. See now?
So in every case, you identify the first olfactory neuron?
Yes. See now, the first anterior structure comes, that is laterally. Can you see this laterally?
Yes.
This is the foramen for the anterior ethmoidal branch of the anterior ethmoidal nerve and vessel. That is not first olfactory neuron, that laterally. Can you see laterally?
Yes.
Something going in. That is not first olfactory neuron.
Yes.
You have to come further medially. Medially, and then you see the first olfactory neuron, which is coming out, and that is our point of interest, defining our posterior limit. Can you see this opening into the skull base?
Yes.
Just medially. That is the first olfactory neuron. This is my beginning of the cribriform plate. And see, during Draf, I can remove all this bone efficiently without any fear, as long as I stay anterior to it. That is my posterior limit. So first thing to define is your landmark, preventing your skull base entry, that is posterior limit. Secondly, this is I'm going to do with a 0 degree, always with a 0 degree. Draf is always done with a 0 degree, head on. And there are various techniques. The traditional one, which I'm going to show you to define your frontal recess, follow the frontal recess, and then remove the entire floor. The other one, which is described by our own Professor Richard Harvey, is the outside-in technique. See, once you have seen your posterior limit, this is your frontal sinus, frontal recess. What it shows, what it does, go anterior to it, define your frontal sinus lumen first, and then go medially, anteriorly, and the frontal recess later on end. So that is a reverse technique, equally good, much faster in his hands particularly. That is outside-in technique. This is what Professor Richard Harvey described.
We used to call it the Formula One drilling.
Yes.
Richard Harvey.
What I am defining here, what I am describing here is the traditional one. inside out technique, wherein you can easily, that is simpler to understand for the junior colleagues. You have to define the limits first, your frontal recess, your lateral limit, and then you can go further. See what I'm doing? This is your frontonasal process.
Yeah.
Come karo, Pani. See, first of all, below the level of this axilla, I'm defining my frontonasal process to define my lateral limit. Now see my lateral limit. See the change in color.
Yeah.
That is
Yes,
outside the
yes.
skin. Can you see?
Yes, yes.
Yes.
That is outside skin. Now, following this lateral limit, I will go anteriorly. I am using this 15-degree stylus transnasal burr. I'm using 60,000 RPM at present. This is a coarse diamond burr which cuts like a butter. See this? This is not cutting burr. This is ultra safe. What I'm defining is I'm removing this beak, respecting my lateral limit. Can you see?
Yes.
Keep defining. See, believe me, whoever is doing sinus surgery, this is the simplest procedure you can add on in the safest region. Safest region means there is no critical structure anteriorly, except your skin. Your all around limit is the skin. My external, limit is the skin. The anterior limit is going to be skin. And I've seen Professor Sethi in Hyderabad demonstrating this entire, ipsilateral Draf in 12 minutes with the same blade.
Wow.
Why was he in a hurry to
Post-diamond.
catch the flight?
See this? Keep going anteriorly. You are pretty safe. Keep an eye on the color change. See the skin all the way?
Yes.
See the skin. See the skin. That is my limit. See, I am working with a 0 degree. See this?
Absolutely.
I am working with a 0 degree and see my entire frontal sinus. I am entering head on. Head on. In no time, see, I am drilling this obstacle. This is what Draf has given us a gift. Draf 2, this technique has enabled, handling the frontal sinus lesion more and more endoscopically. Now in this era, we have been drilling with all tumors of the frontal sinus, all CSF leaks, all tumors with endoscopic approach using these, trap techniques. See this? Keep
Yes.
going anteriorly until see this skin, which is reflecting anteriorly now. See
Right.
this skin
Yes.
coming anteriorly, that is your anterior limit. See this?
That's
Keep
right.
going, keep going. In no time you can accomplish this.
Wow. Well done.
This is with 0 degree. We are in frontal sinus per se. Now, having seen our posterior limit, wash. See, my posterior limit is here. See this? This is my
Yes.
first olfactory neuron here.
Yes.
Having seen this, I can come anteriorly, medially, till the intersinus septum. See this easily, without any fear of damaging the skull base.
Yeah.
This is how you can accomplish in no time. See, it's been less than 5 minutes. I have started and you can using this. Now my drill is 70,000.
Satish, can you also give us the indication for what is Draf 2 used for?
Pardon?
What is Draf 2 procedure used for? Which lesions?
For Draf 2 is very commonly used for many, cells into the frontal sinus, like sometimes a bigger type 3, type 4 cell, frontobular cell. Sometimes you have a massive disease, revision surgery, AERD. You need more extensive procedure, more, thorough irrigation post-op, more, surveillance later on the draft. So draft is very common in practice. I told you all the modifications that those are now also very common in my practice, I would say. See this, keep doing it. Professor Sethi, if you want to make any comment, if you do anything differently,
No, excellent, Satish. We are just watching you. Amazing.
this is what I learned from you only. Watching
Thank
you
you.
operate is
Thank
always
you.
a.
Thank you.
See this?
Richard would
See
have
the
had some
anterior of the
questions, but he
frontal
just
sinus with
stepped
0
down.
degree.
Yeah, beautiful. Beautiful.
nice.
See the entire interior of the front. Now, see, coming to the CSF leak, Narayan, I remember last time you made your comment regarding dealing with the CSF leak by the open approach. Remember?
That's right.
See, I know this is a complex approach for the beginners. See, you can see for CSF leak from anywhere, the technique is going to be same.
Yes.
Exposure, exposure, exposure.
Correct.
Good for cribiform, sphenoid sinus, anywhere the exposure. Now, suppose I have a leak from here. I have a leak from here.
Yeah.
What can be a better exposure than this? Tell me. I have a leak from here. I have a leak from here. I can further extend this. I have a leak from here. I can further. I told you several modifications. The beauty is you can do everything under vision the way you do at any other place at the skull base with same efficiency. If you want to further, if you're not well versed, suppose there is a lateral recess leak somewhere in the frontal sinus, you can take the help of, trephination to have an additional port for your instrumentation, your telescope, whatever. I can do fenestration from here. I will show if you want to. And then I'll have 2 ports of instrumentation. One from inside, one from outside. And you can manage anything. That is very important to deal with tumors, papillomas, so many things from inside. So for any CSF leak for last so many years, for frontal sinus, I have not done a single case with open approach. This Draf technique has opened up the gateway to deal with such complex situation so easily. See, this Draf didn't take 10 minutes. Believe me, if you do it properly with your good instrument, but it doesn't take more than 10-15 minutes, and you reach to the same exposure rather than doing an open approach, craniotomy and all that, which have their own disadvantages. This is pure endonasal. Nothing
So,
doing.
Satish,
And see,
Dr.
now I'm
Satish,
going more and more medially.
Ideally. So, Dr. Satish, I
Yes,
do
madam.
quite often this open osteoplastic technique for far located CSF leaks in the frontal sinus, because at times I am afraid because I may give so much raw area or bare bone in the nose, it may cause adhesions, fibrosis or osteitis later on. So how do you cover all this area once you are
See, I have already told you. See this flap, anterior sphenoidal artery flap. This elevates from here and apply over there in 1 minute. You can cover everything easily. Now coming to what you said about the osteoplastic flap. Osteoplastic is open approach. You make a bicoronal incision and remove the anterior wall of the frontal sinus.
No, not that. Only the eyebrow incision and lifting the inferiorly hinged.
Yes, there are many, trans-orbital approaches also. See the intersinus septum in the medial part. Can you?
Yes, we can see that.
Yeah, very, very clear.
Yeah. So coming to the madam's point, that is very important. Last, one of the webinars, we had an opportunity to interact with Professor Darlene Lube. Professor Sethi introduced to us, and that was a learning experience for us. And she has mastered trans-orbital approaches. So trans-orbital approaches not only to the skull base, to the orbital lesions, but for the frontal sinus as well. So coming to this is a simple Draf 2B. That's the posterior limit, where there is a posterior table. That's the beginning of the cribiform plate. You can see, and this is the first olfactory neuron. Can you see very clear?
Yes, very clear.
I can further add on to this, anteroposterior axis I will show this, and this is your intersinus septum. I will further drill this. Now, to add on to this axis, what other approaches can help? The other approaches, number one, this is trephination. Trephination is such a simple approach. You can make a trephine in the medial part of the floor of the, frontal sinus here, in the medial most part. See, this is your medial canthus. Your incision should not go more than half a centimeter lateral to the medial canthus, otherwise you will damage the supratrochlear pedicle. So you can make a horizontal incision. You can make a horizontal incision. See this, a very simple technique, and you get an additional port. Yes, additional port to the. This is the floor of the frontal sinus, and you get an additional port in the eyebrow. The incision is always underneath the eyebrow. You can elevate this. Drill देना बस वो the periosteum. कान वाली drill अगर रखिए. See this? Can you see the frontal sinus floor?
Yes.
See how easy it is. If I drill this, I'll be right into the frontal sinus, and then I'll have two ports. One from inside, one from outside. Quickly, give me. These are additional maneuvers with hardly any morbidity you can do in your practice if you are not very well versed with the extended frontal sinus approaches. Got my point? So this is one.
Got it.
The drill is being organized. So
okay. In the meantime, Satish, when can you also show us the landmarks for the septectomy, the superior septectomy, assuming you want to do a draft 3?
Yes. I will show you.
Yeah.
Sir, good morning, sir.
Now, yes.
Sir, can we make this definition even in the lateral portion also, lateral part also?
No, not really. You're not supposed to, because you know the landmarks here. The medial one is the supratrochlear pedicle, and 1 centimeter beyond is the supraorbital pedicle. These neurovascular bundles are important, and they are the important supply for the peritoneal flap as well. So we should avoid going lateral to it. Now see, another approach which Professor Darlene Lube will learn is the transorbital approach, what Madam is saying. In this transorbital approach, you make an incision few millimeters above the eyebrow. Can somebody hold it? Hold this. Tooth forceps. This is a versatile approach not only to the frontal sinus, to the skull base as well as to the orbital lesions. And elevate this in this plane. See this? Elevate in this plane, and you reach out direct to the floor of the frontal sinus. This is floor of the frontal sinus. Can you see here? That's the floor of the frontal sinus. That is floor medially, that is laterally. You can go anywhere you want to with this approach. You can deal with the CSF leak. See the bone?
Yes.
See the bone?
Yes.
That is the orbital roof, floor of the frontal sinus, and floor of the skull base as well. And now if I further elevate, see the orbital roof. Can you see?
Yes.
See, I can do add-on lateral orbitotomy, lateral approach. And this way, if I keep elevating, I will very soon laterally can reach to the superior orbital fissure. We can reach to the middle cranial fossa in no time. 1 centimeter behind the middle cranial fossa. So this way, these orbital approaches are very important. You can deal with all CSF leak or orbital lesions and all that. Drill. See this. This trephine. Frontal.
So the incision is on the lowest part of the eyebrow, just below the lowest part of the eyebrow, right?
Yes.
And half centimeter from the midline.
Yes. See now, if I go from inside, I have curved section. I have another port which I have developed from outside. It's a centimeter incision. You can close subcutaneous with hardly any scarring. See my another port instrument is coming.
Yes, beautiful.
So
Absolutely.
now I have two ports for the instrumentation to introduce anything in the frontal sinus from above as well as below.
Yeah.
Number two, I can push my endoscope also from here to look inside. Can you see my endoscope from above?
Okay.
See this endoscope from the outside opening.
Right.
And you can, even angled scope, you can see even the lateral most part of the frontal sinus. Can you see?
Yes.
Narayan, for any CSF leak coming from the most lateral aspect, I would still not go with any other transcranial approach in this era when we have such minimal invasive approaches without entering into the cranial cavity, without doing anything further to give morbidity. Are you not comfortable with this approach, with this definition?
Absolutely, Satish.
To
Absolutely.
reach out any, so many a time, see this is, below is the orbital roof. Many a time we have lesions, commonly inverted papillomas entering in this area. We can take the help of this definition to clear out undervision, drilling from above, from anywhere in any part of the bone to take, that is the orbital roof. So there are many extended approaches. So this, what we have done is the draft to give me further drilling. Anybody, any doubts or want to add on anything, please let me know.
I think it's a wonderful demonstration.
Thank you, Narayan. Now, I'm further completing my draft 2. More on drill debrider. Reverse that. See this, I will show you the first olfactory neuron, the level of the first olfactory neuron.
Yeah.
See the first olfactory neuron. Very clear.
Very clear.
This is the level of the first olfactory neuron here.
Yes.
See this? See the neuron coming out.
Correct.
See the neuron per se. Can you see?
Very well. Very well.
This, each neuron has millions of fibers. Each neuron has millions of fibers.
This is the beginning of the cribriform?
Yes. So do whatever you can staying anterior to it. See now, this is my limit. Can you see how much I have widened anteroposteriorly? Anteriorly is your skin. See this anteriorly, this is your skin.
Yeah.
You see? You can't go beyond that. So draft means you have to go to the limits. Posteriorly is your limit, that is skull base. Why I am saying so? There are times, still the osteoplastic flap is not obsolete for us, what madam had mentioned once.
Yes.
Osteoplastic flap means coming from above, open up the frontal sinus, remove all the mucosa, obliterate the drainage pathway, frontal drainage, and obliterate the frontal sinus after removal of the mucosa to prevent future sinusitis, frontal sinusitis. Now, what cases we do draft, what cases we do, osteoplastic. In osteoplastic, you need to remove each and every bit of mucosa. Got my point?
Yeah.
If you leave a smallest of the bit of mucosa, it is going to give mucocele later on. And that's a disaster, and then you have to revise it. It can get infected. So, we do osteoplastic flap only in those sinuses which are very small, where the mucosal removal is much easier than larger sinuses with huge scallopings, huge pneumatization, where removal of the each and every bit of mucosa from the each and every nook and corner is very difficult, and you are likely to leave behind. Drainage. Because you don't need to remove any mucosa, you just need to widen the opening. For smaller sinuses, osteoplastic flap, because you can always remove the mucosa easily and give a permanent cure. I hope it is very clear. So that is something, the osteoplastic flap is still in our practice for selected indications. Not only for the sinusitis, not only for the tumors, for CSF leaks and other indications as well. So less pneumatized sinuses, more efficiently you can do a osteoplastic and give a cure forever. More pneumatized, give internal drainage for the ventilation and drainage. Okay. Now, I told you about the modifications of the draft earlier. This is draft 2B. Now, what modifications we can give? See what I am doing? I am working toward the intersinus septum. Can you see what I have opened?
The opposite side.
Yes, yes.
Opposite side, give me section. Code section. So I can open up this intersinus septum completely and allow the opposite sinus to drain to this side. Can you see? Give brighter. See the mucosa?
Yeah.
I can remove this septum all the way completely. Just wanted to show you the modifications. Suppose you have to go far laterally in this same side. See the limitations. On the same side, you cannot go. Can you see?
Yeah.
If I do a septotomy here and come with a 70-degree far off laterally, you can address the lateral most pathology in the frontal sinus, that is modified hemilothops. If you add on this intersinus septotomy, see this. See the opposite sinus opened up?
Yes.
See this?
Yes, yes.
Yeah.
Now the opposite sinus will drain. I can remove this entire septum. Without addressing the opposite frontal recess, if the opposite sinus is drained through this is subtotal lathrop, modified subtotal. If I had a disease in the opposite side on this, with a lot of scarring, revision case, orbital entry previously, difficult to enter into the frontal recess, what I will do? I will not touch this. I will do the Draf to this on normal side, do intersinus septotomy. This is modified. It is very clear.
Yeah.
Far lateral pathologies. Now, for far laterally, loculated pathology in the frontal sinus, in the roof of the orbit, what you can do? See now.
Transposition.
See now.
You done this now with me, Satish?
Yes.
Yeah.
Can elevate till wherever you want to. See the periorbit I am elevating? Keeping the
transposition, right?
Orbital transposition. In live surgery, it is much easier. You can keep on it. See this? How much laterally you want to go, you can elevate this. Keep elevating this of the roof of the orbit and punch out, drill away this bone. You have more and more access to the lateral most part of the orbit. See this?
Yes.
Wonderful.
Now, if I remove this bone, see this?
Yep.
See my access? More and more advanced laterally. Can you see?
Yes, fabulous. Absolutely.
See now, I am able to see the most lateral part of the frontal sinus.
Yes.
Yes.
This is orbital transposition. Suppose simpler technique. See, with the same side, I am able to see far laterally. If you want to go in the roof of the orbit, you want to work, see this? This is roof of the orbit.
Yeah.
That is floor of the frontal sinus. And this is called orbital
Transposition.
See this, the lateral most extent. I can drill away this more bone. I can elevate more orbit, stiffen it. And see this, the most, I have reached out the most lateral part of the
Frontal, yeah.
Yes.
Satish, I must say that you make things look very easy. Okay, I've tried this.
It is.
The same thing I wanted to. Yes, that's the thing. I also
myself have tried this orbital transposition, and
it is magical in his hands.
Yeah, there were at times I felt that the instruments were clashing at times, no? In spite
Not
of
really.
creating all the space. But I think the way
Believe
you
me,
handle
this is very simple. Believe me, if I can do it, anybody can do it. Simple. I am not propagating anything which is complex. Simplest, having done so many, and then only I am propagating.
This is superb, very beautiful dissection.
What an entry into the roof of the orbit and frontal sinus. See this?
Yeah.
Or lateral part, just removed this medial wall, is staying superior to the anterior sphenoidal artery. See my anterior sphenoidal artery here?
Yes.
So remove the bone anterior to the anterior sphenoidal artery, superior medial wall of the orbit, floor of the frontal sinus. Keep removing I can still remove as much as I want. If I have to go for any pathology, the advantage of this approach is you ultimately allow the frontal sinus to drain normally. If you have a far localized pathology and you come with the open approach, anybody can say, I can do it easily with the open frontal sinus approach, but how will you drain inside? How will you allow it to drain inside the, into the nasal cavity? No way. So that's the only approach for such laterally localized lesion. I can remove. If you want to further marsupialize, you can cut away, coagulate the anterior artery and go further even. This is, see this, this is the trans-orbital access to the
Middle
skull
fossa.
base. The skull base is there behind. Tumors, meningiomas, CSF leaks, so many things you can address by this approach. See this, what a gateway it has opened. This is orbital transposition. I need to remove this more bone to go more laterally. See this? I can easily punch out or remove this bone and go far laterally. So these are various expanded approaches to the frontal sinus one can take and can involve use in your practice whenever you want to. Anybody, any doubts, please.
No, that was very, very beautifully demonstrated. Excellent.
See the orbit, we are going around the orbit everywhere. Keeping the orbit reserved. Ashish, any comment? Anything you want me to show further here in the draft?
Just the septectomy before you open the sinuses on the opposite side, so the landmarks are clear.
See the septotomy.
Yeah.
I can remove the septum further completely. Okay, the upper part of the nasal septum.
Yes, upper part of the nasal septum.
So in that, what you need to do is, you need to do the same draft to be on the opposite side. Okay?
Yeah.
Same draft to be on the opposite side. And nasal septum above the anterior to this. Anterior to what?
Anterior to the first olfactory neuron.
Yes. This elevate this mucosa and do this septotomy completely. Remove this part of the septum easily, staying anterior to it. Remove the intersinus septum. Remove this upper part of the septum and complete the draft to be on the opposite side, and this will be modified endoscopic Lothrops. That is draft 3. Okay?
Yeah.
So, in order to address all variety of frontal sinus lesions, we have variety of approaches in our basket.
Yes.
6, 7, 8 variety of approaches, and then you can take the help additionally with the trephination, with the trans-orbital approach, and many other approaches. I hope it is very clear.
Super. Thank you.
Brilliant, Satish. Absolutely. Crystal clear.
Crystal clear.
Yes. Thank you.
Know.
Yeah.
So,
very
going to the opposite side, so that we move on further to the skull base. We have a 10 o'clock. We have 1.5 hours for the further skull base work, which I am going to take you. So I have to be really quick for that. Now, in order to reach out there, I am completing the opposite side sinus surgery, because this side I had shown the lateral wall lateralization. So I will show the Denkers on the opposite side. See this? We have already discussed it in detail. That's the maxillary sinusotomy on the opposite side. So those who are doing endoscopic sinus surgery using all these extended approaches to the frontal sinus can handle any difficult situation coming in their practice to deal with frontal sinus in the simple manner. That is the, middle meatal enterostomy. Now, in order to reach out the frontal sinus, Professor Sethi.
Yes, I'm here, Satish.
We have done orbital transposition on the opposite side, if you had seen.
Yes, I was watching it downstairs. I went over to the dissection room.
That was orbital transposition to deal with the lateral most part of the frontal sinus. This is intersinus septum removal to drain the opposite sinus. So
That's
that
nice.
is, this is trephination to add on, and this is trans-orbital approach. All.
Great, great, great.
Now coming to the opposite side, now coming to one of the most important approach in our practice for the extended, work, and that proved to be, game changing in the era of mucormycosis. That is Denkers. If you remember how the mucor was dealt, easily doing Denkers to reach out to the far posterior lateral area. So this paramedian approach opens up a gateway to the entire paramedian skull base. Doing Denkers, you can reach out to the middle cranial fossa in 10 minutes. Right onto the middle cranial fossa, right onto the temporal bone in 10 minutes. So we need to understand the anatomy of this region in detail as well at this platform. So the obstacle is what? This medial wall. This medial wall is the obstacle, and the important structure in this medial wall is this what? Nasolacrimal duct. So in modified Denkers, what we do, we remove this medial wall and a part of the anterior lateral wall as much as you want to go far laterally, superiorly, posteriorly. So we have shown Denkers so many times. So quickly what I'm doing, making an incision. It is much easier in the live surgery when you use the cobblator than in the cadaver. See this? I don't have cobblator for the cadaver here. So, see, this is your lateral wall. See this? And this at the pyriform aperture, this is your anterolateral wall. Give me the divider. So I will uncover this bone completely and show you the landmarks till where and where you have to uncover. In lateral wall, besides this medial wall, which is formed by the maxilla, the another important structure is the inferior turbinate. This becomes a very important flap. I have not mentioned about the flap. Quickly, Hadad is the prime flap. We have seen the artery vessel here, and you can use the entire nasal septum for that. With the time constant, I am not showing. So you can use this entire flap, ipsilateral mucoperiosteum to, reconstruct the skull base. And these two guys, Hadad and Bassagestegay, revolutionized the endoscopic skull base surgery by, introducing this amazing vascularized flap, very, very robust, like PMMC for head and neck reconstruction. This is so robust for the skull base reconstruction based on a branch of Sphenopalatine we have seen. So you can ipsilateral Hadad, this mucoperiosteum you can take. Now, once they introduce, there are a lot of modifications now. You can take the floor along with, if you want, along with the nasal part. Now the Korean guys introduced double flap, entire lateral nasal wall, entire Hadad flap, entire floor based on two vessels. We have seen the three branches. One, the same, the nasoseptal artery. Another is the inferior turbinate branch posteriorly. So this entire double pedicle, double flap to reconstruct the entire skull base right from the frontal sinus till foramen magnum. And you can easily reconstruct. You can use a bilateral Hadad, Janus flap. You can use, palatal flap. You can use the oral, from the oral cavity, this entire palatal flap you can use based on the greater palatine. The greater palatine is here, coming from the sphenopalatine like here. So raise the entire palate based on one side artery, elevate this mucosa here, make a perforation in the floor of the palate and bring out the entire flap into the nasal cavity. And that big palatal flap, big, huge, can be taken to reconstruct the skull base if the Hadad is not available. So all these flaps are important if Hadad is not available because of the disease, because of the previous surgery, because the septum is destroyed for other reasons, whatever. You need to have in your basket variety of flaps, lateral wall, anteriorly based, posteriorly based, palatal flap, this flap, anterior sphenoidal artery flap. Then if all these are not available, you can bring in the flap from the outside. This because buccal mucosa flap based on the facial artery, you can introduce inside the nose and take it. You can raise the pericranial flap. See, that is the most sought after flap. Once the outside flap is needed to us, we can make a bicoronal incision. We can make a bicoronal incision like this, elevate the entire pericranial flap. After the Lothrops, you can make an entry into the wall of the frontal sinus and bring the entire pericranial inside the nasal cavity. You can use as long as you want to. You can double breast it right from the foramen magnum, flap coming there and coming back, double breasted. You can take a big pericranial. You can, after the infratemporal fossa dissection, you can bring temporoparietal flap. Dear Ashish uses temporoparietal flap so often for the pinna reconstruction. You can take this entire flap based on the superficial temporal artery. Then underneath the zygoma, you can bring into the infratemporal fossa, and the entire, even the 20 centimeter big flap can be introduced in the nasal cavity. Very thick, robust, reliable, based on the superficial temporal artery, the end branch of the terminal branch of the external carotid into the nasal cavity to reconstruct the skull base. So these flaps have opened up the, endoscopic skull base surgery. They revolutionized this technique of endoscopic skull base surgery. When this endoscopic skull base surgery was introduced, the small few millimeter size defect closure of the CSF leak used to be a major surgery. Now in this era, we make the defects in centimeters and centimeters to deal with the skull base tumors, to deal with the intracranial tumor, defects in centimeters, and then with the advancement in the technique, surgical technique, instrumentation, visualization, camera system, telescope, and these vascular flap enabled us to reconstruct and deal with any pathology more, confidently. So this is how the flaps
Satish, just to give you a perspective, Satish.
Yeah.
Just to give the delegates a perspective, before the advent of flaps, the CSF leak was stated to be something in the region of 35%. And after the advent of flaps, all these vascularized flaps, it dropped down to less than 3%. So
yes,
that's the
vascularized flap is the key. You are bringing in ready-made vascularity. Otherwise, you are using free tissue which can get necrose, which can invite infection. It takes time to develop vascularity, granulation. So chances of failure are very high. Now, in skull-based defects, bigger defects, you can't do without a vascularized flap. There's no way. Otherwise, you are inviting more problems than benefit. So the vascularized flaps have opened up the Pandora box. Now see this. This is the lateral wall I have raised. The same thing can be used as a flap. If I cut it from here, based on the turbinate right there, I can elevate the entire thing and apply on the skull. It's a very, very, I like this flap in the times when I don't have Haddad. Oh, we have cobbleter now? Super. I didn't know. Thanks to Petwa.
That same lateral nasal wall flap, you can either base it on the inferior turbinate artery, or you can even base it on the anterior ethmoid superiorly.
Yeah, so that can be anteriorly based, posteriorly based.
Yeah.
Narayan.
You
have raised a very important point. Recently, we had a good discussion. I did a 3-month-old child with a meningoencephalocele, huge. The location was right here anteriorly.
Foramen cecum.
So yes, very close to anterior to the upper attachment of the turbinate and the middle turbinate. In those situations, you don't need a posterior base flap. You can raise the anteriorly base. See this here, the branches of the facial artery supply the nasal wall. All this flap you can raise, keep based anterior superiorly, and you can apply over here. So for anterior defects of the cribiform, you can raise this anteriorly based flap and rotate in the close proximity. So that's why I mentioned there are variety of flaps for the variety of situation, and we must be well versed dealing with all these situations to, reconstruct. 20 kinds of flap we have in our box. See, now I am removing the lateral wall. Till what level? Staying 1 centimeter below the level of the axilla. Can you see?
Yes.
This entire thing, mucoperiosteum, I have elevated. That's the piriform aperture you can see. See this? Now I am elevating. See this? Oh, too much of glare. See, elevating this anterolateral wall. See this?
Yes, yes.
Yeah, we can see that.
And can you see the nerve filaments?
Absolutely. Yes, we can see that.
Neurovascular bundles?
Yes.
What Professor Richard Harvey mentioned. See this anterior superior alveolar now.
Yes.
See this, there are three major branches of this anterior superior alveolar nerve, and they have numerous interconnections. Numerous. We have studied a lot this to prevent a permanent, numbness to the upper canines and the premolars.
So how do you do that?
Pardon?
How to avoid that numbness?
You can't do. There are numerous interconnections, so ultimately it regenerates.
Okay.
Now see, I can raise this far laterally. What can be the limit? The limit is what? Limit is this. Can you see this?
Yes.
What is this? What is this?
Inferior orbital nerve.
Inferior orbital nerve.
So this is considered to be the limit. Now what? Professor Paul Casanova again did some revolutionary work. I will show you. If I want to go far laterally beyond this, even if I want to remove the entire maxillary lateral wall, I can transpose this now. So he described the technique of infraorbital nerve transposition, showing no boundaries to the lateral dissection. Amazing.
Okay.
I can transpose this and go far laterally, even wherever I want to. That is again courtesy Professor Paul Casanova, who described this infraorbital nerve transposition. This is a very important technique for far lateral lesions. See this? Medially, I remove this. Laterally, I remove this. My superior limit is 1 centimeter below. Inferiorly up to the floor. See this floor of the nose. And this another bone, inferior turbinate. That's a separate bone. This is inferior meatus. See this inferior meatus?
Yes.
And this is inferior turbinate, which is not a part of maxilla. That's a separate bone. Everything has to be removed in modified Denkers. And flush to the floor of the nose. See this?
Satish, apart from angiofibroma and inverted papilloma, what are other indications for this?
For many lesions of the pterygopalatine fossa, infratemporal fossa, temporal base, many times meningoencephalocele of the temporal lobe floor lesions, benign tumors in the floor of the temporal lobe, lesions in the, like mucotime. Many times I've seen that the lesions extending into the temporal lobe of the brain for all those.
Yes, this really
I will show you. And Narayan, I will show you once you complete the Denkers, in 2 minutes you reach the temporal floor.
No, I'm aware of that. The reason Satish, the reason I asked the question is because why doesn't a medial maxillectomy suffice for all of this?
See,
or just a limited Denkers. Why do you want to take out the whole wall?
Medial maxillectomy is, see the difference. Medial maxillary is remove the medial wall. You need more access because of more instrumentation. Agreed. So lateral, anterior lateral wall, you can remove according to the need.
Correct,
it's not hard and fast. You go right always to the infraorbital bundle or beyond.
I understand.
It all depends upon the need.
Correct.
See, now I'm removing this thin anterior bone. I can punch out this easily. And see the thick bone on the nasolacrimal duct behind. Narayan,
yes,
had I not sacrificed this mucoperiosteum on both sides, had I elevated this mucoperiosteum like I elevated on this side, the same thing I elevated this, keeping the nasolacrimal duct in view, I would remove this bone. See this?
Satish, I agree with this because, Satish, I agree with what you're saying. Even I do this part, but I don't take out too much of the anterolateral wall.
So who is saying to remove? Who's saying you to remove? It depends upon the need. I told you.
Exactly.
It's not always hard and fast to go to the infraorbital bundle.
Correct.
It's not. If you want to remove 5 millimeter, 10 millimeter, 1 centimeter, 2 according to the need.
The outer limit is what he's saying here.
Yeah, there is. So outer limit is variable.
Satish, the reason for asking this again is because there are people who feel that the nasal architecture, this dips down because of taking off the anterolateral wall.
Not really. See this, I tell you. This bone above, can you see the bone which is projecting from above?
Yeah.
See this bone, anterior bone. Come on. This bone, the part of the lateral wall, the piriform aperture which we have left above, that maintains the, see this bone?
Yes.
That maintains the,
facial contour.
Shape, number one. Number two, the ala which is 1 centimeter anterior. Always stay on the piriform aperture, not to go into the ala. See this ala?
Absolutely.
This is alar cartilage. If you violate that, then obviously you'll have a deformity.
That's exactly what
With
I wanted
regular
to bring out.
tankers, you will never have. We have done more than 1,000 now. If you go anterior, far anterior, damage anything, then only you'll have, deformity. Otherwise, never.
Satish,
Now,
that's exactly what I wanted you to point out.
that's a very important point. And then you have to, reinforce with the cartilage. That's not difficult to deal with. Just from here only you can reinforce with the cartilage. Now see, what are the landmarks to carry out this safely? First of all, I'll make an entry into the maxillary sinus head-on. See this. See, I made an entry into the maxillary sinus. Can you see, Narayan?
Yeah.
Now, keeping the lacrimal duct intact, having raised the flaps on both sides, keeping the lacrimal duct intact. See, that is there. Keeping that intact, staying anterior to it. This is pre-lacrimal approach. Can you see?
Yes.
You can do your work. Last time I demonstrated for a odontogenic cyst, the big odontogenic cyst, marsupialized completely inside the maxillary sinus. Did with the pre-lacrimal, like this, head on. See now, with pre-lacrimal, you reach out head on. Then when you raise both the flaps, suture both the flaps back. See that? Like this. Suture both the flaps back. The only advantage is you go very fast without cutting the nasolacrimal duct head on. But the disadvantage is your follow-up. The follow-up will be through the natural ostium only, not from here. Okay?
So,
In this dankers, what you have to do is you have to remove this wall completely and cut the nasolacrimal duct sharp, close to the orbital floor. So what I will do now, I will define my superior limit. Say this. Yes. In Narayan, laterally, it's up to you how much you want to go and you don't want to. Can you see I am going close to the roof?
Yes, we can see.
Under vision, define the roof. See this?
Yes, you have reached.
The burr I am using now, the more advanced version of the stylus, this is MR8. More robust.
Okay.
See this orbital floor? I will remove this bone, thin out, anterior to it. What is there behind? What is there?
The lacrimal apparatus.
Nasolacrimal.
Yes, nasolacrimal.
This burr is very good.
This is amazing, MR8.
Very good.
The people assisting Satish are also doing a fantastic job, because many a time you realize this when you yourself do these cases. When you keep drilling here, you cannot maintain a clear field because the assistant needs to understand how to keep the scope clean all the time. I think Satish's assistants are doing a fantastic job.
Yes, he's amazing.
Yeah. I've always observed, apart from Satish, what his assistant is doing.
Yes.
So this is not just a two-hand technique.
They perfectly match the steps of Satish.
Uni-nostril forehand approach.
And that's why Satish takes him everywhere.
So he's integral part of the team.
So Satish, coming back to the topic, I think this is exactly what we do for all angiofibromas as well as inverted papillomas, especially those arising from the medial wall.
Yes,
So
for anywhere you want to address the paramedian area head on.
Yeah, and it's got a superb access right till the infratemporal fossa.
I am removing this inferior turbinate. It has a bone inside. See now my access to the posterior wall of the maxilla. Can you?
Yes.
removing this mucosa to show you certain structures. Can you see the prominence of the infraorbital now there?
Yes, very beautifully seen.
So, this is the nasolacrimal duct, which is still in our, way. We have to do something to it to prevent obstacle. And this is the rest of the medial wall, which I can remove easily without any hurdle.
I'm sure you're going to show them where to cut the nasolacrimal duct to prevent stenosis. I'm sure you're going to do that.
Yes, I will show you. If it is overhanging below, the overhanging duct can get fibrous. So it should be cut flush to the floor. That's why keep an eye on the floor always. Drill. This is very important to focus for a minute to understand this. See this. Extra minute to this to prevent problems.
You're just exposing it up to the floor of the orbit, correct?
Absolutely, right to the floor. पकड़ो. You just see now how to cut this. This, your assistant holds and then you cut sharp in one go. That's it. See, right flush. Now see where the duct is. See the duct?
Yeah.
See the duct? So this is not overhanging, sharp cut, unlikely to get fibrous, and see now it is not coming in our way. Okay?
Yes,
okay.
sir.
For Ashish, who asked for the Sphenopalatine on the other side, the same side you can see section periosteum. बंद है. Quick.
Satish, just a question to you. Satish.
Yeah, please.
Just a question to you. You do so many cancers of the maxilla. Okay, squamous cell carcinomas of the maxilla.
Yes.
Have you ever felt tempted to do it endoscopically, or do you still prefer an open up?
Yeah. So first, reassess the extension attachment. MRI will tell you if it is going beyond the confines of maxilla to the orbit. If the orbit needs to be excentrated, you have to go open. If your anterior soft tissue is involved, this anterior soft tissue, the skin is involved, you have to go open. If the alveolus is involved, no matter, you can remove from inside as well. For all walls, you can remove inside from inside. Even the ethmoids involved, you can remove inside from inside. If it is going to the frontal bone per se, you have to go open. If it is involving the cribriform, you have to go combined. So there are indications depending upon the extensions, So outer skin involvement, orbital involvement is the contraindication for soul. Can you see, Ashish? The Sphenopalatine artery?
Yes, Satish, very well. Yeah.
See, this is the vessel itself. And see if I, Kerrison, give me the punch to show you. See this, showing you how it is coming out.
So it is more close to the roof of the posterior wall. Is it so? Because
no, it's not always like that, madam.
Because you said it is slightly above the posterior attachment.
I always emphasize during angiofibroma surgery to take the reference of the CT angiogram on your DICOM.
Okay.
You can measure in centimeters from the millimeter from the floor of the nasal cavity. How
Great.
high? Exactly 13 millimeter, 14 millimeter, 16, 17. How high it
Perfect.
is from the floor of CT angiogram is amazing.
Oh, great.
So the radiology is game changing. It makes your life so easy in terms of three-dimensional relationship, distances. See the sphenopalatine artery?
Yes.
Much better.
Very nice. Yes.
Very clear. Very clear.
Now, let me remove this posterior wall.
Artery. I was talking to Satish 2 days back, and I was just telling him how good his MRI reading is also. Better than a radiologist itself.
It cannot be better than radiology. The issue is,
it is.
There is a lack of coordination among radiologists and ENTs, surgeons. The reason is very obvious. You talk to the radiologist, our radiologist, what he said. Out of the 100 MRIs we do, rarely 5 MRIs we get from ENTs. Their bread and butter is neuro, onco, and other areas. So they never focus on what we need. Secondly, more and more radiologists are because we don't give them a feedback of the clinical situation, so they become more and more technicians. What they see, they write. They don't know what clinical acumen of that patient is. So you have to have an involvement in the radiologist to get the surgically relevant information. Information is of no use if it is not surgically relevant. And that's how you have to make a team. Otherwise, it is of no use. So what I extract, what I explain in our ENT forum is what's surgically relevant to us. See this. I'm removing this bone and there is an important artery underneath this at the medial end.
So this is the vertical part of palatine bone you have been removing?
Yes. See this? See the artery underneath, vertically down. Can you see?
Very nice.
Palatine vessel.
Yes.
Can you see this vessel per se?
Beautiful.
Yes.
This is greater palatine artery, this one. See this? Where it is coming from? Sphenopalatine here.
Sphenopalatine.
Very clear?
Very clear.
Clear or not?
Very clear.
Super
Very nicely seen.
This is the basis of the palatine flap. What you do in palatine flap? I told you, raise this mucosa from here. Raise the entire flap, palatine flap. Make a hole in this 1 centimeter hole. That will be reposited later on. The mucosa will be reposited. So to prevent palatal perforation.
Okay.
Bring that entire flap with the pedicle. Entire flap with the pedicle with this pedicle.
Very good.
See, the pivot of the pedicle would be here.
Okay.
And that entire flap, see how close is the skull base.
Such a big area.
Amazing flap when the sphenopalatine, this flap is not available, this Haddad flap. Even the, other flaps are not, inferior turbinate flaps are not available. If this vessel is there, you can always elevate. Got my point?
Yes.
Yep.
Now, in this, what I've done is removing the posterior wall of the maxillary sinus. See this? Behind the posterior wall of the maxillary sinus, what you see is the periorbita. And just behind the periorbita is the layer of vessels. Layer of vessels is what? This arcade of vessels formed by the internal maxillary. The sole vessel in this region, which gives numerous branches. Numerous named branches. See now, if I open up this space, the anterior most anatomy is vessels. And that's how in the endoscopic approach to the JNA, we take the advantage of it. How come? The JNA arises from behind this pterygoid process. Here is the pterygoid process. See this is the pterygoid process. Behind. So JNA arises from behind and pushes, as it grows, pushes the posterior wall of the maxilla anteriorly. In the same way, it pushes the vessels more anteriorly towards us. So when we do Denker, the first thing we come across are the vessels.
Yes.
And this is the principal vessel supplying the JNA. So that makes our life so easy. What's my point?
Yes.
See this bunch of, arcade of vessels. See this arising from this sphenopalatine. See this greater palatine. From here goes the posterior superior alveolar artery behind. See this posterior superior alveolar artery going behind. Then medially it gives the pharyngeal artery. It joins the median artery from behind. See this?
Yes.
That goes in the median foramen. That's the median artery that is going behind. See this? There are two foramina behind. Let me tell you to avoid any confusion. See, this vessel is going in the median canal. Can you see this big vessel?
Yes.
This vessel. Then there is a bone medial to it. And underneath the flap, can you see this another canal, very thin canal? See this canal with another vessel going into it. Can you see this?
Very thin branch. Yes.
This is palatovaginal canal. Give me Merosel to move. Medial, infero-medial to the median canal. That is palatovaginal canal, which is formed by the palatine bone and the vaginal process of sphenoid bone. Yes. See this.
Where is the pharyngeal nerve?
Yeah, that leads to pharyngeal nerve, which comes from the this is infraorbital nerve, which is going. I will show you. That forms the pterygopalatine ganglion, and from there the pharyngeal nerve, which passes into it, and a branch from the this artery. That is the branch from the vessel. See that? See this? That's the pharyngeal nerve and a branch from the vessel, both entering into it. See this?
Yes.
This is the foramen. And the median is immediately lateral to it.
Lateral.
See this vessel? The big median artery. See this? This vessel. This is going into the median. I will open up and show you much better. Clearly remove all periosteum and show you the canal. So this is how earlier people would do median nerectomy, which is almost now obsolete, as the posterior nasal nerectomy is much preferred, much focused, rather than violating the median now. The postganglionic fibers, what runs in the median now, ultimately run in the posterior nasal nerve to the nose.
Yes, you have to point out that posterior nasal nerve for us.
Yes. Yes, I will. Posterior nasal nerves are, severed when you elevate the flap. I showed you on the other side. These are various numerous filaments coming out of this perpendicular plate of the palatine bone. See these filaments?
Yes, yes, yes.
See these small nerve filaments?
Yes.
These are part of the posterior nasal nerve. So how to do posterior nasal nerectomy? In practice, simply you don't need to count the nerve fibers. Elevate this flap completely and coagulate this. Nerve fibers are going into the mucosa and ultimately it is coagulated.
Okay.
This is pharyngeal now, and this laterally just immediately the median canal. Can you see the median canal? This is median canal. Can you see very clear?
Very clearly.
Now, the other foramina. See, what is this bone? This is pterygoid bone.
Yes.
This bone is what? Pterygoid process.
Yes, medial and lateral.
Yeah, let me elevate this completely. See this? This is pterygoid process. Can you see?
Very beautiful.
And this is pterygopalatine fossa. This most medial part is the pterygopalatine fossa. This is pterygopalatine fossa, entire pterygopalatine fossa. Okay? Now, another anatomy which is behind. See this infraorbital now coming? See this infraorbital now? Let me follow this.
Yeah, as you dissect that, Satish, I just want to ask the panel and yourself, I'm pretty liberal in my dissection, often around the sphenopalatine foramen, in the nose, posterolateral nasal nerves. I don't see them as offering huge morbidity. But, Satish, over the years, I've done little flaps and things around this area, the dissection, and patients have presented with some numbness behind their teeth.
Yes, manipulation.
And I would say, even though we all acknowledge that incisive foramen edema and and the greater palatine nerve is usually the supply to the area behind the teeth, and that is common after septoplasty. You can occasionally, in my opinion, see it where I think it's because of our manipulation in this area. And that may be, Satish, I don't know what your feelings is, but I thought when that happened in a few patients that actually that area behind the teeth was not being supplied by the greater palatine, but by the posterolateral nasal nerves coming all the way forward, and their sensory branches going through the incisive in the sort of retrograde direction from what we anatomically think it should be. What do you think about that, Satish? That's just
Could be. I agree with you.
Do you have that, like doing skull base? You get someone who haven't touched the front of their nose, and they get a bit of numbness.
Yes, numbness we have almost always seen, but that is transient, never permanent.
Yes,
and manipulation, like any nerve you manipulate, the neuropraxia, numbness is always inevitable. Now see, what is this? What is this? This is the infraorbital now coming. One of the internal maxillary branch. Can you see the retrograde branch going there up?
Yes.
The infraorbital foramen. See, all these foramina, they carry a nerve branch and an arterial branch from the internal maxillary. Greater palatine artery, greater palatine nerve, lesser palatine artery, lesser palatine nerve, pharyngeal artery, pharyngeal nerve, median artery, median nerve, infraorbital artery, infraorbital nerve, posterior superior alveolar nerve, posterior superior alveolar vessels, all. So see this. This is a vessel which is ascending from the, from the internal maxillary into the infraorbital foramen. Can you see very clear along with the nerve, this artery?
Yes.
And this nerve is coming from where? See this. See, this is the V2. This is the maxillary nerve which continues as an infraorbital nerve. Can you see?
Yes.
What Casanova described, elevate this nerve from the canal completely right till the foramen anteriorly. The Paul Casanova flap, transposition of this nerve. And in that situation, he elevates this nerve completely out until in the infraorbital canal anteriorly. See, bring out of the canal, transpose the nerve, and you can remove this all bone lateral to it. So there is no limit laterally once you transpose this nerve. That is infraorbital nerve transposition. And this is now, see, I am opening up and making this very clear. This foramen rotundum through which this nerve is coming. See this. See this. I am uncovering the foramen rotundum.
Satish, can you point out the pterygoid wedge and both the processes and all?
Yes. See this. See the bone above the V2. That's what I am trying to show you. There's a bone above the V2. What is that?
Maxillary strut.
Maxillary strut. Yes. So, see, this is the V2. The V2 comes out of the floor of the middle canal fossa. See this? And this is the bone above. That is maxillary strut. See the maxillary strut now coming in picture.
Yes.
Can you see the maxillary strut now better?
Nicely.
Yes, very nicely. Separate from the...
Yeah. This is the V2 coming out of the foramen rotundum, and this is the maxillary strut. Now see this bone laterally. If I remove this periosteum, if I told you this V2 comes out of the floor of the middle canal fossa. Now if I drill this bone, where I am going to be?
Middle cranial fossa.
Right onto the temporal lobe, yes. See, this is my fastest gateway to the temporal lobe of the brain. You did remove the posterior wall, define your V2, medialize your V2, and give me a drill. The moment I go into it, I would be right into the middle canal fossa. In the mucor time, we did a lot of procedures addressing this. Many times we get a schwannomas from these nerves, and we can deal with them like this.
So how do you protect V2 while using the burr?
What do you?
How do you protect V2 while drilling there?
V2?
Yes. You put some instrument or?
Section perios. Kahan gaye ho? Section perios. I'll show you, madam.
Okay.
See this? This is section periosteum.
Okay. Very good.
Just I'm trying to show you quickly where I am.
Yes. Already opened.
Yeah.
Yes, thinned out. See now, this bone
Okay.
is, this is temporal floor section, the regular section. Patla. This is temporal floor, and you can have a huge access. Many a time we do remove schwannomas very commonly from here.
Okay.
This is the temporal floor. See this bone, once you drill it, you're right onto the temporal lobe of the brain. This is V2. Behind is going to be the V3. I will show you later. And between the V2 and V3, V1 and V2, there are lots of triangles in this region, which are important to understand the tumor grow through these spaces into the temporal. Like a very, you know, many times you must have seen the angiofibroma going into the temporal lobe, middle canal fossa. Where do they ascend from? They arise from the pterygoid process. Where do they ascend into the middle canal fossa? Between V1 and V2 and V2 and V3. Anteromedial and anterolateral triangles through which they, you know, ascend into the middle canal fossa. So how to remove them? Wherever they have gone into the fossa, you have to widen the opening, and the same way you have to pull them out. Nothing doing. It is always extradural. You have to follow from where it has entered into, widen the opening and pull it down from there. Same thing you have to do what the tumor has done. Got my point?
Satish, is it possible to identify the zygomatico temporal nerve?
Yes, I will show you. What exactly
that carries lacrimal fibers.
Yes, that is very important now. That is very important now. See, this now, this V2 coming out of here suspends a ganglion. See, I have done it. It suspends a ganglion there. And from this ganglion, there is a branch which ascends up and laterally into the zygomatic foramen. Up and laterally section. That is an important area. This nerve which carries the postganglionic fibers to the
lacrimal gland.
Lacrimal gland. This joins a branch coming from the V1 and then supply the lacrimal gland. That's why in some of the patients you get epiphora once you no lacrimal sensation once you transect this nerve. I don't see exactly the thin now since you asked late and I debrided everything. But you can see
that's fine.
This is the way the nerve ascends superolaterally.
Sir, can you show the foramen ovale, sir, from here? Foramen ovale and...
Yeah, foramen ovale is far behind. I will show you. So now I'm removing everything this to show you all the foramens here. Debrider. See this V2 you have seen coming out of the foramen rotundum? I'm removing all this soft tissue. Even V2.
Satish, one question. What happens if you damage the V2 during surgery, JNA or any other surgery?
Numbness to the anterior part of the cheek. Numbness.
Numbness.
To the upper teeth, anterior part of the cheek. See, this is foramen rotundum. Very clear. This is median canal. Very clear.
Very clear.
I hope it is very clear.
Very clear, Satish. Very.
This is temporal base. It is very clear.
Yes.
Yeah. You follow it more.
Yeah. And I'm removing. I have not done the sinus surgery on this side. I have to remove anyway. Now, the important relationship for the skull base coming up, because we need to know the relationship of all this to the critical area, and critical area is coming behind. Now, quickly, since the time is less, I'm just removing all these, paranasal cells, sinus cells on this side, as the sinus surgery was not done on this side.
Just one important distinct orbital
Quick to
apex.
reach
How
into
you
the
reach-
sphenoid, quick. Pardon?
how to reach the orbital apex?
Yeah, that's what
Yeah,
I think. He's going
I'm
to show
coming
that.
to the orbital apex. That's
Okay.
why.
He's going to show that.
Okay.
Yeah,
Okay.
I'm removing all this quickly. And
Yes.
this side sinus
Yes.
surgery was not done. And I will reorient you and go to the orbital apex. The key area for us, for ENT surgeon, skull base surgeon, that I will show you this 1 square inch area which terrifies the ENT surgeon.
Terrible.
Endoscopic surgeons. Because that 1 square inch area contains the optic nerve,
Everything.
carotid artery, all cranial nerves, orbital apex, 3rd, 4th, 5th, 6th, all branches. That is where
Yes.
I'm going to reach
1
out.
square inch. 1 square inch.
Yes. Any tumor extending to that area, it terrifies. See, widening the sphenoid. This is intersinus septum. I will remove quick. That is the opposite sphenoid we have already seen. Just to reorient you. See, in skull base surgery, pituitary surgery, sometimes we make a rescue flap. What is that? Flap based on the Sphenopalatine, the septal branch. We make an incision and elevate it little inferiorly, so that we preserve the inferior branch like this. We keep this elevated for a centimeter or so and push it down. You can take away your, rostrum and all. In case the Hadar flap is required, you can raise the Hadar flap. In case not required, you can deposit it back.
Okay. Okay.
That is rescue flap. Okay.
Okay.
Now, quick chisel hammer. See, this is the region where we were. This is your V2. I will reorient you what I am doing. This is V2. This is your Vidian canal. Okay.
Yes.
This is your pterygoid process. This is medial pterygoid plate. This is lateral pterygoid plate. This is infratemporal fossa. This is occupying the biggest muscle, that is lateral pterygoid. See this lateral pterygoid inserted on the lateral pterygoid plate.
Yes.
And this is forming, this roof is forming formed by the greater wing of the sphenoid. This is greater wing of the sphenoid. And
Okay.
this is below that, this is infratemporal fossa. See this?
Okay. Yes. Yes. Absolutely.
Below the temporal lobe. Temporal lobe is here, infratemporal fossa is here. Can you see the balcony?
Yes. Very nicely. Perfect.
And this is pterygoid process, this is sphenoid. So I'm quickly removing, just orienting you to this anatomy quickly in next half an hour.
Okay.
Quick.
Itna. You're a super fast surgeon.
Now we have to. We remove the rostrum. This is
Satish, you can maybe
intersinus septum.
Satish,
Yeah.
you can maybe describe the lateral sinus since you're already there.
Lateral recess.
Yeah, lateral recess. Yeah.
I don't think he has lateral recess.
No, he doesn't have, but you can describe where
So
it comes
he-
from.
yes.
See-
He wants to.
See this, I remove the intersinus septum. कहाँ गया वो? वाह. ला ना उसको. See now. This is your clival recess. This is your sella. Not very prominent. See this, this is the sella, clival recess. That's the carotid artery I showed you on the opposite side. Paraclival, I will show you all parts of the course of the carotid artery in the cavernous sinus. And we'll complete while do the skull base right from the origin till destination. See this, this is clival recess, this is paraclival prominence on both sides, having the vertical cavernous carotid artery. This is the cavernous carotid on this side, that is the anterior band of the cavernous. So carotid is how it has various curvature. It enters into the sphenoid bone here at the level of the foramen lacerum. Then it has a posterior vertical course, we call it paraclival. Then there is a posterior band. Then it has a horizontal course coming anterior. Then this is anterior band, which is paracellular. This is anterior band. Then it goes up clinoidal in relation to the clinoid process, and then it becomes subarachnoid. So this is both is anterior bands of the carotid artery. So see quickly, I am removing this bone because bone work takes time. So I am using all instruments to carry out this faster bone removal. Debrider. And then I will orient you. See this? This is V2. Remember? Hello?
Yes, yes.
Yeah,
This
we
is
are all here.
V1. This is median now. Okay?
Yes.
Median now running in the floor of the maxillary sinus is an amazing landmark for the foramen lacerum carotid artery.
Yes. How far is the foramen lacerum behind this median canal?
Almost a centimeter. I will show you. I will come to that, madam. I will exactly show you where the foramen lacerum, where the artery is ascending into it.
Okay,
All
great.
parts of the cavernous carotid I am going to show you soon.
Okay, great.
Chisel hammer. Chisel. See, this is median. This is median, which runs in the floor of the sphenoid there to the level of the foramen lacerum, where it is formed. It is formed by deep petrogel coming and the sympathetics from the carotid crossing the carotid artery here.
Okay.
The nerves coming from lateral to it, crossing here and then come anteriorly.
Okay.
Yeah, quick. Remove this bone. So median carries the fibers, the postganglionic fibers from facial nerve, GSPN.
GSPN, yes.
See, all bone I am removing with non-traditional instruments faster. That's it. See the course of the median nerve in the floor. See the course of the median nerve. No, divide the 40. First section block, quick and drill ready. I will drill away on this one side of the sphenoid bone on these prominences to uncover what is hidden there underneath. See the floor of the sphenoid? This is clival recess.
Yes, clearly see.
And see in the floor where the median nerve is running. This is median nerve. See this is running in the floor in this canal. Can you see?
Yes.
So median nerve is the best guide for foramen lacerum. For everybody. For every part of the carotid artery is a specific landmark to protect the carotid artery. Identify and protect the carotid artery. Every segment has a specific landmark. I will show you. For this foramen lacerum, median is the best landmark. For parapharyngeal course, I will show you how Eustachian tube protects the carotid artery like mother's lap. That is the best landmark all the way. For cavernous carotid, there are other landmarks, opticocarotic recesses, medial and lateral. section. See, I'm uncovering the median canal just for your information since you asked about the foramen lacerum. I guess.
In fact, Madhuri, if you see
the median canal I have drilled. Can you see the median now there further?
Yes, slight reflection.
Madhuri, if you drill the infratemporal fossa B approach, if you see how you're coming from lateral to medial, you generally have the middle meningeal, you have the V3,
yes.
Then you have the carotid, and then you have the eustachian tube. So you can actually correlate that over here as well.
So keep going anteriorly and then you follow
lateral
this.
To medial. Lateral to medial.
Okay.
I'm talking of lateral skull base approaches.
Okay.
Totally. Plus section, my dear, plus section. See the median canal in the floor. And that is going to be the, see the carotid artery behind. The carotid artery is there behind. See, there it is coming up from here. साइड लगा हुआ है इधर की तरफ हटाओ उसको मत काट उल्टा चला that's the foramen lacerum region. Now see where we were. Again, to reorient you, this is your V2. Okay.
Yes.
This is very important in our practice, in day-to-day practice, as many lesions enter this region, and how to understand this anatomy to carry out a safe work, to shatter your fear. Now what I'm doing is uncovering the orbital apex.
Okay.
See this bone I'm removing this one. See this all orbital apex bone I'm removing. See how this orbital apex is separated from V2. Can you see?
Okay.
Why this? What is this? Maxillary strut.
Okay.
This is orbital apex. See this?
Okay, okay.
What is there behind is the paracellar carotid. Orbital apex
is very close to the paracellar.
Paracellar carotid runs through the cavernous sinus. Okay. And the anterior extension of the cavernous sinus is what? Superior orbital fissure.
Yes.
See, I am removing this bone to show you. Removing the bone over the carotid also. That's a carotid artery per se. This is carotid.
Yes, yes, yes.
See, I am removing all bone, medial to it, inferior to it, anterior to it, to open up the cavernous sinus. The cavernous sinus continues anteriorly as superior orbital fissure. So all the intracavernous nerves continue anteriorly from the superior orbital fissure into orbital apex. I will show you one by one all the nerves. Just uncovering this bone to show you everything.
Okay.
This is cavernous carotid artery anterior band. I will show you all parts in the cavernous.
Okay.
Drill. Quick. I am drilling this sella.
Okay.
This opposite side carotid.
Okay.
In between is this sella turcica harboring the pituitary gland.
Yes.
Dr. Sethi?
Yes, I'm here.
Yeah, sir, just a thought occurs to me, a very naive thought. Future of skull base surgery, you should have some chemical which will just dissolve all this bone and put your structure, expose your structures, do your surgery and something to, put like some injection back and all the bone comes back.
Yes, yes.
I think,
very good thought. Very good thought.
Good
and
thought.
like everything else,
the research. Pardon?
like everything else, Richard is working on it.
Okay. I exactly put the thought so that maybe you could just pass it on to them as well.
Richard had already thought about it.
Okay.
Here I thinned out this bone so I can flake off this bone completely. See this bone I have thinned out.
Beautiful.
Now see, this is the bone from the sella. See, I've opened the sella. Section. See, two structures, very clear. This is sella turcica harboring the pituitary gland this is the meningeal layer of the pituitary. The two periosteal meninges. This is opposite cavernous carotid. See this?
Yes. Satish, what is the name of this fibrous tissue that holds the
falciform ligament? Falciform ligament, you're asking.
Falciform ligament, that's right.
About the optic now, I'll come to that, sir. This is pituitary and this is the cavernous wall. See the lateral cavernous wall and can see this, how this pituitary is suspended to the cavernous sinus through these fibers. Can you see these fibers?
Yes,
these are all dentate ligaments. How the pituitary is suspended. पानी डाल दिया करते हैं, सोए मत खड़े खड़े.
Can you later on show us the origin where the meningohypophyseal trunk and the inferiolateral trunk originate?
All I will show you. See this pituitary. Now, can you see behind the inferior hypophyseal artery?
Just point it out.
Yes.
Can you see the inferior hypophyseal artery?
Okay, yes.
This is arising from the posterior band of the carotid artery.
Yes.
This inferior hypophyseal supplying the posterior lobe.
Beautiful.
Supplying the posterior lobe on either side. The same on opposite side as well. See this?
Yes, very well.
This is coming from the posterior band of cavernous carotid.
You can see it coming out.
This is still outside the subarachnoid space. This carotid, see, this is the vertical course from where the carotid comes out of the foramen lacerum as a vertical cavernous carotid. Okay. Then there is a posterior band. And then this is the horizontal cavernous carotid. Can you see the horizontal?
Yes.
This posterior band give rise to meningohypophyseal trunk, giving rise to many vessels, including the dorsal clival artery. See this? Many bunch of vessels. Now this carotid, once this turns here as the anterior band. See, this is inside the carotid lumen. Can you see?
Yeah.
Yes.
This is the anterior band. See, this is the anterior band. And there, after the clinoid process is here, I will show you. It becomes subarachnoid where it gives the retrograde branch as facial artery. I will show you. After the facial, here it gives another branch,
not
superior
facial, ophthalmic
artery.
Ophthalmic artery.
Ophthalmic artery, sorry. After the
Satish, can you do me a favor and just show the paraclival vertical carotid coming in now?
Yes, yeah.
And I tell you what I'd love you to do is, can you actually remove the bone so you can see the vertical paraclival come in?
Sure, boss. I'll remove this bone to show you.
You do it just for me. Thanks.
So what I was trying to say, after the ophthalmic, it gives up a superior hypophyseal artery. So both this superior and inferior hypophyseal artery form a plexus around the pituitary where all hormones are released to the gland. Posterior pituitary hormones.
Satish.
Portal circulation. Yes, please.
You got no break, Satish. Yeah, hold on. Satish, stop right now. Stop right now because I want, before you dissect any more, Satish, I want you to show me. I want you to show us all.
What exactly you want to
see? Satish is asking.
No. I'm not muted. I'm not muted.
Certain questions.
No. Satish, I want you to show everyone here. Because you've got a great view of the vertical or paraclival carotid coming in.
Yes.
It turns and becomes the horizontal.
Yes.
And many people talk about the medial cavernous compartments.
Yes.
And is a great opportunity to talk about, Juan Carlos's
sinus compartments.
Yeah, but I don't want you to talk about every single classification system. I'd love you to show people the one that I like, which is Juan Carlos Fernandez version, which is all about the horizontal carotid. So you have an anterior inferior compartment. It is that space below the horizontal.
This is inferior compartment.
Exactly.
This is inferior compartment.
show the
This is medial
superior.
compartment. This is posterior superior compartment.
No, it's not. No, it's not in posterior. There. That is the superior compartment here, because it's superior.
Most of the pituitary tumor enter into it easily.
Yeah, yes, that's right. People call it the intercarotid sulcus, but it is the superior compartment. And show the posterior compartment. So the posterior compartment's at the back there. Can you show it? There, yes, that's the because it's posterior to the horizontal carotid. And you know what? I love Juan Carlos Fernandez's classification. It is so simple. When you've got an exposure like you have, Satish, is the time to explain Juan Carlos's classification. There is only one other area. You have the show again the inferior.
I will show you. I will show you, sir.
And then superior and posterior. And the final classification is the lateral wall. Because the lateral wall is not really a compartment. It is
just a space.
It is a potential space of nerves in dural folds. And so really in pituitary surgery, I've seen you dissect, Satish. I know that you can get cavernous involvement in any of those three compartments. And really it's only the lateral compartment. Once tumor gets into the dural folds between the nerves, then you're in trouble. And perhaps maybe radiotherapy is a better treatment. But surgery in these three compartments is all possible, Satish. I know it is. I've seen you operate here, right?
Yes, super. So what Professor Harvey said, this is anterior inferior compartment, superior compartment where most of the pituitary tumor transgates and go beyond the carotid, medial compartment and the posterior compartment. And there are various approaches to address each of these compartments. In between is the carotid artery. Now, if I follow the in between is the sella, the pituitary gland, and if you see this pituitary gland behind, there is a stalk of the pituitary. Can you see this stalk?
Yes.
Going to the posterior pituitary, coming from the hypothalamus, that is the pituitary stalk, and this is coming through the diaphragm. So I can elevate this entire pituitary. What the technique of pituitary transposition has been described to address the dorsal sella lesions. So I can elevate this entire pituitary off here, expose the dorsum sella, and that is known as pituitary transposition. See, this entire dorsum sella can be exposed like this, and this pituitary can be transposed. So for that, you need to open the plenum, which I am going to do quickly. Because of time constraints, I am going a little faster. See this, I am opening up this. You have not seen the optic chiasma, which I am going to show you very soon. So here, I am removing the plenum bone of the plenum. Above is the optic nerve. See carefully.
Yes.
Above the optic nerve, the optic canal is there on either side. So I am removing this very quick. This is the bone of the plenum. To uncover the, see the brain is little autolyzed.
Floppy.
Yes, the brain is little autolyzed. I can see. Oh, yeah. See the optic nerve on the opposite side. Can you see?
Yes.
Forming the chiasma above. That's the pituitary. That's the chiasma above. So in transposition, you can lift the pituitary and push it up onto the chiasma. You can park on the chiasma, the entire pituitary gland like this, and put a tissue glue like this. And this dorsal sella can be exposed section. Behind the dorsum sella is the interpeduncular system, the basilar artery, and the entire vascular system is behind that. Let me remove this bone quickly, and then we'll focus onto the cavernous sinus once again quickly, since we don't have time. So I will go really fast. Behind this, behind that. This is the dorsum sella, which I am going through. And behind the dorsum sella is going to be the interpeduncular system, where you will see, and you can see the circle of Willis completing, how it completes with the branches of basilar and carotid artery. So that is the pituitary, and behind is the dorsum sella, for your information. Now coming back to the, the carotid artery. This is carotid artery coming from here at the foramen lacerum. This is foramen lacerum or median. This median now, see this was the median canal going towards the foramen lacerum, and then it crosses the carotid artery. Now anterior to this, anterior to the carotid. This is orbital apex. Anterior to the carotid, it continues as superior orbital fissure. So let me open up the superior orbital fissure to show you the lateral compartment of the cavernous sinus, where all the cranial nerves are running from the cavernous sinus to the orbit. See now, this is your carotid artery.
Yes.
Can you see?
Yes.
I have medialized the carotid artery. This is your carotid artery running to the cavernous sinus. This is cavernous sinus. And there are numerous nerves running in the cavernous sinus. Can you see? See in the lateral wall of the cavernous sinus. Can you see very clear?
Yes, absolutely.
I will bring out one by one
Structures.
Yes. Now see, the top, above all.
This is the lateral.
Yes. See, this is your clinoid process. That's what I want to
really
show you.
Beautiful. Yes.
Can you see the clinoid process?
Yes, very beautifully.
See, below is the foramen rotundum. It is separated from the superior orbital fissure by maxillary strut. Can you see?
Yes.
Now this is a superior orbital fissure. It is separated from above by the optic canal. Optic canal is above. It is separated from the optic canal by optic strut.
Okay.
Optic strut is a part of the lesser wing of the sphenoid coming to the sphenoid body. So that separates the optic canal above from the superior orbital fissure, and maxillary strut separates the superior orbital fissure from the V2. Okay? And see all the nerves in the lateral wall, embedded in the lateral wall. They don't run through the cavernous sinus lumen. This is in the outer wall. So one by one, if you see the largest above close to the clinoid process, this is your third nerve.
Oculomotor.
Yes.
Oculomotor.
Sir, I can hear you. Welcome. Dr. Deepak Haldipur. See this?
Hello, Deepak.
Hi, sir.
See, this was the third now, which if you follow, if I can show you, if I remove the dorsum sella, you can see how it is coming close to the posterior communicating artery. That's a very important anatomy, how the third nerve is coming from the midbrain to the cavernous sinus. Below the third nerve, see this. Below the third nerve, the tiny nerve, the smaller nerve.
The trochlear.
Fourth.
Yes.
Trochlear,
See this smaller one?
Yeah.
Little lateral. Can you see this?
Yes.
This is fourth is a smaller nerve supplying the superior oblique. The third nerve is a bigger one, medially placed. The fourth nerve is a smaller one, laterally placed. Now below are two nerves. Can you see?
Yes.
The one medially placed, this one is abducent. This actually runs to the cavernous sinus proper.
Yes.
This runs to the cavernous sinus proper, close to the carotid artery. See how this nerve is close to the carotid artery? So this abducent actually runs through the blood of the cavernous sinus. This abducent close to the carotid. And the lateral one is the V1. See that?
Yes.
That is the V1. So these four nerves leaving the cavernous sinus, this is cavernous sinus. If I follow the V1 posteriorly, I will reach the petrous apex. See this section. You will find the ganglion. Let me cut the abducent here. Abducent I have cut. Yeah, cut and go follow the V1. You will reach the petrous apex with a trigeminal ganglion. See this. That is the petrous apex. And on the petrous apex sits the trigeminal ganglion. I will show you the ganglionic fibers. And here the ganglion divides into three branches. The one lower one is V2. See this horizontal V2. This one. The V1 is ascending into the superior orbital fissure, and one inferiorly and laterally. Here I will show you soon once I debride this lateral pterygoid muscle here would be the V3. I will show you very soon through the foramen ovale. So all these foramen run through the sphenoid bone to the pterygoid and the greater wing of the sphenoid. So V1, V2, V3. This third now, as it enters the orbital apex, see, for the orbital anatomy, to understand orbital anatomy, the best is to come from the transcranial side. Remove the orbital roof and you will see the nerve one by one in layers. The three now, which are outside the annular tendon, are the most superficial one. That is the branches of the nasociliary, the frontal and the lacrimal nerve, and the trochlear nerve. All three, this fourth nerve, all three are outside the annular tendon. Rest pass through the annular tendon as it enters the orbital apex. That is the condensation of the periosteum, through which all the muscles are, orbitarized. So this upper now, as it enters, divides into two branches, the upper division, lower division. The upper division supplies the LPS, levator palpebrae superioris, laterally and superiorly, and the superior rectus. And this lower division of the third supplies the medial and inferior rectus and the inferior oblique. And that nerve to inferior oblique is very, very crucial, which supplies the postganglionic fibers to the, the muscles of accommodation in the pupil, constrictor pupillae, and, one more muscle there. So this lateral rectus muscle is supplied by the abducent, which is the most medial nerve. See, the most medial nerve of the abducent, it enters the, annular tendon and goes laterally to supply the lateral muscle inferior, the lateral rectus. So all these muscles are supplied by the respective nerves. Nasociliary now. See, this V1 is a very important now. We discuss about the lacrimal fibers. This V1, as it enters, divides into frontal nerve, that divides into supraorbital, supratrochlear, which is the bundle for, pericranial flap, the vessels. The nasociliary nerve, which is very important now, carrying all the fibers going to the, sensory fibers to the constrictor pupillae muscle. It enters into it forms the ganglion from which the postganglionic fiber arises. So all muscles are important, all nerves are important. What I told in the beginning, this 1 square inch area, remember, optic nerve, carotid artery, all cranial nerves, orbital apex, V2, median, and the sella turcica. This 1 square inch area is most crucial to the otolaryngologist, to the endoscopic skull-based surgeon, as many tumors either arise from these areas or tend to invade these areas, like common angiofibroma tend to invade very commonly the cavernous sinus, orbital apex. And similarly, see, what the importance of anatomy is, the relationship. So wherever the tumor is going, accordingly, the relationship and remove the tumor accordingly from these areas. See now, the outer dura to this. If I go inside and open up this, see, I am opening the dura. And what is there laterally?
Muscles.
Temporal lobe of the brain again. This is temporal lobe of the brain again here. Okay. If I open up, that is the temporal lobe of the brain in the lateral wall of all these nerves. So that is the dural, outer dural layer, and outside that is the temporal lobe. Temporal lobe is above this, temporal lobe is lateral to this. All anatomy is around this pterygoid process. So let me quickly destroy this pterygoid, remove this pterygoid to show you much better. Some more anatomy. See inferiorly. You see this? This is Eustachian tube. See this? This is Eustachian tube. This is Eustachian tube. This is the edge of the pterygoid process. Can you see here behind?
Yes.
Posterior edge. That's a very important landmark. The parapharyngeal carotid artery is more than 2 centimeters behind from this edge.
Okay.
When you are operating in the parapharyngeal space, don't terrify yourself with the carotid artery.
Okay.
From this edge where my instrument is the posterior edge, the parapharyngeal carotid is more than 2 centimeters behind.
Okay.
And what is there anterior to it? This Eustachian tube. See the Eustachian tube.
Yes.
This Eustachian tube all the way, this is cartilage. I will remove this pterygoid and show cartilage. It goes up and laterally where the bony Eustachian tube comes, and then bony continues laterally to the middle ear in the anterior wall, anterior to the cochlea, medial to the, so all the carotid artery is medial to it all the way. In the ear, if you remember, the carotid artery is medial to Eustachian tube. The same bony Eustachian tube continues here, cartilage is Eustachian tube, and the carotid artery is medial all the way to it. So don't terrify while working in the parapharyngeal space. As long as you are anterior to the Eustachian tube, you are 100% safe away from the carotid artery. Let me break this, pterygoid quick. Oh, yeah. Yes. That's a pterygoid chunk. Let me, if it is immobilized, I will remove to uncover a lot of things. See this? And there is a muscle inside it. There are two muscles inside. Can you see the muscles?
Yes.
Two muscles. See this lateral pterygoid plate anteriorly give rise to the lateral pterygoid. From the medial surface, this muscle which is going in is the medial pterygoid.
Medial pterygoid.
And another muscle is the tensor tympani, which is again in the pterygoid fossa. And the tensor tympani, medial pterygoid are the great landmarks for the Eustachian tube behind. So I'm removing this pterygoid, removing this in toto quickly as time is running out. See this? Now see Eustachian tube section. See, this is the Eustachian tube. This is the Eustachian tube cartilage. See, per se. This is the Eustachian tube cartilage going up. Can you see?
It is
going up there. And there are two muscles, major muscles which control the Eustachian tube. See this. This is Eustachian tube cartilage, is Eustachian tube.
Yes.
The one muscle going from here up. This one muscle going up is the tensor tympani. And one muscle going down from the Eustachian tube here. See, this is levator palati.
Levator.
That is tensor palati. This is levator palati forming the palatal aponeurosis. See this? In the anterolateral part of the Eustachian tube cartilage, it is running towards the soft palate here. This is soft palate. So this is Eustachian tube. All this bone, pterygoid bone, remove and follow the Eustachian tube. As long as you are on the Eustachian tube, your carotid is far behind. Don't bother about it.
Okay.
As long as you are on the Eustachian tube, forget about a carotid injury or anything. So carotid protect the Eustachian tube protects the carotid all the way, not parapharyngeal up to the middle ear, like mother's lap. See the remnant of that pterygoid I am removing. Now, this Eustachian tube is an amazing landmark for this parapharyngeal carotid. I told you there are various landmarks for various regions. For the foramen lacerum, we have Vedian canal. Vedian now. For the parapharyngeal, this one. For the cavernous carotid, opticocarotic recesses. And yes. See this. Now, this is all pterygoid muscles. We have seen the upper part of the pterygoid process. This is V2. So, V3 is going to be just behind that. Just behind that from the upper edge of this pterygoid process. That's the V3 which is coming out. That's the V3, that's the foramen ovale through which you will see the same thing in the lateral skull with this thick now. Yeah, this thick white now. This thick white now, can you see?
Yes. Beautiful.
Can you see this thick white now?
Yes, we can see.
This is V3, the thickest of all. This is V3. V3 is thickest of all trigeminal branches. See this? And as it now comes out, see, all these nerves coming from the floor of the middle canal fossa. See, this is the floor of the middle canal fossa from where the V2 is coming down, from where the V3 is coming. This is coming across the carotid artery. Which carotid? Let me show you. See, the carotid ascends the parapharyngeal space into the carotid foramen. Then it becomes vertical petrous. Then it takes the anterior band. I will show in the lateral skull base anterior to the cochlea. Then it becomes the horizontal petrous carotid, which is coming from the cochlea like this, anteromedially to the foramen lacerum. This is this foramen lacerum. So that carotid is coming from here, horizontal petrous. This V3 crosses the horizontal petrous carotid from above and then comes down like a horseshoe leg. It is running in the floor of the middle canal fossa above the carotid and then come down the horseshoe leg. And this is the leg after which we see. That is the horseshoe leg. Now see, this V3 has various branches. This V3 has various branches. The one going, see this laterally? What is this?
Auriculotemporal.
Auriculotemporal. Particularly the posterior division has many numerous branches. From the trunk it gives a branch. Anybody? From the trunk it gives a branch. That is now to medial pterygoid.
Oh.
Which gives a branch to the tensor tympani in the ear.
Okay.
Then it divides into two divisions, anterior and posterior. The anterior is all the muscles of mastication. The mesenteric nerve, which is very important for the,
Yes,
I will show
yes.
you during the lateral skull base dissection, mesenteric facial anastomosis, mesenteric, all those nerves to the mastication is given up by the anterior division. Posterior division divides into three branches. The auriculotemporal, inferior alveolus and the lingual nerve. So if I remove this muscle, you will see the lingual nerve is joined by the chorda tympani there behind. See this? So this is the area where the chorda tympani joins the lingual nerve in the region to the posterior division branch. That is the lingual nerve, and that inferior alveolar nerve goes in the alveolar canal of the mandible. Lingual nerve we all know come in the submandibular triangle. That's how all muscles are innervated. Now this is the Eustachian tube. This is medial pterygoid. If I remove this entire medial pterygoid and go behind, you will come across the parapharyngeal carotid coming out. Give me the debrider. That will be the parapharyngeal carotid. So in the parapharyngeal region, when you operate, you're always, terrified by the parapharyngeal carotid artery. So we need to know all the landmarks. And when you go from anterior to posterior, I'll give you a good reference. See this? You take the reference of the posterior nasopharyngeal mucosa. See this? This is the level of the posterior nasopharyngeal mucosa. The carotid artery runs in the parapharyngeal space 1 centimeter behind this nasopharyngeal surface. See that the nasopharyngeal surface?
Yes.
So
yes.
as long as laterally you walk parallel to the nasopharyngeal surface, the carotid is more than 1 centimeter behind.
Okay.
So from the beginning, you don't need to terrify. You have to do a complete work. You have to remove this medial pterygoid muscle. Behind the medial pterygoid muscle would be the carotid sheath.
And how far is
behind?
Hello?
Pardon?
In the opening in the nasopharynx, how far is the carotid from the opening of the eustachian tube?
More than 2 centimeter behind and lateral.
Okay.
Fossa Rosenmuller is a landmark where the tip of the fossa Rosenmuller ends. The carotid is more than 1 centimeter behind, even from there.
Okay.
So carotid is far behind. It's not all that easy to enter the carotid in this region. It is so difficult to reach out. So you have to go behind this medial pterygoid muscle. The first barrier is the medial pterygoid muscle all the way.
Okay.
Eustachian tube, medial pterygoid muscle. This V3 is a landmark. See this? V3? The carotid, parapharyngeal carotid, where it crosses the horizontal petrous is 4 millimeter anterior to it. And parapharyngeal carotid is posterolateral to it, behind the foramen spinosum. See my area where I am going to?
Yes.
Posterolateral to the V3.
Satish, can you show us the foramen spinosum?
Yeah, foramen spinosum is where the maxillary artery branch, the middle meningeal enters. Will show in the lateral skull base approaches also, and here this is foramen ovale.
Yeah, so foramen spinosum is just posterior and lateral to this.
Lateral to it.
Lateral.
The foramen spinosum, where the middle meningeal artery enters. The same anatomy we'll see in the infratemporal fossa.
Yes.
The approach to the lateral skull base.
Yes.
So that also crosses the petrous apex. I mean petrous carotid artery.
No. That crosses the petrous carotid, obviously, like V3.
Yeah.
I will show you there.
So when you start from lateral to medial, Madhuri, you can see middle meningeal would be most lateral, then would be V3. then
Yeah.
would be Eustachian
More
tube,
lateral,
as you can
posterior
see,
and
Satish.
lateral. It's more
See,
posterior and lateral.
Yes.
These are this is the auriculotemporal. Between the twigs of the auriculotemporal, the middle meningeal ascends.
They're the middle meningeal
Oh,
artery.
great.
So this is the greater wing of the sphenoid, all the way, greater wing of the sphenoid.
Great.
And that
Yes.
is the middle meningeal artery. See this. See
Oh,
this.
yes.
That is
Very,
middle
very,
meningeal.
yes,
very
yes.
Very
Between the
Can you
two
see?
branches. Yeah.
See this
Yes.
middle meningeal?
Yes.
That is
Ascending
foramen
to this
spinosum.
foramen. Just
Yes,
above my
yes.
instrument. Section karna.
Yes.
It's lateral to V3.
Pardon?
Posterior
Lateral to
lateral.
V3. Lateral to
Yes.
V3, I said.
Yeah. Lateral to B3.
Slightly
See the
posterior
middle
and
meningeal
lateral.
artery?
actually.
See the middle meningeal artery.
Yes.
That is the middle meningeal artery, everybody.
Yes.
Can you
Very
see the
nice.
vessel?
Very
Yes,
nice.
we
Yes,
can
yes.
see very clearly.
Yeah. Carotid is immediately behind this
Okay.
in the
Hmm.
lower part.
Yes.
So, if I remove all this muscle, more than 2 centimeter thick muscle, the carotid is still far behind.
Okay.
See how behind is the parapharyngeal carotid. इसको दबा के रखें बोन को इसको दबा Oh, my parapharyngeal carotid is far off. See the inferior alveolar nerve. This is the inferior alveolar nerve.
Yes. Going towards the mandibular foramen.
Yes. And medial to that is the, see that is okay, the lingual nerve. See, daba. Push down.
Inferior volar lingual. Yeah, that's right.
That is the lingual nerve, medial one.
Okay.
And this lingual nerve is joined from behind by the chorda tympani. See the lingual nerve?
Yes.
Much better now?
Yes. Very clear.
If I see them, that's the chorda tympani. See that chorda tympani? The whitish
Focus it.
fiber.
Point it out, please.
Just a minute. Cut or what? And still the carotid is more than a centimeter behind.
Okay.
Okay. This was the which I cut. That is the chorda tympani.
Yeah.
Here. That's joined the lingual now, but I am going behind. See this? Now comes the styloid diaphragm. Styloid diaphragm is what?
So you
The thick muscular diaphragm covering the carotid artery.
So you need to clean your endoscope. Satish, there is a
Yes.
bubble coming there.
Yes.
Yes, now better.
See, the carotid is far behind.
Very far.
So what are you looking for now? Styloid process?
No, styloid is far laterally here, sir.
Yeah.
Styloid, deep lobar parotid are lateral.
Yeah, all lateral. Yeah.
Out of the reach of endoscope.
You're doing this step just to demonstrate the parapharyngeal carotid, or is it something else?
Yes, that's to demonstrate the parapharyngeal carotid. That's it. That is.
I'm just about see it, I think.
Yeah, it looks like just a minute. See, even your debrider falls short. It is too deep.
Maverick.
So as long as see this nasopharyngeal surface, 1 centimeter deep to that parallel.
So for parapharyngeal
See the
lesions, you go from
V3
the next.
branches. V3 branches.
Satish,
Yeah.
For parapharyngeal lesions, you'll go through the neck.
दोनों को separate कर.
Is there any lesion that you'll go from here in this way?
Pardon?
For parapharyngeal lesions, you go through the neck. Is there anything you will use this endoscopic approach to the parapharyngeal
I'm
space?
removing this now. And yeah, in the region what?
Parapharyngeal endoscopic approach to the parapharyngeal space. What lesion would you access through this approach?
Can you see the carotid artery behind? That's the carotid artery.
Yeah, it's seen.
That's the carotid vertical. See this? That is carotid artery. Hello.
Yeah, we can hear you. We can see it clearly.
See
Satish,
how
we can see it
far
clearly.
behind is the carotid? Can you see the carotid?
Yes.
That's the carotid artery. See how far behind it is and see the relationship. That was the V3. This was the foramen spinosum, just deep to it. Here, this is the parapharyngeal carotid artery. Everybody.
Yes, nice.
Yes, nice.
carotid-
Nice.
This carotid ascends up the carotid foramen. Let me show you what is the course going to be. This carotid ascends the carotid foramen to become a centimeter course as vertical petrous carotid. Then it takes a turn anterior to the cochlea, medial to the Eustachian tube in the ear. We will see from there. And become the horizontal petrous carotid to come here all the way to the foramen lacerum. And this horizontal petrous carotid running in the floor of medial canal fossa is crossed by V3. See this V3? This crosses that carotid. The horizontal carotid comes here at the foramen lacerum. Here it ascends. There is a ligament, petrolingual ligament. After that, it becomes cavernous carotid. And this cavernous has a vertical course, posterior band, horizontal course, then anterior band, clinoidal portion, and then it becomes subarachnoid. Since the brain is autolyzed, I cannot show you, otherwise I would show you intracranial structure. See this?
Yeah, you can just about see the ophthalmic branch, I think, over there. Be careful with your debrider. I think you can just about see.
Yeah. See the ophthalmic artery. See, it is given off from the carotid here.
Yeah, you can see it, yeah.
Let me show you. I have
It's
seen the
seen, sir.
ophthalmic artery. Yeah. See this carotid? And see this retrograde branch given off. This is ophthalmic artery. Can you see?
Yeah.
This is ophthalmic
Very
artery
clear.
which has come. This is optic nerve which is cut. This is ophthalmic joining the optic nerve. And then it continues. It gives superior hypophyseal. Here is the superior hypophyseal. Then gives the anterior cerebral, posterior communicating, which joins the basilar system and forms the. See the band of carotid, how it looks like.
Yeah.
See the carotid injured.
Yeah, we can see that.
That is the horizontal portion, anterior band, and it becomes subarachnoid. And here it gives the first retrograde branch, ophthalmic. See this?
Yeah.
Yeah.
So, from parapharyngeal, vertical petrous, horizontal petrous, this we will follow the horizontal petrous in the lateral skull base dissection. If I remove this bone, see this pterygoid base, this one from here to here, you can see the horizontal petrous carotid quickly. Quick. Hit. Yes. I want to remove this pterygoid base. The middle cranial fossa will be exposed. The floor of the middle cranial fossa in which the carotid artery runs in the length of the petrous bone. This V2, as we have seen, is separated from the superior orbital fissure in the cavernous sinus by the maxillary strut. So V2 never passes to the cavernous sinus, for that matter.
You can see the metal
carotid
scale.
there?
Yeah.
See the horizontal carotid.
Yeah.
Yeah. Yeah.
I said you can
Now
just
the-
begin to see the metal scale.
Yes. So behind is the petrous apex. There are very variety of endoscopic approaches to the petrous apex from here. If I drill the clivus and I can transpose the carotid medially to expose the petrous apex there. So see now this. What is this? That's the horizontal petrous carotid going behind. See this?
Yes.
This is, let me show you. In no time. See this carotid, this is horizontal one coming from the ear. See this carotid.
Yeah.
And see this now was crossing the carotid in the floor. This is floor of the middle canal fossa.
Yeah.
Yes. Yes.
Just for your orientation, this carotid is coming from behind. See, this is the carotid. This is the carotid. This is the carotid. See this in the floor. The bone is very often dehiscent.
Can you see the GSPN?
GSPN, I have, here is the GSPN. This is coming and
that's the
forming the
one.
median
That's the
here.
one.
Yes.
Yeah, that's the
Forming the
GSPN.
median here. So now
Yes.
see the carotid, horizontal petrous carotid, everybody.
Absolutely.
Can you see, boss?
Yes.
Beautiful.
Yeah, it's clearly.
Beautiful.
This is horizontal petrous becoming foramen lacerum and then cavernous. So this
And
carotid,
can you see the petrolingual ligament where it becomes the
so petrolingual ligament comes from the behind. See,
From behind,
behind
yeah.
is the petrous apex. Let me show you. See this. Yeah, you can hold this. Above this level, see, this is petrolingual ligament. See this.
that's right.
From the petrous apex to the sphenoid, lingula of the sphenoid bone, the importance
That's a
of
very
this
important
ligament is-
landmark.
importance of this ligament is after this ligament, this is cavernous carotid. The cavernous
Fine.
starts not from here, foramen lacerum, from
Mhm.
petrolingual ligament.
Petrolingual ligament. Yes.
Then onwards is the cavernous carotid. Before that is the horizontal petrous and the foramen lacerum. So that was and see, this is the course of the horizontal petrous carotid, and this was crossed by V3 here. See, this is V3.
Yeah.
So V3 coming from here, from the petrous apex like ganglion, crossing the carotid artery, and then come down like a horseshoe leg. Immediately down like this. So from this, the petrous carotid is 4 to 5 millimeters. See this carotid here? Once you see the horseshoe leg, this V3, the carotid is 4 to 5 millimeter behind.
Yes.
What an amazing landmark. This is the horseshoe leg. That is the V3, the mandibular canal. This is mandibular canal. And this is the, main trunk, the posterior division here. And this is crossing the carotid. And this is the horizontal petrous carotid. Now, if I remove this bone, what is this bone? This is Eustachian tube, bony Eustachian tube. If I remove this bone, whatever carotid we have seen here, you will find carotid reaching into the middle ear and taking a turn and coming like this. This turn you can see, this turn which is coming here. And if I drill this bone, we'll be right into the middle ear. From there, you can see the all middle ear structures, facial nerve, everything, the cochlea, everything. This bone needs to be drilled. That's a Eustachian tube. See this?
Yeah.
So that part of the dissection we will see from the lateral skull base. So what we have seen, the carotid in the parapharyngeal space going except the temporal bone, coming out. This is the horizontal petrous carotid. See this? In the floor of the middle canal fossa, very often this floor bone is dehiscent, covering the carotid or very thin. See this?
Yes.
And here it becomes the foramen lacerum carotid and then the cavernous. So in the sphenoid sinus, see when we work in the sphenoid, this is sphenoid sinus. In the sphenoid sinus, when you see the paracellar carotid, this paraclival carotid, this pterygoid is there to protect us. This thick bone is there to protect, because carotid doesn't come here down, the carotid goes behind. See this behind. See this how it goes behind?
Yeah.
So don't terrify. Here is not going to be the carotid. Here is the middle canal fossa base. So the tumors involving the middle canal fossa dura, tumors involving the cavernous sinus, tumors involving the sphenoid, tumors involving the pterygoid are the most complex tumors because of this
So
neurovascular
Satish,
anatomy in the vicinity. Yes.
Satish, the direction of the petrous carotid is from the
Right.
posterior lateral to a more anterior medial direction.
Yes,
correct?
yes. That is the petrous horizontal
That's
petrous
exactly what you
carotid.
can see that. Yeah.
So what I was trying to say, this is petrous carotid. This 1 square inch area, all the tumors in this region are most important, and for this anatomy, understanding this anatomy is very clear.
Okay, hey, Satish, you got one. It's beautiful anatomy, and you know everyone. You can see that the foramen ovale also stops the surgeon from getting into the carotid foramen. But can you show me now's the time, Satish, to show Paolo's fat pad? So do you know? Are you familiar with Paolo's fat? This is how you find the cervical carotid before it enters the skull base. By going between the TVP and LVP.
Okay.
Well, it's actually really TVP and medial pterygoid muscle below the skull base, because the other place that surgeons need to find the carotid is in the infratemporal fossa. And I wonder if you could show us the cervical carotid, where to find it in the infratemporal fossa. And I call it Paolo's fat pad. But
I had shown, boss. I think you were not that time. See, let me show you. This is the V3 branches. Behind is the foramen spinosum. This is the middle meningeal artery. Foramen spinosum. This is V3 foramen ovale.
Yep.
And behind that and below was our parapharyngeal carotid. I had shown that. I will show you if you want to again. Now, what I was going to show in the end was the petrous apex and the various approaches to the petrous apex. Petrous apex, petroclival region is a complex lesion area, and there are various approaches from the lateral skull base, open and endoscopic skull base, and you have to choose a technique according to the anatomy, according to the disease extension and what. See this.
So you can see the fat pad here. It's slightly medial to where you are. Not there, even more medial. No, come anterior, Satish.
Yeah.
No, anterior. If you come anterior, you'll see the fat pad. Just lateral medial to that. Yeah, see that? See a muscle there? So just in there. That's that. See that yellow fat? Yes, but in that little plane between the muscles is where Paolo describes it. Between medial pterygoid and TVP. Yes. And I don't know if sometimes it's hard to demonstrate on a cadaver, but you'll find this little fat plane between the muscles, and it takes you
medial
to
pterygoid is the guide, basically.
Yes, essentially, yeah.
But
not. We used to use the medial pterygoid plate, didn't we? But this is following the split between the medial pterygoid and TVP.
Yes, medial pterygoid muscle I am talking about is the best guide to go behind. Now, see in the end. See now, can you retract like this? Can you see this bone? What is that? That is petrous apex. See, this is V3 which was coming. See this V3. This is V3. Can you see? V3. And
then is that the cavum?
This is the trigeminal ganglion.
Yeah, that's the cavum.
That's the ganglion here behind. And this is the petrous apex, which is being crossed by the ganglion. That's the petrous apex, which is being crossed by the ganglion. So to address the petrous apex, there are various approaches. Medially, trans-sphenoidal. From here, you can expose the carotid artery and transpose the carotid artery medially, and you can be there on the petrous apex. This is the ganglion. And there are approaches infrapetrous, suprapetrous. This is the petrous apex. Suprapetrous this is the quadrangular space. Can you see this quadrangular space between the vertical and the horizontal part of the carotid? And we have removed the abducent. The abducent one now forms the roof. This is quadrangular space to address the petrous apex or the trigeminal ganglion. Anything else you want me to show? We have already crossed the time limits. Still, I can show you if you want me to anything to show.
I think you're half an hour past, so we need to switch on to lateral skull base. You got any comments, or would you like to say anything?
Anybody wanting me to show anything? No. Any comments?
Only that it's an amazing dissection, Satish, and that you make it look easy. And I think anyone who's wanting to do surgery in this area should do some cadaver work first, because it's if you're not familiar with this area, it's not as easy as Satish shows it, in terms of dissection. So amazing job, Satish.
Thank
Satish,
you.
You are a magician. Very beautiful. Very beautiful,
Thank
superb
you.
dissection. We
So for
enjoyed it.
lastly for everybody, this is temporal base. This is
Yes.
temporal dura. This is temporal lobe of the brain. This
Yes.
is bounded medially by the cavernous sinus, inferiorly by the infratemporal fossa. This is infratemporal fossa. Here anteriorly was the pterygopalatine fossa. So
And you
this
can see
is
the
the
beautiful,
temporal base
you know,
to address the
carotid
temporal
arteries.
base lesions.
Yeah.
See, this is the anterior nasal cavity. This is the highway to the temporal base. Once you go by the paramedian approach, this is highway. We do a lot of lesions like schwannomas, CSF leak, meningoencephalocele, tumors, mucor. Mucor was the one who required maximum this kind of approach to address to this temporal base and the cavernous sinus and pterygoid. Mucor would preferentially involve the pterygoid bone and the temporal base further. So this is something we endoscopic surgeons must be well versed with this kind of paramedian approach to address the skull base and the course of the carotid artery.
Satish,
Dr.
we have
Dr.
a
Sethi?
otologist who just joined us some time
Yeah.
back. Like to introduce him. Come, Hingwei. He's waiting for
no.
the lateral skull base. Yeah. Hingwei is with the Changi General Hospital. He is the head of the department and an otologist and lateral skull base surgeon. So he'll be joining us for the afternoon session.
Oh,
So say hi to him.
nice. So nice of him.
Thanks, Prof. Hi. Nice to meet you.
Welcome.
Amazing
you.
dissection. Very nice.
Thank you, boss. Thank you. So lastly was a question from Madam Bafna here, whether we can see the motor and sensory roots of the trigeminal ganglion. Practically, no, but yes, in the region being from endoscopic perspective, you cannot see. From lateral skull base, yes, I can show you. The reason is the motor roots are carried only in the mandibular branch. Rest are all sensory. So if you follow the motor root in the Meckel's cave, you can see the motor fibers coming specifically. That comes from the different part of the pons as compared to the sensory roots. So any other questions?
So Dr. Sethi, thank you for stopping Satish at this point before you
Yes.
started showing lateral skull base surgery through the endoscopic route.
Yeah. no, Satish.
We had
It's really
almost reached
important
the middle year.
Yeah,
we can all see you now. We can all see you now on the screen. And so out of respect for the otologist, you're allowed to take your blindfold off now. So you're allowed to use your eyes when you do the lateral skull base dissection. It's
Yes.
okay. We don't mind now.
I was
boss.
telling them that you're doing the dissection blindfolded.
I'm sorry, I'd caught eye flu last night, so I have to use this to protect others.
Satish, I really thought you'd show the facial nerve now next endoscopically.
Facial now, see, we had seen the Eustachian tube wall. The moment,
Satish, it's okay. Show it lateral skull base. I was just joking.
yeah, in the lateral skull base, just let me tell you, we'll start in 5 minutes. In lateral skull base, what we'll focus today in the given time, the entire anatomy of the temporal bone in detail and some common approaches like translabyrinthine, infratemporal fossa, middle fossa approaches for the to address various lesions. In-depth anatomy of the inner ear, semicircular canal, cochlea and vestibule in detail. As far as the cochlear implant is concerned, in that perspective, we'll see the entire anatomy of the cochlea from inside with all the scalas and all the turns of the cochlea in detail. And then, very, very important, the facial nerve. We'll show you the origin of the facial nerve from the brainstem to the various, parts in the temporal bone till its final destination in the salivary gland, the parotid. And in the end, we'll show the facial-mesenteric anastomosis, as our dear friend Dr. Ashim Desai had a special request for that. So we'll do the facial-mesenteric anastomosis, our preferred anastomosis for the 5-7 anastomosis for the facial palsy rather than 12-7. We have given up 12-7 years back, and the facial-mesenteric is the answer. We'll show that. So in 5 minutes' time, we'll get back to you. After this break, we'll reorganize our microscope and lateral skull base instrument and then get back to you. Yes, sir.
Arrange one silent scope also, just to see the cochlea inside.
Okay,
If it
I'll
is there.
silent scope. Okay, we'll show the cochlea from inside with the silo endoscope. That's great idea, boss. Okay, thank you. So we'll get back to you. You can also have a break for 5-10 minutes. We'll reorganize the instruments. कब आए नहीं थे क्या किधर बताइए
Yeah, for the temporal bone bit. Yes.
Rightly. باعت له ابقى معاه على الزوم عشان اتكلم معاه.
Okay, cool. Satish, are you online?
Hello.
Yes, yes.
Hello.
Yeah, we are online. Hi.
Yeah. So there was some skin of the head was taken off by the skin guys for their some research work. So
Yeah. Go ahead.
all this skin has been removed for some research work here. So what I'm trying to show before reach out to the temporal bones is because we have to reach to the temporal bone. There are certain, this is the era of, skull-based surgery where we need very often or we look for vascularized flaps everywhere.
Yeah.
Around the temporal bone are variety of vascularized source. There are a lot of tissue which is a source of vascularized flaps around the temporal bone. So I'm quickly giving an overview because the time is for the temporal bone dissection. See, this is the pre-auricular region. Can you see?
Yes.
Pre-auricular region, and I'm giving this incision to show you some important flap in this region, which our dear friend Ashish Bhumkar uses very often. This is a very useful flap in our practice as well. This is the pre-auricular region, and what we see here,
I'm
just
sorry, we
underneath
are
the
out
hair
of
follicle.
focus.
Pardon?
We are out of focus. The camera should focus better.
Focus.
Satish, we are having the external picture.
Awesome.
Better?
No, you're seeing through the microscope, but I think we have an external picture.
Microscopic vision. Okay, I didn't know. So what I'm trying to show before I go to the temporal bone, some important vascularized flap which can be very useful for reconstruction of temporal bone defects. And the first one, what I'm showing is this preauricular incision. There's an important vessel, the terminal branch of the carotid, the superficial temporal artery.
Yes.
This is given off. So I am raising a flap. This is a flap based on the superficial temporal artery branches.
Centralized, please.
See my plane of.
And let it be focused.
Yes.
Slightly more. This is the lowest magnification.
Boss, focus ठीक नहीं है.
Yes, I am doing, boss. Better?
Yeah, good.
No, very good.
Excellent.
Perfect.
Now see what I am doing is elevating this flap. Just underneath the hair follicles. Can you see this?
Yes.
Yes.
Just underneath the hair follicle, because the branches of the superficial temporal are very, very superficial. And this tissue, superficial temporoparietal fascia, is a great flap, very robust flap based on the superficial temporal artery. See this? This contains all tissue lateral to the deep temporalis fascia. From just underneath in the live surgery, you will find this tissue to be more thicker. You can go and elevate this flap from far anterior to far posterior region. So this is a huge flap based on superficial temporal. See this?
Yes.
You are not supposed to go deeper. Just stay immediately medial to the hair follicles. You can use the Doppler to see the facial nerve branches. See, this is a thick flap, can be used for temporal bone obliteration, after the defects in the temporal bone, for lining the bigger mastoid cavities, or many other regions, including the pinna reconstruction, resurfacing the raw areas after the pinna reconstruction. See this? I am not showing the entire flap. What I am showing is this tissue is the donor tissue for reconstruction. Yeah. Got my point?
Right.
You can go high up to the temporal line. You can go far anteriorly. You can go far posteriorly, and you can raise this entire, thick tissue until the deep temporalis fascia, and the vessel is superficial temporal artery. Got my point?
Right.
This fascia can be taken for endoscopic, skull-based reconstruction. I told you, this entire flap based on this vessel can be taken from underneath the zygoma to the intertemporal fossa, and you can line the entire, skull base.
So lately, what
I am removing this to show you deeper.
Okay.
See this? This is a thick flap. This looks more thicker in the live situation. Now, what is this? This is temporalis fascia.
Yes.
This is the temporalis fascia. See how thick the flap is. This flap can be 20 centimeter in width. I can raise this flap right from anteriorly there till posteriorly. This is temporoparietal fascia flap.
Yes.
Underneath, this is based on superficial temporal. Okay?
Yes.
Now, another flap underneath this is the temporalis fascia. We use commonly for as a fascia graph for tympanic membrane reconstruction.
Yes. Reconstruction in middle ear and mastoid.
Now, this entire temporalis fascia can be taken as a pedicle flap based on the deep temporal arteries anteriorly. Deep temporal vessels are branches of maxillary artery.
Maxillary.
So this again 15 to 20 centimeter large from behind till anteriorly everywhere. This entire fascia flap can be raised as a vascularized flap. See this? Like this. This is fascia. This fascia flap can be raised as a vascularized flap to line the temporal bone defect to the mastoid cavities, and it is a very good flap. See this? This flap can be rotated inside the mastoid cavity based on these deep temporal vessels anteriorly. See the pedicle vessels anteriorly here. See the pedicle vessels coming into it.
Yes, we can see.
So that is deep temporalis fascia flap, and you can see this entire area behind the ear. You can raise this entire fascia and taken as a good flap for lining vascularized flap.
Yes, that's what I use for low hairline of a medpore. And with Satish's help, we are also using the superficial temporal artery flap for lining the canal atresia. You make
yes, that's very nice on the skin.
You're right, Ashish. This flap really helps.
Yes, and there's one more he will show, the deep temporal, maybe if we can. But that's the one he helped me to. It's okay, Satish, go ahead. Sorry.
Yeah. Now underneath, this is the temporalis muscle.
Yes.
See, this is a huge muscle from the retroorbital region behind till the occipital region. And this muscle is very interesting, extending up to the superior temporal line. This muscle has a unique, neurovascular supply. This muscle has a segmental neurovascular supply. In the sense, and using that advantage, taking the advantage of understanding of that neurovascular supply, you can make a variety of flaps of this muscle. Almost 8 to 10 variety of flaps can be made from this muscle easily. The reason being, the anterior 1/3 or less than that, around 25 to 30% of the anterior part of the muscle has a supply from the anterior deep temporal vessels and anterior deep temporal nerves. Middle 40 to 60% is supplied by posterior deep temporal vessels and nerves. And the posterior 20 to 30% is supplied by posterior deep temporal vessel as well as middle temporal artery. See, this superficial temporal artery as it crosses the zygoma. This is zygoma here. The superficial temporal artery as it crosses the zygoma, it gives a branch behind. I will show you. Those are middle temporal vessels which supply this posterior part of the muscle as well as the underlying pericranium. So this posterior 20 to 30% is supplied by deep temporal and the middle temporal artery. So all these segmental blood supply, and the blood supply comes from the deeper surface of the muscle, traversing through the thickness of the muscle to come to the periphery. So all this entire network traverses the muscle from deep to superficial. So by elevating the muscle from all around, you can preserve the nerve supply coming from below, vessel supply coming from below, and variety of flaps can be instituted. Bipartite, tripartite, variety of flaps can be made according to the need.
Sorry, Satish, can this vascular map be seen on CT angio?
Yes,
or is there any imaging modality?
Yes, you can see this. You can map the entire vascularity on CT angio. And this is so versatile. The anterior part can be used for orbital reconstruction, for facial nerve paralysis, making the orbital, the eyelid slings. The middle part for the oral cavity defect. For the this advancement of the temporal. facial palsy to the advancement to the lip, the tendon advancement to the lip. Yes.
Satish, lately what we have started using the whole muscle as a flap for repairing palatal defect, big palatal defects.
Yes.
It is very
This is versatile. And it has
very
a rich
versatile.
vascularity. You can use it everywhere. The posterior and the middle part can be, rotated for the reconstruction of the temporal bone defects. You can completely cover the temporal bone with this defect. Though in our practice now, we have stopped using temporalis muscle as a material for obliteration. The reason being, we use the fat. Fat survives well. The reason is the post-operative time. Because
Satish, we lost you. The picture is frozen and we can't hear you anymore.
Gives an interface, you can get a fat suppress imaging and see the tumor recurrence separately.
Please repeat what you said because we lost you.
Oh?
Yeah. So, So you were talking about using fat and then we stopped hearing you. So can you repeat what you said?
Now is it coming?
Now it's coming. Now we are perfect.
Okay. So what I was trying to say, we have stopped this muscle as a material for obliteration after malignant tumors. The reason being, we have to monitor recurrence, and the fat gives an amazing interface wherein we get a fat suppress MRI that completely suppresses the fat, and you can monitor the tumor recurrence very well. With the muscle, when you use the muscle, with the variable enhancement of the muscle on giving contrast, it is very, very, very difficult to differentiate the muscle, enhancing muscle from the tumor. So that is a problem. So now we have stopped using this muscle as a, obliterated material for after malignant tumor, but just for other reasons we do. Okay. Now, so these are the variety of muscle flaps. Now, I will make this post-oral incision showing some more flaps for usual practice in otology. See this. This is my post-auricular incision. The pericranial flap I will show after raising this, post-auricular flap. That's the post-auricular, regular post-auricular incision. आ जाओ एक जना. See the regular post-auricular incision. I'll complete in a minute and show you some very good flap which you can use in every otology case. Whether needed or not, you can replace it back. See this. This is the post-auricular region.
The patient is bleeding like he's alive.
That is the extra-aortic canal. See this? When you are doing any cholecystoma surgery or anything, what you can simply do when you are particularly doing a canal down mastoid surgery. This is so useful. If you don't use, you can replace it back. That is occipital. Occipital artery base flap. See this thick tissue behind over the mastoid cortex?
Yeah.
See this? What I will do, I will cut from above at the level of the temporal line. Cut above at the level of the temporal line and make a flap of it based inferiorly on the
occipital artery based flap.
The beauty of this is the occipital artery comes from below, comes from medial aspect. See this. On this thick flap, you can raise very easily. If you don't want to use any time, you can replace it back. But if you have done an open cavity mastectomy, this is an amazing vascularized flap to line the cavity.
Yes.
To partially reduce the cavity, there is a vascularized tissue over which if you place your temporalis fascia, takes up very fast and certainly, almost certainly prevent discharging cavity.
So we can elongate it by cutting.
tips or tricks to lengthen this flap, Satish? Sometimes it can fall short.
Even you can go high up to raise this.
So take the muscle along.
Yes. See this flap is so richly vascularized. Occipital artery is a branch from carotid artery.
So don't you take the periosteum along with for
You
better
can.
vascular?
You can take.
Okay.
See this, and the vessel is quite deep, so you never injure the vessel with this. See this, you can use it lining the mastoid cavity. Such a good flap
And
to partially obliterate, line, and you can place your temporal fascia above this. Okay.
And you can cut the width to increase its length. In the
Yes,
width,
yes, yeah. You can cut the width from here and further increase the length if you want.
Yes.
See this? That is the mastoid tip. There are variety of number of muscles attached to the mastoid tip. The most lateral one, this is the sternomastoid. Then underneath this is the splenius capitis. Underneath that is the digastric. A variety of muscles, number of muscles attached to the mastoid tip, and this vessel comes from deep to digastric. What my point?
Okay.
So this way the vessel comes from below, it is never damaged,
Okay.
So it is very, very safe. See, if you have a cavity, remove the mastoid tip. In order to place this flap, you have to remove the mastoid tip for this flap to go inside easily. And then it can cover the entire cavity so easily. It can reduce the size of the cavity to prevent cavity problem. And this is vascularized. If you lay your free temporal fascia graft, it takes up very fast. So this
And
is
once you once you remove the tip,
flap. Pardon?
once you remove the mastoid tip, digastric also comes and fills the deeper part of the cavity. So it also obliterates the deeper part. Digastric
that
muscle.
falls into the
Once
cavity.
That falls into the cavity.
Falls into the cavity. Now,
Dr. Vai,
lastly,
any comment?
I told you something about the middle temporal artery. Remember?
Which
Hello?
one? Oh, yes.
Now see,
Peritoneum.
where are the middle
brilliant
temporal
flap.
artery branches? See this.
The railroad artery is the flap
See
I am
this.
also using.
See, lots of middle temporal artery branches. Can you see?
Yeah, very
Yes,
nice.
yes.
Can you see these vessels?
Yeah, railroad appears.
Railroad. So this gives us another flap. Ashish, this can be very useful to you.
Yes,
I
yes,
showed
you
once
taught me this. You
for
taught
your
me.
pinna. Yes.
And
For
unlike
canal
the
lining, let me
superficial
show you.
temporal artery, this is a very thin flap.
Yes.
So, for the canal lining, this is even better than the superficial temporal artery.
Yeah. Yes.
So
See
very,
now
very
what I'm
thin.
trying to show. How versatile this flap is. We use it very often for various indications. See this. I have raised the muscles from behind, elevated the muscle. This vessel arborizes all over and supply this pericranium like anything. See this vessel is just underneath the pericranium. Can you see this vessel?
Yes.
Yeah,
very
Satish, very nice. I think this one also you can use it for lining skull-base defects,
Yes.
Yeah, it's a nice
See
thin
now
vascularized flap. Yeah.
how big the flap I am taking now. See how big the flap I am taking.
Yeah.
You can use it for lining the temporal bone cavity, covering the electrode, the cochlear implant electrodes, covering the skull base, the tegment defects, and covering the bare extraordinary canal. See, that is most important. If you have a bare extraordinary canal with no skin, you can cover all around with this flap and put a free skin graft over it, which takes up very fast. Now see, I am elevating this. This is such a thin flap, very robust, very useful, and elevate it from all over. All over, you can elevate it. In the live surgery, it is much better. You can elevate this pericranium like this. And this whole flap can be rotated inside wherever you want to.
There's almost 100% acceptance.
Yeah, and you put a skin graft over it, it takes up very fast. You put a temporal fascia graft over it, takes up very fast. And we have done a couple of cases using this flap as a vascularized flap tympanic membrane reconstruction. See, until now, what we have been using for tympanic membrane reconstruction, free temporal fascia. Free graft can always acquire, infection because of lack of vascularity. with such a
What you are
thin
doing? Why are you irritating me?
See this, such a thin flap, you can do a pedicle graft tympanoplasty, which can never fail. Pedicle graft vascularized flap tympanoplasty, which can never fail. This is such an versatile. It has a narrow pedicle below. You can rotate the entire flap into it. See this? This is much easier. In one go, you can elevate this plane in a live surgical situation. So this flap, such a big flap, see this? You can use as a pedicle flap for the tympanic membrane reconstruction. So this was quickly all about the flap. We'll focus on the temporal bone dissection. So coming to the temporal bone, that's a very important, I would say, one of the most complex bone in the body. Temporal bone, developmentally has 4 parts. Developmentally. 4 parts being this most superficial. Everywhere what you see, this part of the bone going, see, till high up over here, till high up. This is the suture line. This entire part, entire mastoid everywhere, this is squamous part of the temporal bone. Whatever you see on the surface is the squamous part. No other part is visible on the surface. Everywhere is squamous part, large one. Deep to it, harboring the labyrinth and all important areas is the petrous part. Third is the tympanic segment forming the inferior and the posterior inferior part of the exotic canal and continuing as a, the styloid process below, later on down with a, that is tympanic bone. I will show you the thick bone which forms the lateral wall of the jugular foramen. That is very important to drill away in glomus jugular surgery, the paraganglioma surgery. And the fourth is the styloid eminence. Styloid eminence is the bone which forms the fallopian canal, which forms the posterior most part of the mesotympanum with all the impressions, depression forming that bone. That is ponticulus, subiculum, caudal eminence, all this pyramid, everything are formed by styloid complex. That is a different part. Developmentally, mastoid is not developmentally a part of the temporal bone. Mastoid later on after the birth develops with the squamous and the petrous part of the temporal bone. So mastoid is not developmentally a part of the temporal bone. It is formed by a fusion of squamous and petrous part of the temporal bone. So mastoid is not present at the time of birth. Yeah, after an year or so, you start developing during first year, but it is not at the time of birth. So sometimes, yes, the traction from the stenomastoid pulls it. Now, focusing on the temporal bone. Hope the picture is good.
Yes,
very good, very good, excellent.
Now, this is mastoid cortex. Now, when we drill the mastoid cortex, I will show you all these 4 parts of the temporal bone join each other in the various parts of the temporal bone, medially, laterally, superiorly, inferiorly, anteriorly, posteriorly, to make 34 suture lines within temporal bone. All named suture lines, all are important. We'll show wherever we go deeper, all 34 suture lines, and some of the suture lines, particularly medially, if are deficient, become the source of infection to spread to the brain. And that is very it is not uncommon in children who develop otitis media and immediately meningitis. Now in this era, it has reduced, but in immunocompromised, yes, it can. Now, from surface, there are certain landmarks. As I told you, on surface, everything is squamous part of temporal bone. See this eminence, this is zygomatic process, is a part of squamous temporal bone posteriorly, and it continues as a temporal line anteriorly. Here is the spine of Henle. Here is the spine of Henle, which is again a part of squamous temporal bone. And these are all important landmarks. See, the most important structure when we start drilling in the depth is the mastoid antrum. And there are many ways the people have described the McEwen triangle, triangle of attack. But the important thing is to take certain landmarks in consideration to prevent complication. So this temporal line is an amazing landmark. Amazing in the sense, useful in the sense, this corresponds to the segment plate above. Correspond means this is a safety landmark. If I drill on the temporal line, if I drill on this line, my segment plate is few millimeters above. So that's an amazing landmark. Similarly, the spine of Henle, you can follow this like this, and when you put a tangential line, Mario Sana calls it as a triangle of attack. The king of skull-base surgery, Professor Mario Sana, described so many techniques. The man who has done phenomenal work in this field.
Center it a little.
See this, I am just drilling the cortex quickly so that I can focus on the important area down. Only thing what you have to be careful is all these landmarks. See this temporal line, can you see?
Yeah,
my temporal line is here and the segment is much above. So if you take the reference of the temporal line, you are automatically away from the tegment. My tegment is here now. See how superior. Couple of millimeters above the temporal line is going to the tegment. This is tegment. Can you see very clear?
Yeah, very
Yes.
nice.
Yes.
So the soft tissue retraction has to be quite good. Otherwise, one tends to.
See the tegment level, and this was the tegment temporal line. So this is a good landmark and very safe landmark as well, as it protects the segment from getting injured while you begin the dissection.
So Satish, do pass on the tips for locating antrum for the younger viewers. They many times in a narrow sclerosed mastoid, they tend to miss it.
Yeah. So for the antrum, like Madam said, you have to drill in this area of triangle of attack, number one. And your question is so valid. I'll tell you the reason behind that. Always, when you look for the antrum, never drill a keyhole. The principle of temporal bone dissection is use the biggest possible burr and keep going deeper after widening laterally. Keep widening laterally and then going deeper. So for the antrum, the biggest mistake people sometimes commit is they create a keyhole. A keyhole cannot work. Always define the tegment, and it is always better to go close to the tegment to look for the antrum. The reason being, see, this is tegment plate all the way. In order to locate the mastoid antrum to reach out, I would always recommend not to go at this level. Not to go at this level, go close to the tegment. If you are close to the tegment, you are away from the lateral canal and facial nerve and everything which are underneath away. So go define the tegment and go along the tegment.
Skeletonize the tegment, and that's
skeletonize the tegment and then go. Keep widening at the expense of thinning the canal. Keep widening behind until you see the sigmoid sinus.
Before depth,
Sigmoid sinus is behind.
Satish,
yeah, please.
May I ask what precautions will you take if the sigmoid sinus is anteriorly or laterally placed?
To protect the sigmoid sinus?
Yes, if it is anteriorly or laterally placed.
Yeah, see, anteriorly or laterally placed, it depends upon what pathology you are operating for. For middle ear mastoid surgery, you have to respect it and stay away from it, stay anterior to it within whatever space you have, cholecystoma or other pathology, whatever. In lateral skull base, it's different. Suppose I am doing a translap and my sphenoid, the sigmoid sinus is prominent and narrowing my axis. In that situation, I will, remove the bone of the sigmoid and push it behind. That is, widening the axis by means of decompressing the sigmoid sinus. So it all depends upon what pathology you are, treating. But this is important. Your question is valid. The sigmoid sinus need to be addressed in case, and you have to be very careful in case if it is anteriorly and inferiorly placed. So even in this, our axis is not very big. This temporal bone is not extensively pneumatized, you can see.
Yes. Yeah, that's the lateral canal. You can see the lateral canal in the
Yeah,
depth.
you can already see the lateral canal.
And one more tip that I would also have for the juniors is that keep the middle ear under vision also, because that will give you a reasonable impression of depth, especially in a very sclerotic and non-pneumatized mastoid.
Absolutely
yes, very
right.
important.
Yes.
And that comes in relationship to the corner septum sometime. What happens, as I told
Yes.
you, this mastoid is formed by, fusion of the medial petrous bone and the lateral squamous bone. And sometimes this petrosquamous suture is remnant. So once you start drilling in this region, the thick bone comes in the way, and you never know, you are sometimes terrified that you have gone too deep or what. So keep taking the reference of the tympanic membrane. Anything which is lateral to the tympanic membrane, you can drill away.
Satish, can you explain what's the corner septum?
Corner septum is a persistent suture line which is present, which is otherwise, not there because of the fusion of petrous bone below medially and the squamous bone laterally to form the mastoid process. See, this medial bone and lateral bone, squamous bone form the mastoid process. And so that the corner septum is not usually there and it is pneumatized. In case that persistent petrosquamous suture is there, once you start drilling the mastoid, you come across a very thick bone. And then you are terrified that either you have gone too deep or you are disoriented or done something wrong. So what you can do, you take the reference of the tympanic membrane, what Dr. Ashim Desai just mentioned. As long as you are lateral to the tympanic membrane level, you are safe and you can drill away. Keep going and drilling and you reach the antrum deep to it. But my point.
So the corner septum will be at the same area or the same location where the petrosquamous suture is?
Yes. So normally it is absorbed and it is entire area pneumatized to form the mastoid process, normally.
Right.
But here the petrosquamous suture line, suture is, if it is, that bone is intact, present, not resolved, then it is corner septum.
Yeah, so it appears as a pseudo antrum.
Pseudo antrum.
Another situation I found youngsters getting confused is when there is a big tympanosclerotic plaque. It almost looks like a tegmen bone only. In that situation, they should be exposing the sinodural angle and then follow it anteriorly. It will lead to the antrum.
I think once again, the definition of sinodural angle is actually different from the way people look at it. The actual sinodural angle is the angle between the superior petrosal sinus with the sigmoid sinus.
Yes, it is
Yes.
in the depth.
I will show you that.
Absolutely right.
I will show what Dr. Sethi has mentioned very rightly. The actual sinodural angle is between the junction of superior petrosal sinus and the sigmoid sinus. See now, in the depth we have reached the antrum. Can you see this?
Yes, we can.
And in the floor.
Yeah, Satish, you did a very nice move there. So you actually followed the posterior wall and thin it down, because if you keep going vertically up, you're going to hit the tegmen, right? So you need to follow the curve of the posterior canal, which you did so beautifully. Yeah.
Yes. So the principle is same. As you go deeper, keep widening laterally. This is my tegmen. This is my posterior wall. This is sigmoid sinus. And see in the depth, this is the prominence of the lateral semicircular canal. This is your canal wall, and see underneath what is there, the incus, the short process of the incus. Can you see the glimpse of that?
Absolutely.
Yeah.
Very well.
Very
well.
Now, as I told, this is not a very extensively pneumatized temporal bone, but I will show you certain landmarks which are extremely useful, which God has given us. We need to understand and exploit them. And one of them, all these landmarks are needed for the deeper structures. Deeper, the most important structures out of all is the facial nerve here in this region. So in order to identify and preserve the facial nerve, we need to be careful, and we will see the entire course of the facial nerve right from the origin till destination, I told you. And here,
Satish, Sethi says that God has given us a lot of landmarks and God has given us Satish to find those landmarks.
One point for the junior people, Satish is always parallel to the structures. He's never across any structure.
You always drill in the direction of the structure, in the same axis as the structure that you want to expose. That's right.
This is mastoid tip. I am hollowing out the mastoid tip to show you something. This is mastoid tip from inside.
Yeah.
I am hollowing it out and show you a very, very important landmark, which is I
locating the
consider to be
facial
one of
nerve.
the best landmark for the facial nerve.
There you go.
See this pneumatization of the temporal bone. See the huge mastoid tip. Tip is extensively pneumatized.
So this is the kind of case where if you're dealing with cholesteatoma, you will need to remove the tip necessarily in order to prevent the sump effect.
So what
and if you're obliterating the cavity through such flap, you need to remove the tip as well.
Yeah, absolutely. So what you want, the sump effect is when the mastoid tip is at a lower level than the external canal. So whatever you do, debris will collect. So the way forward is to remove the tip and allow the soft tissues to collapse in.
Now
so
see
you can see
some
the
important
digastric
structure
ridge.
coming into picture. This muscle which is attached outside, I have hollowed out the tip. This is digastric. See that? Can you see?
Yeah, very nicely.
And see this digastric ridge where it is leading to.
Stylomastoid, yeah.
Stylomastoid foramen.
See, this is the digastric which is leading anteriorly and medially. See this?
Yeah.
Yes.
This is an amazing landmark as it is leading toward the vertical segment of the facial nerve.
Yes.
See this? This is an amazing landmark we must keep in mind. I will show you later. Once I show you the entire course of the facial nerve, you will see one by one how each and every segment of the facial nerve has a particular landmark, which is most useful for that particular region.
So Satish, tell us the boundaries till what we have to excise the mastoid tip. How medial we can go.
Boundaries of?
Mastoid tip to be removed.
Mastoid tip?
Mastoid tip.
See the medium.
It is to be lateral to the
lateral to the digastric ridge. Everything has to go.
Yes.
Lateral to digastric ridge.
Actually, when you define the digastric ridge, the tip becomes mobile.
Yes. If you completely define from here to there, it will become mobile.
Yes. Yes.
And you have to remove it. See this? You can remove it like this. This part of the bone I am drilling is the tympanic bone. This one.
Yes.
See the tip is gone?
Yes, gone.
Gone. This is all digastric muscle. Now, madam, what you were telling before, while we are talking about obliteration, when you remove the tip, all these muscles fall into and reduce the size of the cavity.
Yes.
So that is added advantage of, removal of the tip. Sometimes we feel that the tip removal will widen the cavity. Actually, it narrows the cavity overall.
Narrowed the lower part of it.
Now, coming to the size of it. Now, another important, approach nowadays, which has become more popular as the cochlear implantation has gained popularity, is the posterior tympanotomy approach. What is posterior tympanotomy? See this. You have to make an opening from the mastoid to the retrotympanum, accessing the posterior part of the mesotympanum from the mastoid, staying lateral to the facial nerve, but medial to the annulus. Is a direct entry into the retrotympanum, and that will give an access to the round window cochlea, and you can do your cochlear implantation without violating the external auditory canal, without opening the external auditory canal. In that situation, you don't need to open the external auditory canal, what we have done here. So that is called posterior tympanotomy or facial recess approach. And this has revolutionized again the science of cochlear implantation. The reason being, this facial recess, the size of the facial recess is same what in the adult and same what it is at the time of birth. See, there are certain structures which do not change in diameter after the birth. The middle ear, inner ear, if it's same size at the time of birth, what is that in the adults? Same. The mastoid antrum. The facial recess. What all changes is the pneumatization of the mastoid and the curvature of the extraorbital canal. Rest all remains same inside. So this facial recess approach can be used even in the youngest of the children. The youngest of the child we have implanted is 8 months with the same facial recess approach. So you have to be careful. You need to know the anatomy, how to approach this facial recess and do implantation. Now see, in order to carry out this, see how pneumatized this bone underneath. See how pneumatized this is. Amazing pneumatization deeper. So what are the most important landmarks to carry out the facial recess approach safely? Because the biggest concern is the facial nerve. The facial nerve remains all the way in the medial wall. So there are many ways. Indirect ways to stay lateral to the facial nerve, and direct positive identification of the facial and chorda tympani and stay in between is the best way, direct way. Why chorda tympani? Because chorda tympani stays immediately underneath the annulus. As long as chorda is intact, your annulus is almost always intact. So in order to preserve the facial nerve and carry out this approach, we take certain landmarks to avoid injury to the facial nerve. And the biggest one, see this short process of the incus. As long as I am working parallel to the short process, not going deep to it, I am always safe. See this? This incus always is lateral to the facial nerve. So as long as I am parallel to the incus, my facial nerve is always medial to it. See my burr point, I am running parallel to the incus. That's the biggest landmark I am following. This is extremely pneumatized medially, this particular bone. And you will find as I go in this plane and try to go little medial to look for the facial nerve, you will find the facial nerve.
You can see the vessels of the facial nerve
coming. Can you see the change in color?
Yes, we can appreciate it.
This is facial nerve, which is your medial limit. See that?
Absolutely.
This is called positive identification.
Sandeep, welcome to the gang. It's surprising that a rhinoplasty champ is listening in on lateral skull base. But welcome.
Hi, Sandeep.
Hi, how are you all? Nice to.
Hi, man.
Well,
how are you?
I felt a bit of FOMO with you guys all being online and in Singapore.
We have Dr. Santadeep Pon joining, a very dear friend and amazing class apart facial plastic surgeon based in UK, celebrity surgeon for the celebrity.
A celebrity human. Absolutely. It's a joy. It's a joy to have you on board, Sandeep.
Thank you. My knowledge of the ear extends to the oracle about that. That's about it. But it's intriguing watching a master operate. So definitely FOMO. And my football team are playing there today as well. So even better for you guys to be there.
Great. So Satish, we can see the chordofacial angle and the chorda is beautifully identified.
The most important is the digestic ridge. Can you see?
Yes.
This is taking toward, this is a vertical course of the facial now, and this is going right over it. Can you see?
Correct.
If you
so
follow
as long as you're lateral to the digastric, you can never damage the facial.
Which remains immediately posterior and lateral to it. It takes toward the facial now, and in the any given situation, if you're looking for the landmark for the vertical course of the facial nerve, this is one of the best.
Yes.
One of the most reliable landmarks you can think of. So this is vertical course of the facial nerve. Now, another thing which I'm looking for, see this.
Chorda now.
laterally, my lateral limit is going to be the annulus, which is defined by my chorda tympani now.
Yes.
Can you see the chorda coming in picture?
Very well.
See, this is chorda. And in between these two, I can always enter into the retrotympanum. Retrotympanum, that is going to be.
Is that the chorda? I think.
See this one is this. So this is your facial now. I've thinned out this wall. This is.
Satish,
Yes.
kindly keep sharing the size of burr you are using in different positions.
Yeah. As I go
People may
deeper,
be nice.
keep reducing the size of the burr. Now
Yes.
the two procedures I'm going to show over here. See this. This is the facial now. Can you see all the way?
Yes.
Yes, we can.
Can you see the facial now?
Yes.
Yes.
Very
Can you see
clear.
the chorda arising from the facial now?
Yes.
Can you see the chorda?
Yes. Yes.
And what I've done, I've thinned out.
Hello.
You remove this bone lateral to everything, lateral to these nerves all over, and a big chunk of this bone, along with the malleus and incus, along with the entire tympanomeatal flap, axon, artery, canal, tympanic membrane, you can remove and block. So that is my cutting line for the lateral temporal bone dissection, lateral to these two nerves. Okay.
Yes.
Now see, between these two nerves, section. Keep reducing the size of the section as well as burr point as you go deeper. Like Madam asked, can you see the chorda very clear?
Yes. Yes. Very clear. Caudal canal is even visible.
Chorda tympani. That is chorda tympani. See this, and this is facial now, and in between them is what? This is facial. This is excited.
So you are using cutting burr, but in actual live situation, you must be using diamond burr here, no?
No, until now cutting. Cutting is more safer a burr, I tell you. You use it judiciously with irrigation. Diamond gives more heat. If you use, if you try to use the diamond to remove too much of bone, this generates more heat and more dangerous.
Heat. Yes.
See, now I have shifted to diamond at this point. See, this is the posterior part of the mesotympanum.
Yes.
See this? This is retrotympanum.
Retrotympanic area, yes.
Can you see very clear?
Yes.
Then I will show you certain landmark. That is my round window region.
You are directly on round window.
Yeah, that is round window
Point
region.
blank. Point blank hit.
Satish,
yes.
Satish, sorry to interrupt. Can I take a leave from all of you all?
No.
No. Big no.
Okay.
Come on.
Okay, Narayan. Yeah. Narayan has got up at 3 o'clock in the morning. He's done a marathon.
Okay, Satish,
see now how I'm enlarging the facial recess. See this. With my, see, you need to use long tapering burr points or various sizes, long tapering. So the sharp doesn't come in contact with the nerve and damage.
So tell us, Satish, what is the maximum extent of widening you require to do in cases of cochlear?
So you should be able to see, you should be able to see 2 millimeters below the round window without any obstruction. See this now? Wide opening. Now superiorly, we should be able to see the tendon of stapedius. Can you?
Yes.
Very clear?
Very clear.
My limit anteriorly, chorda in the line, and this is the facial now with a thin bone over it. See this?
Yes.
Now enlarging and showing you the deeper anatomy. Patla section. Patla, none of the match.
So many a times retrotympanum is quite deep. So the fibers anterior part of the fibers do come in the way.
Yes.
This
See,
facial
this
nerve. So those
anatomy and orientation of the cochlea is not always same. The
not
orientation.
always same. Yes.
Sometimes it is posteriorly rotated, medially rotated, and that you can pick up on your CT scan. See now what I'm trying to show. This mucosal band I'm opening up. Can you see something?
Yes, now you can see the membrane.
Yes.
See the round
And-
window.
Yeah.
See the round
Bony niche.
window?
Yeah.
Bony
it's
niche.
inferior. It's the inferior.
Very clear?
Yeah.
And see, this is the overhang over the round window.
Yes.
See this? This overhang sometimes obliterates the visualization of the round window, and you can pick up on your CT scan exactly how millimeter thick is the overhang, so that you don't get disoriented.
And this is what Satish has revolutionized again by drilling this overhang and getting the round window membrane on a platter for you.
Yes.
This has changed cochlear implant surgery. Yeah.
Here's this round window, completely, see the much better view of the round window?
Yes,
What are
the
they?
membrane. Yeah.
Round window is the backdoor entry to the scala tympani. Will uncover the entire anatomy of the inner ear, and this is one of the most important area we must know. Sometimes you have an intractable BPPV. We have done 2 procedures and we had good results, and we had to resort to those procedures. I'll tell you, BPPV is because of the posterior semicircular canals as the particles settle down in the most horizontal canal. The most dependent canal is the posterior canal, and whatever autoconia release are settled down in the canal giving BPPV. And there are many procedures, including maneuver. Sometimes maneuver will remove that autoconia from the canal into the utricle, utricle. And if it doesn't, you need to do a lot of procedures. And one of them, what Gesek described earlier, is transaction of
The
singular nerve.
singular. Yeah.
Singular nerve is what? When I show you the intra-auditory canal, I will show you where the singular nerve arises. Is a branch of inferior vestibular nerve, which is given off just before the lateral mode part of the canal and supplies the posterior semicircular canal. And how it comes to the posterior semicircular canal? My posterior semicircular canal is here laterally here.
Yeah.
It comes from below, just close to the round window margin to supply the posterior semicircular canal. So like this is the round window margin, 1 millimeter below and 2 millimeter deeper. If I run, I will transact the singular nerve, and that will be the BPP will be over. This is one of the, though this procedure was not commonly accepted because of the complexity, but this is amazing, which Gesek described in the 70s. And we followed this. This is the region, if you drill, just underneath the lower margin of the round window, just underneath for 2 millimeter, this is where this canal runs, and you actually ruin the nerve coming into that. So that is Gesek's technique of posterior.
You done your rectum.
You have
Singular nerve section.
Yeah, singular nerve resection.
Yeah, but sometimes maneuvers themselves cure the BPPV. So
yeah.
But Satish, this singular nerve is actually coming from the IAM. So which means the IAM is just behind this?
Yes. Just behind, just deep
Just
to it.
behind
Singular nerve comes from the IAM laterally.
So yeah.
So we drill
So
in the
if you
lateral
go
course of
deeper
the
than
IAM.
this, you will be in the IAM. You will be in the IAM.
We are lateral to IAM. We are running, dissecting the nerve while it is coming out of the IAM laterally towards the semicircular canal. Canals are laterally, intra-auditory meatus is far medial. I will show you the intra-auditory meatus and all the nerves. So now, leave it. We were focused on the
round window.
Round window. This is very important anatomy. Now going to that, further, I am not opening the round window here for the cochlear implantation. I will show you how the implant should go in relation to the round window so that it remains in the lumen, not hitting here and there. most of the time people try to open up the round window and push the implant blindly. Believe me, that is not the correct way. Because if I open this round window, and push my implant straight, my implant will first go and hit the modulus. Once it hits the modulus, the implant will curl in the lumen here and there. It will hit the osseous spiral lamella everywhere. So I will uncover the anatomy of the inner ear, the cochlea, that in what lumen the implant should go and how correctly we can push into that lumen without hitting in there and there. That is the whole aim of, dissecting the cochlea 360 degree. We will dissect out all 3 turns of the cochlea. Okay? So I am not doing anything to the round window here. Okay? Now, I told you this lateral bone, you can remove en bloc for the lateral temporal bone dissection. Okay? The idea is to stay all around and remove. Here I am not doing, I am just removing this lateral wall so that we can focus on the anatomy much below. See this? Otherwise, what I was trying to say, see this? This is the tympanic membrane and the annulus. All around. In next, if you do 10 minutes drilling, all around from here, staying in the atic, going to the anterior wall, going here inferiorly, staying in the hypotympanum lateral to this now. You have to transect the chorda tympani. You stay in this plane, transecting chorda lateral to the jugular bulb anteriorly, staying lateral to the eustachian tube, going below, elevating this entire tympanic membrane, entire this thing, you remove this bone and entire thing you can remove en bloc. En bloc means for all extra-aortic canal malignancies, you can remove en bloc with entire tympanomeatal flap, tympanic membrane, malleus and incus. You have to disarticulate at the incudostapedial joint and remove this entire specimen en bloc. That is called lateral temporal bone dissection cutting the first. So thus I explained you the steps, not showing here so that we can focus much more, inside. So that is lateral temporal bone dissection. So here I am not doing, I'm removing this, bone. I hope you got the idea how it is done. You can see our previous dissection to refer to. See this.
Yes.
You can remove everything. You can remove everything like this.
Satish, good morning.
Yes, boss.
With you, Dr. Afifi from Egypt.
Hello.
Yes, boss. Can I ask you, please, when we do posterior tympanotomy, for beginners, when we do posterior tympanotomy,
yes,
we can use the bezo or not? For beginners, bezo electric surgery?
I didn't get your point. While doing posterior tympanotomy?
Not using the drill, using piezo or not?
Chisel and mallet. Can you do that?
No.
Instrument used drilling for the rhinoplasty cases, piezo, it just cuts through the bone and doesn't run on the soft tissue. That is what you mean.
Okay, piezo.
Piezo.
Yes.
Piezoelectric, yes. That you can use, that is protective to the soft tissues, but it takes hours and hours. That will
only
take...
Okay.
That is a very slow tool and that will take, so long for the bony drilling. Yes, that is a useful tool when you are close to the important neurovascular structure like facial nerve here in this region and carotid artery or anywhere. You can use that. Now see, what bone I have removed and what we have started seeing. This is the incus, this is malleus. Can you see they are suspended by various ligaments in the atic?
Slight focus, slightly more.
Ligament.
Can you see various ligaments?
Yes.
And
see the superior malleolar ligament, sometimes it is occupied. Incudal ligament, malleolar ligament. This is anterior
tensor fold area. Yes.
See, this
anterior
is
the anterior ligament for Ashish.
Yeah, Ashish. You always talk about anterior malleolar ligament. Ashish talks a lot. This is anterior malleolar ligament from the anterior process of the malleus going And just deep to it is the chorda tympani. Can you see?
Yes.
Yes, yes, yes.
Ashim, can you see?
Beautiful.
Very well,
yes.
very well. Beautiful.
We have learned this art
Not
of
only
anterior
Ashim, I also
malleolar
can
ligament
see.
stretching, anterior ligament cutting from Ashim this side. And see, immediately underneath this is the chorda tympani. So this ligament sometimes get ossified. It becomes hyalinized because of the non-use when the ossicles are fixed in atherosclerosis, and you have to really divide this ligament. You know, I remember my
the 5
times
to
with
10 dB currency. 5 to 10 dB currency of Ashim Desai.
Yes, you know, Ashish,
Yeah.
when I joined the ABR Desai,
Yeah.
this was 25 years back
Hmm.
when I was with ABR Desai, sir. When he would do stapes surgery, in spite of doing the best work, he would do intraoperative audiometry himself.
Yes.
Himself.
He still does. Ashim still does. Yeah.
Then,
We still do it. We still do it.
yeah,
Every day.
yeah, I remember. And in spite of having done everything perfect, sometimes he would not be happy. We thought everything is good. He will remove everything, open everything, canal. He remove the piston, check the anteromalleolar ligament, and cut it, put the piston again and do audiometry and show us, doctor, I have got 10 dB improvement.
Yes.
So he was so meticulous, so committed. And this malleolar ligament, if hyalinized, Ashim can tell a lot of things about it. He does very regularly. And this is something, a trick to improve your results, you know, which we mostly overlook. So this is your tympanic membrane, the ossicular chain, this anteromalleolar ligament, and this is the, you know, this is the chorda tympani. See this, how it is medial to that. And this chorda tympani here, after leaving this, I will show you later in the skull base, lateral skull base approaches. This leaves here in a canal of Usier. Canal of Usier. Here is the fissure, Glacierian fissure. In the upper part of that fissure is the canal of Usier. And it comes out anteriorly and goes deep to the TM joint. See this. This now goes in the medial. This is TM joint here. Goes anteriorly, surrounding the TM joint, medial to it, and run down vertically down in the infratemporal fossa to join the lingual nerve, which you saw during the endoscopic dissection. So this is chorda tympani, and I removed these ossicles laterally. As we go deeper, I will keep removing the structures to uncover the deeper structures. Now, once I remove, can you see something, some important prominences in the medial wall of the middle ear? See this? The most important, the facial nerve. Can you see?
Right.
This is the horizontal facial canal. And immediately underneath, medial to this, or sorry, inferior to this is somewhere where some tendon is coming through it. See, this is processus cochleariformis. Can you see?
Yes.
Through which this tendon is coming, which was inserting onto the medial surface of the neck of malleus. Now see, there are two canals. This is facial canal, and this is another canal parallel going anterior. This is tensor tympani canal.
Canal for the tensor tympani.
Canal for tensor tympani. See this? I have opened the canal, and this is for everybody the tensor tympani muscle. Can you see?
Satish, they seem to be in the same plane, and this is why sometimes on the CT scan they look like as if it is a facial nerve that you're looking at.
One section below, you will find the tensor tympani. One section above, facial nerve. Yes. For everybody, Dr. Sethi has immense interest in radiology, and the last time in Jaipur when we were dissecting, he presented his 1.5-hour lecture on clinical correlation of the radiological findings in temporal bone. In temporal bone only, by his techniques of reconstruction into various formats using various structure correlating with each other, and the way he presented was so useful that before you're operating, you can actually have a three-dimensional idea of the entire anatomy of the surrounding structures.
Boss, I was inspired by you. Boss, I was inspired by you.
But boss, we would like to hear from you that again and again.
Thank you.
That was amazing.
Yesterday he had a fabulous lecture, guest lecture for the Singapore course on MRI of the temporal bone, and he left us all spellbound.
He
Well,
loves
it was not
radiology.
actually MRI of the temporal bone. It was MRI of the. It's basically talking about various sequencers and their application in
MRI per se.
Yeah.
Now, see now another anatomy where this tendon or tensor, this is the tensor tympani muscle, where it is coming from the walls of the Eustachian tube. See where I am going. This is tympanic membrane margin. This is anteriorly where the TM joint is. Anterior wall. This is tympanic membrane margin, and underneath this, what is this? Bony Eustachian tube.
Yes.
The same Eustachian tube which we had been following from, endoscopic route. This has two parts. The medial 2/3, what we saw was cartilaginous. Medial 2/3. In the nose, in the posterior part, nasopharynx, from there it was cartilaginous. And this lateral 1/3, almost 1.2 centimeter, this is bony. And from here it starts becoming cartilaginous. I will show in the infratemporal fossa B approach. From here, we will see the same carotid artery, what we see there.
Okay.
So
Satish, what is the location of the carotid artery here?
carotid artery is medial to the Eustachian tube. See this? Let me remove. Give me a birth point. See,
And
I told you the Eustachian tube protects the carotid artery. So here, this is Eustachian tube, and see in the medial walls. See,
and that direction is identical to the facial nerve in the middle ear.
Yes.
They
yes,
both
in the temporal
like
bone.
in the similar pattern.
Yes, what madam says, I will show you. In the temporal bone, the carotid and the facial run parallel to each other. See this?
Absolutely, that's right. And you notice the relationship with the cochlea.
What? See the carotid artery here?
Yeah.
This is carotid.
Yes,
this is
yes.
cochlea. This is carotid.
Yeah. And this is a very
And
important
this was Eustachian
relationship.
tube, and this is all bony carotid artery. See, let me remove the bony lip to show you better. That's the bony carotid artery, Eustachian tube.
And this.
And this is carotid artery, the huge. This is carotid. See the bone. See, I removed the bones.
Yes, yes, we saw that.
See the carotid periosteum.
Beautiful, beautiful.
That's
You
the
can
carotid
remove that bone
periosteum.
also, the bone chip, you can remove that and you have the whole canal there.
This part of the carotid has a thick periosteum.
Beautiful, beautiful.
Now you know what happens. This carotid goes up here and turn anteriorly. See this?
Yes.
This is turning anteriorly. This is the genu. And beyond
Yes.
that is the horizontal portion which we saw from there,
Other side, nose side.
on the
huh.
other side. See that this is the horizontal portion.
Thank you.
Yes,
This is
it's the
horizontal
vertical portion that's becoming horizontal portion.
Yeah, this is horizontal and which we saw from
Yes.
endoscopic side. This is the one which is going anteriorly to the foramen lacerum. See here? And this is tensor tympani. I will show you how the tensor tympani, I told you during the mandibular nerve, that the trunk of the mandibular nerve gives a branch now to mylohyoid, which gives a branch now to tensor tympani. And here is going to be the mandibular nerve. And I will show you how tensor tympani arises from the lip of the Eustachian tube and taking a nerve supply from the mandibular nerve, and here it comes. So this canal is for tensor tympani. This is carotid. This is genu of the carotid. See that, all that. And this is cochlea. This is round window here. This is your stapes bone. And this is your facial nerve.
Facial
Okay.
nerve. Beautiful.
Now, give me the drill. Let me open it further a little bit. See, this is the facial nerve. This is your lateral semicircular canal. Can you see?
Yes, yes, yes.
This
Beautiful.
facial nerve runs anteromedial in very, very close proximity to the lateral canal. See this. See, the facial nerve has a genu here. Then it becomes vertical. Can you see?
Yes.
Various segments of the facial nerve. This is the cranial nerve, which has such a long bony course in the temporal bone. This is horizontal. Before that horizontal, let me give me a pointer. See this. This is the horizontal facial nerve. This is the genu. Here it will become vertical. And here is going to be the stylomastoid foramen. Very soon I'm going to show you.
Satish, you want to point out the first genu of the nerve? Facial nerve?
I will dissect and show you here. Give me drill. So what Dr. Sethi is wanting is the first genu here, and from where the nerve takes a deeper turn.
Deeper turn.
Behind and deep. That's a 135-degree angle from here to like here. I will show that. And the structure here in the closest proximity is the superior semicircular canal. I will show that.
Yes. And Satish, the nerve that we see on the promontory, is that a Jacobson nerve?
Jacobson's nerve, yes.
Yes.
Oh, you notice? So nice.
Yes.
See
That's
how
beautiful.
sharp Dr. Sethi is. Who has noticed, see this nerve running on the promontory, the thin nerve?
Yes, beautiful.
Yes.
You have noticed, this is Jacobson's nerve. Can you see?
Yes,
This
very nice.
is the jugular bulb.
Yes.
That is the carotid artery.
And it's
And
coming
this
from
area,
there.
the bone between that is the crotch. And this nerve is coming from there, originating from the glossopharyngeal there. I will show you once I show the translab, the glossopharyngeal nerve in the infratemporal fossa approach also. So here it is coming and see where it is going. Let me tell you, if you want to know, this is processus cochleariformis. Can you see?
Yes.
This nerve here joins couple of nerve twigs coming from various cranial nerves. So this nerve forms a plexus over promontory.
Tympanic
And
plexus.
this is Jacobson's nerve. This goes underneath this tensor tympani muscle, underneath this muscle.
Yes.
It joins a twig from the facial nerve. From the facial nerve. It joins a twig from the Arnold's nerve. Arnold is a branch of 10th nerve. How the twig come over here? See, in this posterior canal wall, the Arnold nerve is here in the jugular fossa. It gives a lateral branch in the jugular fossa, run in this bone, and then run lateral to the facial nerve in the fallopian canal. That a branch from the ulnar nerve run in the fallopian canal lateral to the facial nerve. So this nerve joins the branch from the ulnar nerve and branch from the facial nerve to form together the lesser petrosal nerve.
Okay.
All these three nerves form the lesser petrosal.
Lesser petrosal.
So lesser petrosal nerve receives the twig from 9th nerve through the Jacobsons, 10th nerve through the Arnolds, and the 7th nerve from the facial nerve. And this lesser petrosal nerve goes along just below the greater petrosal. Here,
the irony is, Satish, the irony here is that lesser nerve actually receives 3 twigs and is still called lesser.
Yeah. And known less than the greater superficial.
Yes.
Still called lesser.
This nerve, the reason being, this nerve runs below the greater superficial petrosal nerve. Because it runs below in the course, that's why it is known lesser. See, now I am drilling in this region to show you something. Above is my tegmen. See, above is the tegmen.
Also tell the location.
I will show you the labyrinthine segment. I will show you the GSPN.
Okay, important point is to tell how the tegmen bone is located in the this tympanic cavity. What is the depth of tegmen bone in the mesotympanum, antrum, and mastoid. So it has got 3 parts.
It has a tortuous course, madam.
Yes. It's slightly
always forceps.
So anteriorly it gets more inferiorly placed, no?
Yes, the more you go anterior, it is more inferiorly directed.
And we can hit it when we are working.
Tympani I have removed. This tensor tympani.
Yes.
See this lesser petrosal now going.
Yes.
Lead to the tensor tympani I told you.
Oh, yes, beautiful.
This is lesser petrosal going. Now, where is greater petrosal? This is greater petrosal.
Yes, nicely seen.
And now you can see greater petrosal is much bigger now.
See this greater petrosal going anteriorly. Wow. See this?
Yes.
Very nice.
This is lesser petrosal.
Yes.
This lesser petrosal ultimately supplies the postganglionic fibers coming through this Jacobson now to the parotid gland. And this greater petrosal, see this now greater petrosal. This is extracranial. See the important beauty of this now. This is extracranial. This contains postganglionic fibers for
lacrimal and all.
Pterygopalatine ganglion.
Yes.
See this. This now, the facial now takes a medial turn here. And it continues anteriorly as a GSPN. This GSPN, greater superficial petrosal now, see this important thing. Can you see the carotid artery below?
Yes.
This carotid turns anteriorly here and go up to the foramen lacerum, vertically straight, but extracranially. Okay.
Yes, everything is extra.
At the foramen lacerum, this carotid which is running extracranially here, at foramen lacerum, it becomes intracranial, turns upwards. Okay.
Okay. Okay.
This GSPN enters the cranial cavity over here.
Okay.
Stage extradural. Stage extradural which enters the dura over here.
Okay.
Intracranial goes straight parallel above the carotid. Parallel above the carotid right till foramen lacerum.
Okay.
At foramen lacerum is the crossover. This GSPN crosses the carotid to go down as a median now.
Okay.
Joining the deep petrogel, and this carotid crosses this GSPN to come up as a foramen lacerum and then cavernous segment we saw just now.
Yes.
So foramen lacerum is the cross point. Okay.
Yes.
Once I remove this TM joint and this, I will show you the foramen lacerum how the crossover takes place. And this is a very, very important anatomy. This GSPN in the middle fossa approach. In middle fossa approach, this GSPN runs just superior to the carotid artery. That's the biggest landmark and protection while going anteriorly in the middle fossa. This GSPN run all the way above the carotid, parallel to it. Superior to it. GSPN is superior, carotid is inferior. So that's an amazing landmark.
Yes.
Now, if this patient now, this is given GSPN, and then see here, it takes a sharp turn. I show you. This is the sharp turn here, and this segment is going down. See this part? This is labyrinthine segment.
Labyrinthine segment.
This is tympanic segment going like this, and now this is going below. This is tympanic, the labyrinthine segment. This labyrinthine segment is here.
Yes.
Then it's going to come back.
See, this is labyrinthine segment. Can you see?
Yes, absolutely clear.
Like this, and this is labyrinthine.
And
I can remove this bone. I can remove this bone to see further labyrinthine segment. But my fear is, here is the superior canal. See this here.
Yes.
This is lateral canal. This is superior canal. And here, if I try to drill, I can end up opening the superior canal. See what Madam has published, Morwani sir has published, is a transzygomatic approach. For everybody, what they have done, there I am sitting here behind the patient. They sit in front of patient. This is zygomatic arch. See this. This is zygomatic arch. They drill away this zygomatic arch and come from anterior to posterior in this direction. And this direction, they remove this bone. So this superior canal doesn't come in the way, and you can drill away this bone to expose the labyrinthine segment of the patient now.
Yes, absolutely right. Absolutely.
So
to avoid injuring the
transzygomatic approach. Transzygomatic approach to the labyrinthine segment of the facial nerve. See the glimpse of labyrinthine segment.
Beautifully seen. Beautiful.
I will show this further when I dissect the cochlea, because this basal turn of the cochlea comes like this in closest proximity to this labyrinthine segment. And this is very important.
So labyrinthine segment,
labyrinthine cochlear implant also. This labyrinthine segment is very important in cochlear implant also, because this is in closest proximity to the upper descending portion of the basal turn of the cochlea.
Yes.
Particularly in patients with otosclerosis, where the bone becomes hypodense. The current spreads to the hypodense bone more often, more intense than the thick bone. This is the thickest bone in the body. When the otosclerosis involves the cochlear otosclerosis bone, this bone is replaced by the hypodense bone. And once you implant in that bone, and the implant, if it's in close proximity to this labyrinthine portion of the facial nerve, in this upper descending portion of the cochlea, then may lead to facial nerve stimulation. And that's a disaster. Very difficult to treat. Either you switch off all electrodes close to it, or you may have to explant if the facial nerve stimulation is not stopped. So this is the region. That's why understanding this anatomy is very important. So this is facial nerve. We have seen the labyrinthine portion. We have seen the horizontal portion. And this is your genu. See this? This is genuine, this is the vertical portion. Okay?
Absolutely clear.
Now I'll elevate this circular. Elevate this entire facial now to go deep to it. Because deep to it are lots of important structures. See this facial now?
So you will be showing the anterior transposition now?
Yeah.
No? Okay.
Transpositions, yes, you can. I will tell how to do, how is to be done. Transpositions have revolutionized the lateral skull base surgery. You know, what is transposition? See the course of the face. If there are tumors deep to facial now, how you can access by the lateral skull base approach? In the past, those tumors were considered to be inoperable. But now in this era, you can transpose the facial now in various ways from its place to another place, and you can remove the tumor underneath. For example, see this facial now is coming from the first genu here, horizontal course, vertical course, and then in the parotid. Give me the.
Yes.
I will show in no time.
Once you do anterior, and then you must also show the posterior transposition.
So transpositions are, and then I will remove the facial now to show the deeper structures.
Yes, yes, later on.
See, this facial now leaves here. This is tympanic bone anterior to it. See this thick tympanic bone?
Yes, yes.
This is lateral to the jugular bulb. So jugular bulb is just here underneath. This facial now crosses the jugular bulb. In the center, half of the jugular bulb is here, half is behind. And this facial now crosses the jugular bulb like anything. See this. This is pneumatization, and let me open up this pneumatization. See this opens and access from deep to facial now. See, this is, I am working deep to facial now.
Yeah, yeah.
Here, if I follow the retrofacial approach, I can again access the mesotympanum from behind. From behind, like we did the post-tympanotomy, you can do the retrofacial approach. What is retrofacial approach? My superior limit is the posterior semicircular canal. Okay? Behind is the sigmoid sinus.
Yes.
Yes.
Below is the jugular bulb. And laterally is the facial now. See this axis? Such a huge axis. If I go behind, anteriorly, underneath this, I can go in the middle ear from here. See that is jugular bulb. I open the jugular bulb. Can you see this?
Yes, yes.
This is jugular bulb. This is jugular bulb. This is jugular bulb here. This is a high jugular bulb, you can say. See this?
Yeah.
This is high jugular bulb. This is jugular bulb. This is the, see the interior of the jugular bulb.
Yes.
Right.
Petrus
The medium of the jugular
Show
bulb
us
here.
the inferior petrosal sinus.
You can show us the interior.
Separators of the
Yeah, I
inferior
will show
petrosal
once I
sinus.
remove this.
Yeah.
And this is the jugular bulb which is projecting high up right, close to the, this thing.
So do show us the infracochlear approach to Petrus apex, and
yes, that is the route to the infracochlear approach. In this, with the high jugular bulb, infracochlear approach is very difficult. Infracochlear approach to the Petrus apex is what? Staying inferior to the cochlea, above the jugular bulb, behind the carotid artery. If I drill away this bone, this leads to Petrus apex. That is infracochlear approach.
Yes.
That's a direct approach, and this is a preferred approach in pneumatized, temporal bones. Not this. Here there is high jugular bulb. See now, this is facial now. Facial now. This is retrofacial axis. Retrofacial axis is between this semicircular canal and the jugular bulb, which axis is very narrow because of the high jugular bulb. So now what we are seeing is this facial now going out of the temporal bone from here. Can you see?
Yes.
This is
absolutely clear.
The facial now is going out, and what I will do, I will remove this bone. Give me the drill or the bone nibbler. See this part of the tympanic bone I have removed. Cut. Can you see the digestic?
Yes. Clearly.
Now see, I'll remove this little bit of the bone more and see how the facial now goes in the parotid. This is very important. Give me the drill. See why this is stylomastoid foramen? Why it is called stylomastoid foramen? The mastoid was laterally, styloid is medially. This is a styloid process for everybody. This is styloid.
Yes, very clear.
Mastoid is laterally and this is the stylomastoid foramen. See the nerve coming out of it. See this nerve.
So beautiful.
Beautiful.
See this? No, you got it. Here, the movement, the nerve. See this?
Just focus on the relationship between styloid process and the nerve.
Yes, again. See this nerve coming out of the temporal bone?
Yeah.
Yes.
Rising up. See, this is the nerve. Rising up as it leaves the temporal bone. See, this is the facial nerve. This is facial nerve. See this.
And there is a slight inferior turn when it is coming out of stylomastoid foramen, and then it goes up. Little bit, slight, very slight. So can you show the wait, Satish? I want you please show the 3 branches before it divides into the terminal, because those cut. Yes.
Already been cut, I think.
This branch is still there going to the belly of digastric, this one. Then it gives a branch anteriorly to the stylohyoid and a branch.
So when you are doing fasciomastotic or any anastomosis, we have to cut these branches to make the stump longer.
I will show you that anastomosis.
Okay. Yes.
That's a special request from Dr. Ashim Desai. See this, the facial now I have elevated. Now, if I follow this facial now, laterally, you will find it dividing into the parotid.
The point where it divides into 2 is called pes and serinus.
Pes is the entire, network. See this now, artery. See this now ascending into the parotid. See this?
Yes. Beautiful.
Okay, next one. And see how this nerve is dividing into 2 divisions. Can you see?
Yes.
Yeah.
See the division. The lower and upper. We'll follow all the branches later after the temporal bone. But see what I'm trying to say. Now, what madam was asking about the transposition. Transposition is what? You transpose the nerve to the other area. Now see, given a situation, you have a vascular tumor in the jugular foramen down. See here. This jugular foramen is immediately deep to the nerve. Can you see?
Yes.
In order to remove the big tumor underneath, this nerve overhanging that cannot allow you to give a, freedom. Cannot give you freedom to do the work there underneath and ultimately can get damaged. So what you need to do is elevate this nerve. So just elevate this nerve from here. Elevate this nerve from here and transpose it anteriorly. We make a new fallopian canal. See this now being lifted off. Can you see this?
Beautifully.
And transpose anteriorly into the parotid like this. See this.
How much time it takes to get a normal power after transposition?
After transposition, it goes to grade 2.
Grade 2, maximum grade 3 for a short time.
If the traction is too much,
no,
but
we have
to best to grade 2.
Grade 2 only.
Is normal. Grade 2 is minimal with no obvious disfigurement. Eye closure is complete. So that is minimum. So grade 2.
Because the blood supply is compromised, so we must always counsel the patient that it is not going to be better than grade 2.
See now, this is what the fallopian canal. The blood supply of the facial nerve is unique. Let me tell you.
Yes.
Why this is compromised after transposition. So for all jugular foramen lesions, see now the jugular foramen is in front of us to do anything. The facial nerve is away. The facial nerve is there. Can you see? And we can do anything you want to jugular foramen with full freedom. Wash. So this is part of the approach what Hugo Fischer described in 70s infratemporal fossa type 1 approach. The phenomenal Hugo Fish had described this in 1770s.
Imagine that time when there were no good microscopes.
Now, having done this, now the blood supply. See, the facial now runs in this fallopian canal. The blood supply comes from both ends. From above here, a branch of middle meningeal artery known as descending petrosal artery enters the facial canal at the level of first genu.
Yeah.
And from below, the stylomastoid artery, which is mostly a branch of occipital, sometimes posterior auricular, enters the stylomastoid foramen. These both vessels form a plexus around the nerve, all over the entire course. Plexus. The moment you lift it off and place it other region, the nerve gets devascularized to a certain extent, and that's how the paresis happens to occur. See this now. Okay?
Yes.
I hope it is clear.
Yeah, beautiful.
Yes,
See this is the labyrinthine segment.
So beautiful. Now there is a beautiful relation when the labyrinthine segment enters the medullary. It is lying posterior to the basal turn of cochlea and anterior to the ampulla of superior, as you are showing in this.
Yes.
Both.
Now see here in the middle ear. We have seen the round window here.
Yeah.
And this is the oval window here with the foot plate. The suprastructure I have removed. This is the foot plate of the stapes. Can you see?
Yes. Yes.
That's the oval window. It was arched superiorly by the facial. Now this is round window. Now we have to uncover the inner ear anatomy. Inner ear is most complex. I know it is difficult to understand when you read from the books. So I will uncover the three-dimensional anatomy of the inner ear now. So inner ear is composed basically of cochlea anteriorly, vestibule in the middle, and the semicircular canals behind. Okay?
Yes.
Yes.
And they all have a bony, this is entirely known as a bony labyrinth containing the perilymph. Inside is the membranous labyrinth, all over, in all these parts what I mentioned. And inside the membranous labyrinth is the endolymph. And both fluids have a different composition, endolymph being rich in potassium and the perilymph rich in a lack of potassium, more rich in sodium. So now, how to uncover this? The biggest obstacle was the facial nerve. Because facial nerve was going all the way over this part. And here in the medially, the biggest part of all this inner ear is the vestibule in the middle. Vestibule giving origin to all the three semicircular canals. Vestibule is giving origin to the cochlea. So all origins are from the vestibule, and vestibule has 8 openings. 3 semicircular canals open into the vestibule by means of 5 openings.
Yeah.
6th is the opening. What you have seen is the oval window laterally. 7th is the opening where the cochlea starts, cochlear duct. And 8th is the opening for the vestibular aqueduct in the medial wall. Let us uncover one by one, and then we'll uncover the cochlea, its tunnels, and entire 2.5 turns, and then medially how the internal auditory canal gives all the nerves to the entire labyrinth, the cochlear, vestibular, facial, all the nerves, how they are coming from the internal auditory canal. What we have seen is the anterior transposition. There is another technique, posterior transposition. How it is done? See, this is the nerve. How the posterior transposition is done? Posterior transposition done in transcochlear approaches, where you have to remove the cochlea. See, Mariasana has described modified transcochlear approaches. In modified transcochlear approaches type 1, out of all skull-base approaches, this is my most preferred approach in my most extensive cases. The modified transcochlear approach is number 1, giving widest of the exposure. To give you an overview, how widest is the exposure to address the lateral skull base? See, the anterior limit of the transcochlear approach is this carotid artery. Okay? Posterior limit is all the way the jugular bulb, this sigmoid sinus. Superior limit is tegmen. Inferior limit is jugular bulb. So modified transcochlear 1 means you have to remove everything. including the cochlea, vestibule. So it involves sacrificing the hearing. But once you remove everything, you have the widest exposure to the lateral skull base. If I remove it, my entire brain in the lateral skull base will be in front of me. That is the widest exposure. But it involves, since it involves sacrificing the hearing, that approach is not indicated in patients who have a preserved hearing. But in order to give this kind of the exposure, what is there in between? This facial nerve.
Yes.
Since you sacrifice the hearing, but the facial nerve is there, you have to preserve the facial function, and that's why you do the posterior transposition. What is that? This facial nerve, see this labyrinthine segment goes below here to the intra-auditory canal here. This facial nerve is elevated from the intra-auditory canal. You have to cut the GSPN. Cut the GSPN, facial elevated from the intra-auditory canal, labyrinthine, this horizontal, vertical, all segments are transposed behind over the sigmoid sinus.
So here I want to ask you one question.
Everything transposed behind, cutting the GSPN, right from the intra-auditory meatus till here, and then the whole area is open to play.
Okay, Satish.
You can play around in the anterior area. The facial nerve is the obstacle, and that is transposed posteriorly. That is posterior transposition.
So I wanted to ask you one question. While we cut the cauda, we never get a facial palsy. Have you ever seen that cutting greater superficial petrosal nerve can give temporary palsy to the facial nerve?
Not really, because we are cutting the GSPN after arising from the facial nerve.
Yes.
So GSPN will take off the median nerve function, not the facial palsy itself, not the motor facial palsy.
Not even temporary?
GSPN doesn't contain motor fibers. See, madam, to answer your question, facial nerve origin in the brain has two roots.
Yes.
One is the motor root,
and
another is nervous intermedius.
Yes, sensory and parasympathetic.
Yes, so nervous intermedius join the facial nerve in the intra-auditory meatus, in the medial part.
Yes.
And this nervous intermedius carries the sensory, specialized sensory and the secretomotor fiber running through the chorda tympani and running through the GSPN.
Yes.
It doesn't contain motor fibers. And rest motor nerve is different. Okay?
Yes, very nicely explained. Yes.
So the question of facial palsy doesn't arise. They contain different fibers.
Yes.
Yeah, this will affect, but the lacrimal gland is innervated by the V1 as well. The first part through the lacrimal. This GSPN innervates the pterygopalatine ganglion. From there, the postganglionic fiber goes in two nerves. One is the posterior nasal nerve, another in the zygomatic temporal nerve. That zygomatic nerve joins the V1, the branch from V1 to supply the lacrimal. So even in spite of damaging the, entire this median nerve, you may not always see the dry eye. Okay? Now, coming to the inner ear anatomy. This facial nerve, now I am lifting it again. I told you there are 8 openings in the vestibule, and yet we have not seen the vestibule. So where is the vestibule? The central core of the inner ear, labyrinth, with the cochlea anteriorly and the semicircular canal behind, the vestibule in the middle. So vestibule is a deeper structure. So facial nerve was crossing the vestibule. That's why I removed the facial nerve. And this is the fallopian canal, which I have drilled now. That's facial nerve, which is gone. See now here. Now we don't need the facial nerve here. We have seen this function.
Yes.
Now, let us see how the vestibule and semicircular canals are connected, related to each other. One by one. 5 openings of the semicircular canal into the vestibule. See this. This is lateral canal for everybody.
Yeah.
Can you see?
Yes.
I am opening it parallel to its axis. See this. Opening the lateral canal, and very soon what you are going to see. Yes, see now. Stop. It has 2 ends. See this?
Yes.
Can you see the ampullary end? This ampullary end going right into the vestibule. Vestibule is deep. This is the non-ampullary end. See this non-ampullary end?
Yeah.
This opens separately into the vestibule. This ampullary end opens in the superior posterior wall of the vestibule, and this opens in the inferior posterior wall of the vestibule. I will show you where it opens exactly in the vestibule. Vestibule is a big cavity. This is lateral canal. थोड़ा छोटा दे इस. इससे भी छोटा दे. ये भी छोटा. Now let me open the superior canal now. How these three canals are perpendicular to each other, opening into the vestibule with 5 openings. Let's see. This is superior to the lateral canal. Superior canal is much deeper than the lateral canal. Superior canal is one which is superior, obviously. Sometimes it projects in the floor of the middle cranial fossa as an eminence. We call it as arcuate eminence. See this? And sometimes it is dehiscent, giving the superior canal dehiscent syndrome. See, I am above the lateral canal, lateral canal, and going deeper. See this? Can you see some canal?
Yep.
Absolutely perpendicular to it. Can you see?
Yeah.
All canals are perpendicular to each other. See, this is the ampullary end of the superior canal, lateral canal. This is the ampullary end of the superior canal.
Yeah.
Okay?
Yeah.
This is non-ampullary end of the lateral canal, and this is non-ampullary end of the lateral superior canal. This non-ampullary end of the lateral canal opens directly into the vestibule.
Yes.
Try to listen what I'm trying to say. This non-ampullary end of the lateral canal opens directly into the vestibule, but non-ampullary end of the superior canal doesn't open directly. It joins the non-ampullary end of the posterior canal to form the crus commune which opens in vestibule. Okay?
Yes.
Now, so we have seen 3 openings. 4. 1, 2, 3, 4. Okay? And yet we have not seen the vestibule which is deeper. 5th opening is the oval window we have already seen. See that oval window? This is round window.
Yes.
Now, where is the posterior canal? See this. This is again perpendicular to it. All these 3 canals are in close relationship to different portion of the facial nerve.
Yes.
Different portion means the lateral canal is in closest proximity to the second genu. We have seen. This superior canal is in closest proximity to the labyrinthine segment.
Labyrinthine segment.
And this posterior canal is immediately medial to the vertical mastoid segment. Okay?
Yes, yes. And lies anterior, posterior, medial to that.
See, now very soon I am going to open the posterior canal. This posterior canal is a very important anatomy. I told you this is the upper limit of the retrofacial approach. See how deep it is? And I can see the posterior canal now. Can you see?
Yes.
See this. This posterior canal opens in the vestibule, in the posterior inferior part of the vestibule. Vestibule is still hidden here. I will show you all openings, opening into the vestibule. This opens in the vestibule, posterior inferiorly, and this is the non-ampullary end. This is going to join the non-ampullary end of the superior canal like this to form the crus commune here. So let us see how they join each other. They turn medially and join. I hope you all are oriented.
Yes, absolutely.
Or people slept.
No.
All set.
Yeah. Totally immersed
We are
in
all
your
here
surgical.
watching.
Your enthusiasm and knowledge is non-sedative.
Or sedative.
Non-sedative.
Non-sedative. Keeps you alert.
I wish it could be infectious.
See this? The non-ampullary end running medially there.
Yeah.
Yes.
Right. Very nice.
See this? The non-ampullary end of the posterior canal running up there. From see this?
Thoda central.
Yeah, and Satish, sometimes you can see the subarcuate canal.
What?
The
Subarcuate
artery.
canal.
subarcuate canal.
Petromastoid canal. That is known as petromastoid canal.
Yes. Yes. All
Petromastoid
right.
canal harboring the subarcuate artery
Artery.
is within this semicircular canal block.
Yes.
You know, that vessel is a branch of labyrinthine artery. Ica, which runs through the substance of the semicircular canal in between all these three canals to appear in the mastoid. And sometimes that space is occupied, becomes the source of infection to spread to the subarachnoid space. That's very important. But
Yes.
this is not so important in the adults as it is all ossified. See this. See the non-ampullary end of the posterior running up, superior coming down. This inner ear anatomy is very relevant in a lot of surgical procedures. Nowadays, a lot of more and more inner ear surgeries are being picked up for many disorders. See both the ends coming towards each other. Can you see?
Yes. They're forming the
This
crust
is coming like this. This is coming like this. Okay.
Yes.
This is the thickest bone in the body I am drilling.
Yes.
See this both ends coming together.
Beautifully.
See now they are joined.
Yes.
That's the crust commune.
Beautiful.
That's the crust commune.
Yeah.
That's the crust commune, you know. That's the crust commune which is opening in the vestibule from here. Can you see?
Yes.
Yes.
Now, we have seen 6 openings. 6 means one is the oval window. One is the oval window. Second and third are 2 lateral semicircular canal opening. Fourth is the superior semicircular ampullary end. Fifth is the posterior canal ampullary end. And 6 is the crust commune. There's still 2 openings to be seen. 6 we have seen. Now let me show you how these openings are entering into the vestibule one by one and where exactly the vestibule is. How big the vestibule is. See this. See this. I'm breaking this. See where the cavity. See the vestibule down. Can you see?
Vestibule.
Yes.
Very beautiful. Very beautiful.
See how these are opening into the vestibule. See the superior canal opening superiorly. Ampullary end of the lateral opening posterior superiorly. See this?
Yes.
Yes. Nice.
See this crust commune entering posteriorly. See the thick bone.
Yes.
Thickest bone in the body.
So you're drilling it to open the vestibule completely.
Yeah. Uncovering. See this? The bridge.
Yes.
Underneath the bridge is the opening of the crust commune.
Yes.
See the opening of the crust commune?
Yes. Very nice place.
Very clear? Now, this posterior canal here, give me. See the crust commune is opening behind. And this is the posterior canal, ampullary end.
You can cut the facial now so as to make it,
The facial now I
it is coming in the way.
Deeper. See this posterior canal?
Beautiful.
Yes.
Now where are the 2 openings? 2 more openings.
Now we can
for
see
the vestibular aqueduct now.
Yes, and we can see the utricle and saccule separately.
Yes, impressions of the utricles and saccule.
Very beautiful.
Harboring the sensory epithelium for the balance. See the utricle is? Let me show you. This anteriorly, this shallow spherical recess is for utricle, spherical recess. See anteriorly. That's why this is the oval window. See the part of the foot plate. We are We avoid putting piston far anteriorly as the saccule is very close to the lateral, this foot plate. One of the landmark publication from Hugo Fish, wherein they dissected 343 temporal bones to see the medial relationship and distancing from the foot plate to the end organs, to the vestibular end organs. This is the spherical recess for the utricle. This the elliptical recess is for utricle, and this is for saccule, spherical. So what they did, from the under surface of the foot plate, they measure the distances of utricle and saccule in the various regions of the oval window. And what they found, the most, farthest region from the medial surface of the vestibule, so the foot plate, to the vestibular end organ, utricle saccule, is in the central part of the foot plate, inferiorly here. It is away from the utricle, away from the saccule, almost more than a millimeter. So you can put your piston with much less chances of damaging the, vestibular end organs. That was an amazing study by Hugo Fish. See how much that guy has worked. Phenomenal work they have done in the field of lateral skull base. We are always indebted to Professor Hugo Fish, Professor Mario Sana. Now see, so now two openings are still hidden. Diamond. Where are two other openings? Let me show you.
Vestibular aqueduct now.
Cochlear.
Cochlear aqueduct, sorry. Cochlear aqueduct.
Not cochlear aqueduct. Cochlear aqueduct is not here.
Is the
vestibular.
That is connected differently. I will show. See this. Anteriorly. See, I am drilling, opening, widening the vestibule laterally in the anterior aspect.
Yeah.
See this.
So are you going to show us endolymphatic sac also?
That's right.
No, it is almost gone.
Yeah, I will.
That is one of the openings.
Yeah. Okay.
Yeah. See now at this step, what I have shown, that is the spherical recess.
That's near the posterior.
See the spherical recess?
Opening of the posterior.
And see antero-inferiorly. Can you see this opening going there?
Yes.
See, the cochlea has 3 lumen inside. The scala tympani, we all know, is closed by the round window here. Okay?
Yes.
Scala vestibuli arising from the vestibule.
Yeah, scala vestibuli.
See, scala vestibuli, scala tympani, and in between them is the scala media close to the outer wall. I will show you where exactly the scala media harboring the organ of Corti. That is in the middle part, that is scala media here. Scala vestibuli here arising from the vestibule, from the floor of the vestibule anteriorly, scala tympani here. I will uncover the cochlea and show you all the 3 lumens later.
Okay.
Okay. So that is the 7th opening, scala vestibuli. Okay. Where is the 8th opening? Pick them up.
Near the Donaldson line.
Yes, I will come to that. Yes, boss. So 8th opening is in the medial wall. That is so thin, like barely you can pass an hair.
Okay.
So thin to pass an hair barely. See here in the medial wall. Can you see?
Yes.
Can you see where my instrument is going?
Yes.
That is the beginning here. Can you see this instrument? Now let me open it up.
Okay.
This is the opening. Can you see?
Yes.
Very
Can
beautiful.
you see this opening?
Yes.
This is for the scala vestibuli, the vestibular aqueduct.
And that will come in.
Vestibular aqueduct lying in the medial wall of the vestibule, arising from the utricle, contains ends. Cochlear aqueduct arising from the scala tympani of the cochlea contains perilymph. Okay? So this vestibular aqueduct run in the medial wall of this what? Crus commune, and takes a J-shaped lateral turn like hockey. Like hockey, to dilate here at the posterior edge of the Peter's bone. That's the Peter's bone, that is sigmoid sinus. Here the Peter's bone is ending. At the posterior surface of the Peter's bone, to open through a double layer of dural fold, that is endolymphatic sac. Okay?
Yes.
Cutting there. Now let me open it for you to show you the endolymphatic duct and the endolymphatic sac.
We try to
Satish,
see.
what is the landmark to find this duct actually?
Pardon?
What is the landmark?
Landmark for?
You found it so easily. You know, you knew exactly where it was. You put a probe inside. So obviously you knew where to go. So what is the landmark?
I could see that. It is in the floor of the utricle, basically in the elliptical recess.
Right. I think it's where the crust commune is opening inside.
This is elliptical recess, sir.
Yes.
Now, see, now I am opening the vestibular aqueduct. See the whitish aqueduct you will follow. Can you see?
Yes, sir.
Yes, very
Beautifully
nice,
seen.
beautiful.
Follow this like a J. It turns like a J.
And actually you can see its J-shaped configuration even on the CT. If you do a multiplanar reconstruction.
Yes.
See this J-shaped aqueduct?
Yes.
Coming here behind. See this. And
Yes,
here
nicely
it
seen. Nice.
opens, it,
Endolymphatic
here it's
sac.
wide and dilates to form the endolymphatic sac. This one. This is endolymphatic sac.
Yes, nicely seen.
Beautiful.
Can you
So what
see
is the
very
average
clear?
size? What is the average size of the endolymphatic sac?
Average size?
Yeah. Yes.
The length. Length of the duct.
Dimension. Endolymphatic.
The inside is very narrow. I don't know exactly, but this dimension is almost a centimeter.
A centimeter.
The length. Now
No,
see
when
if
would
I
you say
open
that
up-
the duct is dilated? When would you say that dilate?
No, he's
see the interior of the sac.
Yes.
Yes.
Can you see the two folds of dura?
Yes.
Yes. Yes.
I am within the two folds of the dura.
The typical multiplication of dura there, and he's opening that.
Yes. See this sac.
Glistening white color inside the.
Yeah. So, you know, for Meniere's disease, this is responsible because of the high endolymphatic pressure. And there are various surgeries which has been, you know, propagated. The one which is still the function preserving, hearing preserving, is the sac decompression. Though it is not very popular,
Yes.
but believe me, still it is one of the surgeries which preserve the hearing.
Which preserve
In the sense,
absolutely.
you decompress it and allow the sac to expand and it preserves the hearing. The only
Yes.
hearing preservation surgery for the Meniere's disease is endolymphatic sac decompression. And there are reports where it
Also-
has indicated even the improvement in the sensory neural hearing loss even after
Yes.
the decompression. I don't know it is how long lasting and all that. But nowadays, we do a chemical labyrinthectomy using gentamicin, intratympanic gentamicin as a popular measure.
Yes.
Destructive surgeries are many. Labyrinthectomy, all triple
Vestibular
canal.
neurectomy.
Pardon?
Vestibular
Vestibular
neurectomy.
neurectomy.
Yeah, vestibular
also
neurectomy
is
is
a-
another hearing preservation surgery.
Yeah, another hearing.
Yeah, another hearing preservation surgery where you selectively sacrifice the vestibular nerve
Yes.
by the retrosigmoid route with a narrow craniotomy. I will show you the vestibular nerve lower down
Okay.
when we go deep. Okay, so this is all about all the 8 openings. I hope it is very clear.
Yes. All
Yeah.
openings are very clear.
Now, so what
Which
we have
was-
seen so far in the inner ear, we have seen the vestibule, we have seen the semicircular canals. Now we will see the cochlea.
Okay.
Inside of the cochlea, you know, some clinical, you know, repercussions, implications on cochlear implantation, and then the intra-auditory meatus, then we'll go translap and some infratemporal fossa approaches. Okay? So wash. Any questions so far?
No, you're going fine, Satish. We want to see the inside of the cochlea.
This is this is endolymphatic. Yeah, it opens at the posterior fossa dura, within the fold of dura. This is situated there. It just
You cannot imagine this situation in live vision.
Now see, the most important part is the anatomy of the cochlea.
Yes.
I hope the picture is good.
Very good.
Yeah,
Very
yeah.
beautiful.
It's good.
Deepak sir.
Yes, boss.
Oh, so nice to see you. Now, yes. See, what we had seen earlier.
The cochlea is so close to the carotid.
This is your round window here.
Yes.
Yes.
Okay. We'll see all the three turns of the cochlea. Every turn has three lumens. One is scala tympani, which is close to the modulus. One is scala vestibuli. And third is the scala media, which contains the organ of Corti. We will see right from the scala media till modulus how the nerve fibers run and how it is important from the cochlear implant perspective, where exactly the implant should be placed. Our aim is to stimulate the nerve fibers in the cochlea to propagate the hearing sensation. So, our aim is to insert into cochlea scala tympani, because scala tympani is close to the modulus. Let's see how it is.
Yeah.
Where is scala tympani? What happens if you put in scala vestibuli? Where is scala media? See, this is round window for everybody. Let me increase the magnification if you want.
Yes.
Is this good for you?
Yes.
Is this magnification good for you?
Yes,
Yeah.
good. Good.
See, I am opening the round window for you. This is round window.
Yes.
And I am opening for you. Can you see the back
Yeah,
door
yeah.
entry into the scala tympani?
Yes.
Yes.
If I pass my implant through it, now see, here straight is the modulus. I will show you.
Yeah. Satish,
See, that hole is
just
the
show them
modulus.
where do you drill for the extended round window approach. Show also the singular nerve.
Pardon?
Show them where you drill for the extended round window approach.
For the
And also the
nerve.
singular nerve. Yeah, both.
Singular nerve here.
He has
Yes.
shown it.
Medial to the inferior
Yes.
edge of the round window. Here.
Correct. And the extended round window approach.
Yeah, that's what I'm coming to.
Yeah.
Why extended round window? See, if you have a look inside this opening,
Yeah.
look, can you see some structure inside?
No, it is
Yes.
dull. Needs to be focused.
Yes, we can see.
No, the sharper
some-
side. Yes, now it is.
See some, vessels running over that.
Yes, seems. Yes, we can see.
That is modulus. That is modulus, which contains, that is a porous bone, which contains the nerve fibers.
So,
Now, in
Satish,
order to stimulate this, we put our electrode in the scala tympani. Okay?
Yeah.
Because if you put your electrode, that is closest to modulus. Now, if I put through the round window here, what is going to happen? My electrode will go and hit to the round window first, the modulus first.
Yes.
And then it will start curling.
Yes.
See, what is there in the roof of this? Scala tympani is the osseous spiral lamella. I will show you. So what we do, simply in our practice, this round window is a very important anatomy, and there are lots of structures running close to it. So never ever drill in the medial wall of round window.
Yes.
Just close to the round window in the medial wall is the opening for cochlear aqueduct.
Yes.
Close to the cochlear aqueduct is the opening for the inferior cochlear vein.
Yes.
Both are important structures, so never ever drill the round window. Now see, through this, if I put my electrode, it is going to hit and go and hit the modulus, which I don't want. So what I will do, drill, I will extend my round window. I will extend my round window edge inferiorly. See this bone? The cochlea, the turn of the cochlea, the orientation is like this, like this. See this?
Yes. Yes.
And then like this. So I have to open up the cochlea in the long axis of the scala tympani. See this?
Yeah.
How it can be done? See, simply, I am not drilling the medial wall. I am removing the inferior wall.
Antero-inferior.
Not anteriorly, never anteriorly.
Yeah.
No inferior wall. See now my lumen.
Yes.
Now see the entire tunnel.
Can jump into it.
There's no modulus in the view. Now see the entire tunnel. Can you see the tunnel?
Beautiful.
So it is such a beautiful tunnel.
You can see the
Tunnel.
You feel
Now when I push my implant, it is bound to be in the lumen.
Yes,
It is
nicely
never going
shown.
to hit here and there.
You always show this, and it is always so nice to see, nice, wide and open
My
and direct.
implant should not hit anywhere to the any wall of the cochlea.
Yeah.
If it hits anywhere and goes here and there, it is going to give intracochlear trauma, and our purpose is defeated.
Yes.
See this. Now see, I am turning. See in the roof of this.
Yes.
See the roof of this. Let me drill more and show you. Roof of this, I will show a diagram also and show you. See in the roof is the bone. In the roof
Osseous
of scala tympani is the bone here. See this bone?
Yes.
Yes.
This is osseous spiral lamella. I will show with the endoscope. Silent don't worry. See, that is osseous spiral lamella. See the bone in the roof.
Yes.
Whitish bone. Can you see very clear?
Yes, very clearly.
See the whitish bone in the roof.
Yes.
That is osseous spiral lamella. Can you see the whitish bone?
So where
Yes,
does
we
it
can
become
see, but you
membranous?
have to drill a bit more to show how it is rotating.
Yeah. I will show you. Everybody must see this. You will never forget.
Very
This
important.
is the important implication in the cochlear implant outcome. See the whitish bone there in the roof.
Yes.
See this whitish bone?
Yes, we can see.
Sir, you have any dummy implant, sir?
Yeah. I'm not dummy. I will push some wire or something. We'll show you
Actually, he
some,
puts a silentoscope and shows many times.
Yeah, I will show. See the lumen first.
Yeah.
Could you see this lumen? This is the big scala tympani, and see in the end it is rotating anteriorly. Okay?
Yes.
Now, let me show you another lumen.
Scala media.
Scala, no, scala vestibuli first.
Vestibuli. Okay.
See, arising from the vestibule.
From the oval window area. So you're opening up the oval window area.
See, on this side, there is another lumen.
Yes.
Can you see another lumen?
Yes.
Yes.
Sir, we are able to see the neuroepithelium also.
Yeah, that is neuroepithelium.
Very good.
See the other lumen. See very clear?
Yeah.
That is narrow one. See this? This is scala vestibuli. This is scala tympani. Can you see both separately?
Yes. Yes.
Where is the scala media?
Yep.
In between these two, let me show you. A very thin, less than a millimeter. Thin, but closest to the outer wall, closest to the promontory outer wall. Let me show you. Yes, after. And then I will show the diagram and you'll understand 3D.
Can you go one step higher in magnification, or you feel this good enough for you?
I think this is okay, I think. Now
Okay.
see, I'm
Whatever you are
breaking this
comfortable.
bone. I am
Once
breaking
it
this bone
opens
to
up, it
show
will
you.
show nicely. Yes.
See this? I have broken
Beautiful,
this.
beautiful, beautiful.
Now see, much better. See this. Can you see two lumens separately?
Yes.
Now much better?
Yes.
Yes.
Yes. Can you see in between another lumen superiorly?
Seems, yes.
The membrane.
Slightly more.
Let me show you. Let me show you. Let me
Yes.
show you.
It's between the osseous limb.
Yes.
See now.
Mold.
Again, अरे angle probe देना है यार. ऐसा मत करो. Any angle
Lateral
probe.
part
Quick.
of the
Quick.
it opens up and
Yes. See now. This is very important. You will understand then.
the peripheral part.
Yes.
See this. This in the depth. This is modulus in the depth.
Yes. Yes.
From modulus is a bony lamella which is coming. See this so flimsy.
Yes.
Can you see this whitish lamella?
Yes, we can see.
Again, see this.
Can you represent the
I will
direction
show
of
you 10
modulus?
times, don't worry. This is modulus in the center. Can you see the pinkish?
Satish?
Yes.
Satish, can you show the direction of modulus by placing an instrument in that direction?
Yeah. I am coming to it, madam.
Okay.
See, this is the modulus in the center. In the center, the core is modulus. Very clear?
Yes, very clear.
From modulus is a thin bony lamella arising. See this?
Yes, very beautiful.
Very thin. And from here, inner wall, it is running towards the outer wall. See, this is the outer wall.
Yes.
So from here to the outer wall, this is running. Okay?
Yes.
Now see, just before the outer wall, the module, this spiral lamella is ending. Just before it is ending here. It is not going all the way to the outer wall. Can you see?
Yes, it is not going all the way. Yes.
Not going to the outer wall. Here it splits into two membranes to insert on the outer wall. It splits into two membranes, one on this side inferiorly towards the scala tympani and one towards the scala vestibuli.
Basilar and resinous.
And in between, this is the scala media. Very thin space, very narrow space where the organ of Porta is. Got my point? Now see again.
Yeah.
In the center is the modulus. Here runs the osseous spiral lamella towards the outer wall. Had there been no osseous spiral lamella, there would be single lumen.
Yes.
It is divided into two lumens, one superior, one inferior. And close to the outer wall, it is ended and split into two layers. See these two layers? This triangular scala media. See this triangular scala media.
Beautiful. You can change the direction of slightly.
Yeah. Can you see this triangular scala media?
Yes. Very beautiful. Very beautiful.
Now, what is this? This inferior membrane, it is given. This is a basilar membrane.
Yes.
On which the organ of Corti rests. I will show you with the diagram.
Yes.
And this membrane going above is the Reisner's membrane.
Yeah.
That Reisner membrane separating the scala media from the scala vestibuli. Basilar membrane separating the scala media from the scala tympani. Now see, this you have seen this osseous spiral lamella, these membranes are so flimsy. If I put my implant here without this extended approach going right on the modulus, what is going to happen? The implant will curl above and hit the osseous spiral lamella. It will hit the basilar membrane. It will ruin everything and ultimately go in the scala vestibuli.
Okay.
And that's a disaster. Because what is going to happen? In order to stimulate the spiral ganglion cells here, the implant lying in the distal scala vestibuli, you have to keep the current very high in order to stimulate the spiral ganglion, the Rosenthal canal, the neuron in the core of the modulus. You need to keep a high current, and this will give suboptimal stimulation.
Yes.
Unfortunately, all the implant people are putting to the round window are blindly curling here and there. That's a blind process. And they don't see, even if the implant goes in the vestibuli and keep a high current, patient will hear. But suboptimal. Lots of studies done, big studies done, retrospectively after the implants placed, and many of the implants are lying in the scala vestibuli. So unfortunate. Understanding this anatomy, the aim is you have to ensure that your implant goes right in the scala tympani, all the way in the entire 2.5, 3/4 turn going into the lumen of the scala tympani. Can you see this?
Yes.
See the difference in the lumen. As you go deeper from here, beginning, the scala tympani is a bigger one. As you go further beyond this level, it narrows, and toward the helicotrema, it is narrowest. What's my point? The scala vestibuli is narrow here. As it goes beyond, it widens, and again in the second turn starts narrowing towards the helicotrema. So we have to place our implant in the scala tympani. Now see, where are the neurons, where the implant is going, and then I will dissect further. I'll just show you a diagram, how the nerve is formed, where the implant is going to be, should be placed, and why not in other places. Give me, please, a paper and a pen. I hope you understood what I have shown the lumens. Hello?
Yes, Satish, very
Absolutely.
nice. Very nice. Yes.
Now see what I'm showing.
Perfect.
This is the lumen of the cochlea. Okay?
Yes.
From the modulus, this is modulus.
Yes.
From the modulus, osseous spiral
Osseous.
lamella emerging towards the outer wall. Okay?
Yes. Yes.
This is outer wall.
Yes.
This is modulus. Clear
Yes.
what you have seen? This osseous spiral lamella splits here into two membranes.
Yes.
This is scala
Basement.
tympani, this is scala vestibuli, and this is scala media. Okay?
Yes.
I hope it is clear. Hello?
Yes,
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 can hear you.
absolutely.
Yes.
Tympani, vestibuli, scala media, this is outer wall, this is modulus. I hope
Yes.
so far it is clear. Now,
Very good.
Very clear.
let me enlarge the scala media, this triangular one. Okay?
Okay. Okay.
This one. Here,
Okay. Is
on
organ
the
of
basilar membrane, is the organ of Porti, consisting of couple of outer hair cells, and single one inner hair cell. Okay, there's so many outer hair cells and one inner hair cell. Got my point?
Yes.
And this inner hair cell fiber, see, the basilar membrane moves, the current spreads from in the outer wall. Here is the spiral ligament. So here the current starts and this inner hair fiber moves, and this fiber runs through what?
The osseous fibrous lamella.
Osseous spiral lamella.
Lamella or osseous
Osseous spiral lamella into the
modulus.
Rosenthal canal. Rosenthal canal.
in the modulus here. Okay. Now, in the length of 33 millimeters of the cochlear entire length, we will see in the entire length, this osseous spiral lamella is there, and such are the canals carrying the inner hair cell fiber towards the modulus. So there are around 35,000 canals in the osseous spiral lamella in the entire 2 and 3/4 turn, like this, converging toward the modulus. Okay.
Yes.
Now I'm enlarging the modulus. This is modulus. Okay.
Yes.
The fibers from the basal lamella go almost horizontal into the outermost part of the modulus. Modulus is so big.
Yes.
In the outermost part of the modulus, and here is the ganglion.
Okay.
This is sensory fiber, preganglionic. Here is the ganglion, and there forms the fibers of the eighth cranial nerve. 35,000 fibers of the eighth cranial nerve. Okay.
Perfectly explained. Yes.
Fibers from the horizontal, this basal turn, they are horizontal. The middle turn comes from above. The fibers become little tangential, vertically tangential.
In a spiral
way. Fibers from the apical turn, they project vertically down.
Okay.
What's my point?
Yes, yes, yes.
See, the cochlea has a 3 and 2 and 3/4. The entire length is from outside is 33 millimeter. Inside the modulus, this modulus is 15-16 millimeter. This in the modulus, this canal which contains the spiral ganglion fibers, ganglion cells. So it takes all the fiber, basal turn, complete turn. Then the fibers from middle turn converge inferiorly, apical turn converge here on the module in the spiral ganglion cells. So all ganglion cells are in the periphery. Got my point?
Yes, yes, yes.
All the spiral ganglions form a canal in the outer part of the modulus. This is known as canal of Rosenthal.
Very good.
Canal
Very
of
nice.
Rosenthal containing all ganglions. All spiral ganglion cells are contained in canal of Rosenthal, which is situated in the outermost part of the modulus. Got my point?
Yes.
All cell bodies of spiral ganglion, all cell bodies are situated in the outer part of the modulus, forming the canal of Rosenthal.
Yes.
And from there, all these fibers converge in the center to form the cochlear nerve, which I'm going to show you very soon how the cochlear nerve is formed. Before this leaves the cochlea, they traverse through a cribriform plate here. That cribriform plate, through which these all 35,000 fiber traverse, they take a spiral turn like this, like this, like this, like this, and make this cribriform plate impermeable for the CSF. Okay? I hope it is understood. So our goal is to keep or implant in this scala tympani so that this is closest to the spiral ganglion cell population. Got my point?
Yes.
For optimal stimulation, my implant should never go any point of time in scala vestibuli, and for that the well begun is the best way. You make a tunnel by removing the inferior wall of the round window, see the straight tunnel, push your implant into it, and it has to go into the scala tympani all the way. It is never going to be deviated anywhere. Now, this has a lot of implication on the cochlear implant insertion. See.
So Satish?
Yeah.
I have a flight to catch. I'm really feeling bad. So beautifully you are explaining. I may need to take leave. So,
oh, madam. Thank you for being
so
with
very
us
good,
in spite of
very
your busy
nice.
schedule.
One of the best sessions I could ever have enjoyed. This is the best. Thank you very much, Satish.
Thank you. Thank you.
Okay, Satish. Okay.
Thank you. Now see, coming back to the same area. इसको clean करना है. Oh, please feel free to ask me in case you find still any doubt uncleared. अरे clean करना है. तीन जने लगते हो यार.
Hello.
Yes. मेरे को देखिए ला गिला दे सुगा दे.
So Satish, are you going to pass a wire in there?
Pardon?
Are you going to pass a wire?
Yes, I will.
Endoscope.
I will pass the endoscope also.
Oh, great, great.
And the proline wire also.
That's great.
So let us uncover more the length of the, cochlear tunnel. Yeah, it's good. I hope the picture is good.
Very nice, very nice. We can see all the
what we have seen in the beginning. What we have seen this beginning of the cochlear turn, we have to follow this now.
Yes.
We will see how the modulus is there in the center, in the core, and how the turns are all around it.
Yes. So you're exposing the middle turn now?
No, the basal turn more. More of the basal turn in the length.
Till the basal turn, yes.
Yeah, then we'll open up all the turns, sir.
Yes.
See, as we go. See, this turn, and the middle turn is, see both the membranes.
Yes.
Here is the organ of Corti. See that?
Yes.
And this is the osseous spiral lamella. See that?
Yep.
Same anatomy all the way you will find. Let me open up. All the way you will find the same anatomy. This drill out is one procedure we must know. We all cochlear implant surgeons must know in situations we may need drill out, like in cochlear ossification, post-meningitis cochlear ossification, post-autosclerosis ossification, post-traumatic ossification. See this? See this all the way, how it is turning. See this. This is the upper story. This is the lower story.
Lower story. Yes.
And in between this is the, see this triangular. This is the media. And this is how the spiral lamella is attached to the modulus. See from here, it is coming and ending here, just before the lateral wall. See this? See, this is just ending before the lateral wall. Can you see?
Yes, yes, Satish.
Give me the silent endoscope now.
Now with the CL endoscope, you'll be able to see the scala tympani. You're going to pass it into the scala tympani?
Yeah, from the inside.
From the inside, yes.
Focus करना. See, I am in the lumen. आगे सेट. Oh, I am here. See the scala tympani and vestibuli? Hello?
Yeah, beautiful. Go ahead, Satish.
I am once more. Just wanted to show you the osseous spiral lamella. See this osseous spiral lamella. See this.
Yes,
this
very
is
nice,
ending before the outer wall. Can you see?
Yes.
And from there it is suspended with two membranes. See this?
Yes, yes.
This is how the lumen is and this is how it is turning inside. Can you see?
Yes, very nicely.
So now again come to the microscope. Now I will open up all the three tuns. Okay?
Yes.
Modulus will remain there in the center. See this. This is the basal turn going. And basal turn will be turning here. See, this is carotid artery.
Yes.
Just behind the carotid artery, this basal turn. See this lumen. This is going and turning up there and coming back here. This is the labyrinthine segment up there.
That's right.
And here it will become the second turn. Okay?
Middle turn.
This is modulus. This is modulus. This goes up there, directed anterior superiorly. My second turn will come here and the modulus will be here. Okay? This bone sometimes is very thin between the carotid and the cochlea, sometimes it is absent. So, and there are reports people have implanted in the carotid canal because that's a blind procedure. So now for the second turn, what is the location? Can you see the oval window here?
Yes.
That was the foot plate here.
Yes.
1 millimeter anterior to it. See this.
That's the look.
Roughly.
Right.
This is modulus. This is going to be the second turn, and modulus would be inside.
Yes. So the landmark is just about 1 millimeter above the vestibule, above the oval window.
Yes. Now I'm in the second turn. See this. See this?
Right, right.
See this second turn?
Yes.
Now let me follow this.
Satish.
Yes, please.
The other landmark for the middle turn is the midway between the oval window and the processus cochlariformis.
Yeah, exactly where I am. See, this is processus cochleariformis, and this is oval window. This is processus cochleariformis. This is oval window. Exactly where
And
in the
you're
midway.
exactly in the middle. Yes.
And see how the orientation. Let me tell you the orientation of the right angle. See, the orientation is this turn is coming here. See this here. And then it is going down here.
Yes.
See, that is the coming turn. Can you see?
Yes.
That is the ascending basal turn. Can you see above?
Yes.
This basal turn is coming like this from here. Can you see?
Yes. Yes.
And then it turns here as a second turn. Got my point? Let me thread. Give me the proline. We don't have a dummy implant, so I will show you with the proline, okay? You see how the basal turn is in continuity forming the second turn, okay?
Satish, can you focus a little bit, please?
Yes. This I will thread with this proline. See this proline?
Yes.
In the scala tympani. Proline is still too stiff. Now see. Can you see the
There we
proline
go.
coming?
Yes. 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 Yes.
See the proline.
Oh, beautiful. Beautiful. And this is still in the basal
because
turn.
I opened this outer wall. Otherwise, it would turn there in the second turn. See this.
Mm-hmm. Yes.
Where is the second turn? So this is upper ascending basal turn. Could you
Basal
see?
turn. That's right.
And this would continue here, here as a second turn. This labyrinthine segment, can you see this labyrinthine segment here?
Yes.
See? This ascending basal turn here, this ascending basal turn, this one is closest proximity to this labyrinthine segment.
Labyrinthine, yes.
Let me clear both the things for you for better orientation. Let me remove this. Give me the drill. I will show you the party wall between the labyrinthine segment and the ascending segment, turn of the cochlea. So you can appreciate how close it is. 0.6 mm thick. If the bone is porous, current may spread to facial now, and that happens in otosclerosis. That happens in trauma. Or chota, I have around 50 different size bird tips, long tapering for the cochlear implantation, because you never know what size burr you need at what point of time. See this. I'm just opening up this upper basal turn for your reference. You have seen the implant coming from it?
Yes.
See, widen to show you. See, this is the party wall with the facial now. This one, this is the party wall. Can you see where the facial nerve is?
Yes.
This is the party wall. See how thin bone it is. Could you appreciate how thin bone it is? This is facial now. From inside, you can see this is facial now.
That's right.
Yeah.
And this is the thickness of the bone there. Only this one. So, see, this is the ek side chota there.
So, Satish, the labyrinth part of the facial nerve is then always related to the middle turn of the cochlea?
Ascending basal turn.
Ascending basal turn.
This is the ascending basal turn which is coming.
Okay.
You saw the thread coming from here. And here it takes the, here the middle turn starts here.
Okay.
Let me show you how the middle turn is going and how the medial modulus is medial to it. See, let me show you in a minute. And I'll again pass the thread and you will see how it is going to the second turn. See the modulus in the center.
Yes.
See the modulus here. See now.
Yes, yes, yes.
I'll show you again. You can ask me 1,000 times here, but should be very, very clear for everybody. See this. See, this is the modulus here.
Yeah.
In the basal turn. Our turn is around and coming over here. This modulus is directed superiorly.
Yes.
And this is again the core of modulus here. And
Right.
implant is going around this.
So how far do you go in passing the cochlear implant? All the
See
way
this,
or
yes.
2/3 of the way?
See, I will show you, sir. That's a very important question you have asked. See this? This is the beginning of the second turn. See, the second turn is going there down.
Yes, that's becoming
Can you
the
see the
second turn.
modulus in the core? Can you
Yes.
see the modulus in the center?
Very
Yes, very
clearly.
nice.
Very
And see
clearly.
the thread is passing. I will pass the thread and show you.
Ashim, welcome back.
Thank you.
See? See, this is a very important part of the cochlear implant anatomy. See the modulus in the center? This is modulus here for the basal turn. This is modulus here for the middle turn. No, give me the. See, this is the
Right.
upper ascending basal turn. Can you see?
Yes.
Yes, yes.
And this is closest to the labyrinthine portion of the facial nerve here.
So
Now,
Satish, a lot
give
of
me the
these
thread again.
companies talk about different lengths. They talk about imaging to choose the length of the
Bullshit.
electro.
Bullshit.
Ah,
I tell you.
I suspected that, and I wanted your confirmation on that.
I tell you one thing. See, what you want to intend to stimulate. You want to stimulate the entire range. Okay?
Yeah, yeah. OSL, basically OSL.
Now I tell you,
Ah.
the entire length of the cochlea from basal to apical turn is 35 millimeters.
Correct.
And the frequency range to stimulate is from 0 to 20,000.
That's right.
20,000 at the basal turn, 0 at the apical turn.
Correct.
All commercial model implants available by any company, they have a fixed range of frequency to stimulate.
Right.
They stimulate the frequency range from 75 hertz to 11,750. That's it.
Okay.
They don't stimulate beyond 11,750 until 20,000.
Is there a reason for that, or?
Because that is the hearing human frequency range. We are not dogs. We don't hear 20,000.
Oh,
Our hearing
450
frequency
degrees
range
is
is
what is
maximum up to
relevant.
8,000, 10,000. You know? So, in the frequency spectrum from 0 to 33 millimeter, we don't need to stimulate everything.
Exactly.
So, from 20,000 to 11,750, it extends from beginning of the round window to 3 to 4 millimeter. It is as good as useless to stimulate.
Yeah.
What my point?
Satish, what you have taught me is about 450-degree insertion.
Yes. The reason is, give me the paper again. The reason is this entire, the cochlear lumen, which contains a stimulation by frequency range. The cell bodies of the upper turn, they project in the middle turn. I had showed you. See, the cell bodies, they project. See, this is the lumen.
Yeah.
Okay. The cell bodies of the basal turn project in the basal turn.
Yeah.
Middle turn, they project upside down in the middle turn. The apical turn, they vertically down in the middle turn. So when you implant, You don't need to implant beyond 450.
Right.
Got my point?
Got it.
If you implant till 450, you stimulate cell bodies of all 35,000 cell ganglions, number one. It is bullshit to pass beyond 24, 25 millimeter, number one. If you try to pass, as you go closer to the helicotrema towards the apex, the scala becomes so narrow. You pass your implant, it is going to give more of damage than benefit.
You will tear the scala.
You will damage everything, ruin everything.
The basilar membrane will tear. Yeah.
People who talk about, putting the implant 35 millimeter is as good as useless in my opinion.
Yeah.
No point in going beyond 24 millimeter. No point in keeping electrode for last 3-4 millimeters.
Okay.
So this is all understood because of understanding the anatomy of the cochlea and understanding the innervation, how the cell bodies project down in the cochlea from the apical turn into the middle turn.
So when you have an ossified cochlea, when you say the drill out procedure, can you tell the audience where you would begin your drill out?
Yes, I will come to it, boss. 100%. This is the most important question from the master himself. Right. So just let me, finish this drilling and I will come to that part only, because that is on the basis of, how the ossification starts. For example, how the cochlear ossification starts most commonly from meningitis, pneumococcal meningitis.
Meningitis.
And how the subarachnoid space is connected to the cochlea? To the cochlear aqueduct.
Aqueduct.
Where the cochlear aqueduct opens, close to the round window.
Yeah.
So the ossification starts close to the round window. The inflammatory process starts close to the round window. And the first part of the cochlea to get ossified is the scala tympani of basal turn, where the cochlear aqueduct is opening. Okay?
Okay.
As the process further goes, the ossification goes to the scala tympani, middle turn, and the entire cochlea.
Yeah.
And majority of the time, the scala vestibuli is spared. So if you have a good MRI, you will find the scala vestibuli is spared. And what you can do in that situation, I will not implant in the scala tympani here. I will implant in the scala vestibuli here. Can you see?
Yes.
So that is scala vestibuli insertion in cases of cochlear ossification, because this is still preserved in ossification. But once the ossification is untreated and involve the entire cochlea and everything is gone, then what we do? We use the multiple electrode arrays. Partly one in scala tympani here. After drill out, push some electrode arrays. Put some electrode arrays in the middle turn, superiorly, inferiorly, to cover whatever cochlear length can be covered. So with multiple electrode arrays, even if 4, 5, 6 electrodes, 7 electrodes are functioning, still patient can hear. That is the whole concept of drill out. The most important thing in the drill out, the message I want to give, never ever do with a regular posterior tympanotomy approach. The reason being, in cochlear drill out, if you have to drill out this cochlea, what is there anteriorly? Carotid artery. You can't control the carotid. So, for all drill out, in my opinion, the subtotal petrojectomy approach is essential, so that you can control all around. You have the carotid in your view all the way, all the time. And you can drill out under vision. See the drill out in this exposure, if you do, Hashim.
Yeah.
If you do drill out in this exposure, or if you do drill out in through narrow posterior tympanotomy, imagine the difference.
It's a huge difference. I mean, it's unbelievable. Yeah.
One should never ever attempt to risk the patient's life with the narrow posterior tympanotomy. It has to be subtotal petrojectomy if you really want to do a drill out.
Got it.
Got my point?
Absolutely, buddy.
Subtotal petrojectomy in implantation is such an amazing technique. This coming Thursday, I'm demonstrating for the Indian Academy of Otolaryngology in Jammu. A patient having cholecystoma, I will do same stage, subtotal petrojectomy, cholesteatoma removal and implantation, same stage. This is what we have done in more than 50 cases so far with disease removal and implantation at the same stage. That involves removal of all mucosa and epithelium from the temporal bone with the widest exposure. At the same time, placing implant, obliterating the cavity and blocking off all sources of future infections to the temporal bone by means of obliterating Eustachian tube and cul-de-sac closure of the external canal. Infection cannot enter into the temporal bone after the blocking of all the outside connections of the temporal bone through the Eustachian tube and external canal, and putting the electrode and covering the entire electrode with the fat. So a sterile zone is created to prevent future infection.
But Satish, I have just one little minor disagreement point out here. In that we have always maintained since time immemorial that the immunity, the immune profile of the inflamed ear and infected ear is different from the immune profile of a normal ear. Right. That is why you can never use a Teflon implant in a CSOM and ossiculoplasty because it's going to extrude, while you never have extrusion of a Teflon pistil in a normal ear. Right. So the argument is that since the inflammatory profile is changed, there will be inflammatory cytokines in a cholesteatoma at a ear. Why would you not want to do it at a second stage? I mean, because after all, you're introducing a foreign body, my friend.
That question is obvious. Once we remove the cholesteatoma, we never do in the actively draining ear at the same stage, number one.
Correct.
Control the infection, remove the cholesteatoma, remove underlying epithelium and mucosa thoroughly. You don't have to leave a trace of epithelium and mucosa.
Yeah.
And then in that sterile zone, you put the implant and cover with the, this thing. We have done more than 30 cases, particularly with the cholesteatoma, and Mariosana has a series of probably now reaching more than 200, same stage. That's that's a theoretical possibility you're talking about, but never happens when you remove the entire epithelium.
And now that you mention it, I will correct myself and I will tell you why it does not happen, because inflammatory cytokines are within the mucosa and you're removing the mucosa.
Yes.
Correct. Yes. I agree with you now.
Now see, I think Professor Sethi was with us while I was drilling the middle turn.
Yeah.
Yes.
Sir?
Yes.
To orient you, this is basal turn. This is basal turn.
Ascending basal turn and middle turn.
This is tympanine, scala vestibuli, the basal turn. This is the modulus, and this is modulus of the middle turn. Can you see?
Yeah.
This is the ascending basal turn, and this is then turning the middle turn there. Let me now again put my, give me the same thing. Let me thread it again. See this. See, this thread is quite stiff, which the electrode arrays are not. See the proline coming.
Yeah.
Can you see the proline coming?
Yes.
Absolutely, beautifully. Take a forceps and pull it.
See the proline coming.
Yeah.
Since we have removed the outer wall, so it is coming out. So what I will do now? Normally where it would go, had we not removed the outer wall, this would go in the... This is the beginning of the second turn. Give me the... Wait, what? Blunt wala. Pick the right angle there. See, I will thread now in the second turn. I remove the outer wall, so it is coming out. Got my point?
Yeah, of course.
Yes. Otherwise,
where would it go? Where would it go?
There's nowhere to go.
But into the second turn.
Nowhere else to go. Okay, great.
This is so stiff.
Yeah, I think because it's very stiff, so
It's
but we
stiff
get
and
your
I have
point,
removed the
Satish.
outer wall. So it is coming
Yeah,
out.
Yeah. We
Yeah,
get your
we get
point.
the point.
We get your point. Okay, Satish, just as an anatomical exercise, maybe you can drill out all the whole cochlea, showing the
See where
vessel
it is
turn.
going now.
Yes, yes.
Now it will go in the apical turn. See this?
Yep.
So let us open the apical turn.
That's right.
Yes. As an anatomical
I
exercise,
will
just
remove
expose
all
the
this
whole.
bone, sir. I will remove all this bone.
Yes. So all you see is the modulus then.
Yes, only modulus.
Yes. And then you can, from the modulus, you can see the cochlear nerve coming down.
Now, site for the apical turn is underneath the GSPN. See, this is GSPN going there.
Yeah.
Yes.
Underneath the GSPN.
That's right.
And this is very narrow a channel. Very narrow. So we never thread into apical turn or implant or anything, but I will show you. Now, as you said, was the cutting day. Now I remove all this thick bone and leave only modulus.
Yes.
Okay?
Yes.
Cutting the medial
Thank
side.
you.
And you see the entire cochlea uncovered.
And you will be able to appreciate his relationship with the carotid artery.
Yes, see the carotid artery.
Yes.
See, in drilling out, we advocate never do through the posterior tympanotomy, always with the subtotal petrosectomy.
Yeah.
यूं कर यार रेट्रा के बीच में आता है पकड़ इस सेक्शन ठीक है कौन नहीं ये नहीं खोल उसको दे नहीं
You can see how close it is.
Yes, how close it is. Yes.
This is complete drill out the cochlea, complete drill out.
Absolutely. Yes.
And see how close it is to the carotid artery.
Yeah. Is that the osteospiral
This is basal turn, this is middle turn. Can you see?
Yeah.
Middle turn has same both scala tympani and vestibuli. See both.
And now you
See
can
what
see
you
the
see
osseous
the-
lamina very nicely.
What
Yeah,
you see
that's the
the
osteospiral
osteospiral lamella.
That's right.
See the osteospiral lamella.
Very nice.
Beautiful.
And now I will remove this. Oh, damage the modulus also a little bit. Yes.
So that's the region of the helicotrema.
Yes. See this, remove this everything. See the middle turn, the modulus I have removed partly. Now the most important thing I am going to show you, the beginning of the cochlear nerve. See that?
Yes.
Hello?
Yeah.
Yes, Satish.
सेक्शन 50 बार बंद होता है फ्लश कर वो बंद कर देते हैं। आराम से। Can you see the modulus in the center?
Yeah.
Yes.
Very well.
Now I am uncovering the modulus completely.
The modulus seems to be very porous.
Very?
It's very porous, not compact.
Yeah, it is always a porous bone, sir.
Yeah, because so many
fibers.
So many fibers.
And in lots of cochlear malformation, this modulus is deficient, and those are the patients. We have a direct communication of the CSF space with the inner ear, unlikely to give gusher.
Satish, can you adjust the focus a little bit, Satish?
Pardon?
Focus a little bit, yes.
Hello?
Satish is a bit out of focus. It's a little bit out of focus. Okay, great. Thank you.
Excellent.
See,
Excellent.
this is the basal turn which is going all the way.
Yes, yes.
Why I'm showing this? Once you see in the CT scan,
yes, the basal turn is the first to appear and the last to go.
Most superior cut will show basal turn. Most inferior cut will show basal turn. So both the turns are in the lap of the basal turn. Basal turn is everywhere. This is labyrinthine portion of the facial. Now see this one. This is labyrinthine portion. This is your
7 up.
modulus.
The labyrinthine part is a 7 up, and the cochlea is going to be down. The
Yes,
cochlear
sir.
nerve is going to be down.
Yes. So now this will lead to cochlear nerve. See this.
Yeah.
See this cribiform region.
Yeah.
Let me show you.
Browser.
साफ कर लगा हुआ है यार, सो रहे हो तुम खड़े खड़े. See this labyrinth, this porous, this labyrinthine portion, this is going to lead to the cochlear nerve beginning. See the modulus I am drilling?
Yeah.
And this is intra-auditory canal.
And there's the cochlear nerve below there.
That is the, see, the intra-auditory meatus.
Yes. So where's the transverse crest?
This is, let me remove this and
Okay.
show you. See the big intra-auditory meatus now. It came in section. Yeah. Can you see the intra-auditory meatus? The thorough connection. See this intra-auditory meatus. Sir, now the melt and see the brain has melt already.
Yes.
See this now?
That's right. That's right.
Autolyzed. See the brain is autolyzed. So are the nerves. See this?
Yes. Yes. Very nice.
This is the intra-auditory meatus in the base of the cochlea. See the cochlea? In the middle of the cochlea is the modulus, and in the base of the modulus is the cochlear nerve, and all these nerves which have been autolyzed. See this?
Yes.
You cannot see the white glistening nerve. The cochlear nerve is whitest of all. This is how the nerve starts. That's the cochlear nerve. It starts here. Okay? So what we have achieved, we have seen this. See this? Entire vestibule we have dissected. Vestibule, semicircular canal, cochlea, entire labyrinth we have dissected. Can you see very clear?
Very clear, Satish. Very clear.
Super.
In the base is the intra-auditory meatus. See how deep the intra-auditory meatus is. And see the nerves have autolyzed. Otherwise, you would love to see all the 4 nerves together.
Yes.
So in the base of the modulus is where the cochlear nerve starts. This is This is the falciform crest. Can you see this crest?
Yes.
So there are two groups of nerves inferior to it, two groups of nerve above. Antero-superiorly is the facial nerve. Antero-inferiorly here is the cochlear nerve. And posterior-superior and inferior are the vestibular nerve, superior and inferior one. This is how the cochlear anatomy is. This is how the vestibular anatomy is and the semicircular. This is the entire dissection of the inner ear. See the basal turn, biggest turn. We have seen the turn inside the cochlear turns and everything. Anything you want me to show in the inner ear anatomy? Now there's no more inner ear left.
Satish, you opened the jugular fossa. Can you show us the anatomy of the jugular fossa?
Yeah, that's what I'm coming to. This is jugular foramen. So how the jugular foramen is related to so many things? See this. See this. This sigmoid sinus, this sigmoid sinus here goes and open in the jugular fossa here. See this behind?
Yes.
Here. And this is jugular foramen. The facial nerve was crossing the jugular foramen here.
Yes.
So let me open up the jugular foramen more to show you inside. See the interior of the jugular foramen. The jugular foramen is related to so many nerves. See this, the outer wall of the jugular foramen I have removed.
Yes.
See, this is the cochlea here. This was the cochlea. And below the cochlea is this jugular bulb. See this jugular bulb?
Can we see the opening of the inferior petrosal sinus?
Yes, I will try to in the medial wall. Yes, there is.
Come up as multiple perforations.
Yeah, there are. Give me the
Can we
drill,
focus a little bit, Satish?
Yeah.
Can you focus a little
Let me remove this posterior wall a little bit. I will show you.
Yeah.
बताओ यार उसको पकड़ लो यार 25 बार के Pardon? Yes. So this jugular bulb has lots of connections. I will show you. This continues down as the internal jugular vein. See, let me open up this, remove this posterior wall. See what bone I am removing? The part of the occipital bone forming the posterior wall of the jugular bulb. This is jugular process of the occipital bone which I am removing. See this? And widening it. Can you see some openings in the medial wall?
Is that the condylar canal?
Can you see some openings in the medial wall?
Yes.
These are the inferior petrosal sinus openings. And these one. And this superiorly, a little posterior, the bigger one is the condylar canal.
Condylar canal.
See, this venous system, the blood drains out of the blood through various sinus channels. Through the cavernous sinus, through the transverse sinuses. So this sigmoid sinus, let me give you an overview about this venous channel so understand you better. The transverse sinus is coming from here, where it joins the superior petrosal sinus, it becomes the sigmoid sinus, okay? This sigmoid sinus opens in the jugular bulb, and then in the neck it continues the internal jugular veins.
Yes.
Here the sigmoid sinus has various connections with the mastoid emissary veins. Now what happens if the jugular vein is blocked surgically or by any regions? So there are various alternative venous drainage pathways from the head. And these pathways you can see in the medial wall of this. This is the condylar vein which forms a vertebral plexus. Blood drains to the condylar vein and that forms a vertebral plexus in the suboccipital region here. And that drains the blood coming from the transverse sinus coming over here. Okay? So many a time, even if you ligate both the jugular veins, the simultaneous ligation will definitely raise the intracranial pressure. Even if you ligate both the jugular veins, the patient do not die most often. The reason is there are alternate sinus channels. But in the situation of once there is a hypoplastic jugular bulb or it is already blocked, jugular bulb, And if you block another jugular bulb, then what will happen? All the alternate venous channels in the medial wall of the jugular valve are also blocked, and that is a disaster. Same thing is done by the mastered emissary veins to open up the alternate venous channels. So this is very important to understand this venous drainage pathway to prevent disaster. This is jugular bulb. Now this jugular bulb has various nerves in the medial wall. See, if I remove this tympanic bone, you will see the jugular vein going down. This is tympanic bone, and this is what? The styloid process.
Styloid process.
Yeah, give me, let me contribute. I am removing this tympanic bone. See this. And this is the styloid process which is broken. At this.
Remove that.
See, now this bone has been removed. All bone. Now this cut. Fast. See now the jugular foramen in continuity with the neck now. This is what we do in the infratemporal fossa approach. Infratemporal fossa involves a subtotal petrojectomy to exenterate all air cells as it is going to be obliterated. Then the facial nerve transposition like what we did. Then the neck dissection and removal of this tympanic bone. See this?
Yes.
And see removal of the styloid and everything. And now this jugular foramen is in continuity with the neck. What my point?
Absolutely.
This is what we do in infratemporal fossa, and similarly you have to obliterate. So that's why earlier teaching was when you do this kind of approach, you remove all the skull base, from here with tympanic bone. If any CSF leak happens to occur, nothing is there to hold because the neck is open. So it has been advised to do the intracranial lesions separately than the extracranial after a few months to prevent CSF leak at the same stage because the skull base is removed. But nowadays we have been doing the same stage, as we have various techniques to stop the CSF leak.
Can you show the cervical carotid artery?
Yes. See this.
And as it enters the carotid canal?
Yes. So carotid canal is here anteriorly. See this?
Yes.
That's the carotid canal and that's the carotid artery. Can you see?
Yes, that's right.
That's the carotid artery.
You trace it up. Trace it up.
See this?
Trace it up. Yes, right. Beautiful.
That's the parapharyngeal carotid artery, which is continuing here as a petrous carotid. This is vertical petrous, and then beyond is a horizontal petrous.
Satish, can you share with us your technique to prevent CSF leak when you open the neck and intracranially? That would be interesting.
To prevent the CSF leak?
When the neck is open.
Yeah. So to prevent the CSF leak, you want to know?
Yes.
So what we do, after we seal the CSF space with the muscle with suturing here, open suturing of the dura with the muscle to give a tight closure. And then what we do, we take a big fat piece, long fat piece, half in the neck and half in the temporal bone like this. And we strangulate with this fat piece with a suture on the either side. See, this is the fat piece. See this?
What muscle do you use?
Yeah, this fat piece, and we strangulate with the sutures on the either side like this. So it doesn't allow the neck to communicate with the temporal bone like this. First, suturing the dural defect, suturing with the muscle. And then this fat piece, which is strangulated from neck to the temporal bone. This doesn't allow the CSF to, leak. This is very, very effective. And we have done in so many cases. Without CSF leak is no more a problem now. We can.
Thank you.
Now see, there are various nerves coming from the neck going down.
Satish, can we just focus a little bit, please?
Yes. Better?
Yeah, thank you. Thank you. Yes.
See, these are the cranial nerves, which are, see, going in the anterior part of the jugular wall, anterior, and in the medial wall of the jugular, medial to the medial wall. See, all these 9, 10, 11 cranial nerves, see these cranial nerves?
Yes. Yes.
They go in the anterior part, in the pars nervosa, this is pars venosa, this is nervosa, medial to the medial wall of the jugular wall. See this? All these nerves are coming out of the brain by taking a 90-degree turn over here and coming like this. The glossopharyngeal is right here. Glossopharyngeal is right here, and it takes a turn, 9, 10, 11 come here in the neck. So,
where does the auricular branch of the vagus nerve come in here?
Auricular branch of the vagus nerve comes from, see, this was the jugular bulb.
Yes.
It comes from the lateral wall of the jugular bulb.
Okay.
Lateral wall, which we have removed.
Right.
So these 9, 10, 11, after taking a 90-degree turn over the jugular fossa, come in the neck, and all these nerves are medial to the medial wall. So the basic principle is, when you remove the jugular foramen tumors, as long as your medial wall is intact, the jugular bulb medial wall, all these nerves are automatically spared. If the jugular fossa tumor, see what happens. This jugular paraganglioma arises from the lateral wall of the jugular bulb. Inside the jugular bulb from the lateral surface. Got my point? Then keep extending. See, this is the dome of the jugular bulb here. Do you understand my point? That's the dome of the jugular bulb here. And these paragangliomas arises from the paraganglioma tissue in the dome of the jugular bulb. Laterally. And then as it grows, it goes medially towards the medial wall.
Right.
As long as the medial wall is spared, you can remove the tumor, preserving all cranial nerves. If the tumor has grown too big and infiltrated the medial wall and gone medially into the brain, see what is there medial to the medial wall? Posterior cranial fossa. We have seen there into the posterior cranial fossa. So once the tumor is gone through the medial wall in the cranial fossa, you cannot preserve any cranial nerve. Finished. What my point? Because in the medial wall are the cranial nerves running. Many a time what happens, that is counterproductive to the surgeon, the tumor has gone through the medial wall in the intracranial space. Yet vocal cord function is intact. Cranial nerves are so, placed, their physiology is so, even that 10% fibers are working, they do not show clinical, symptom. Facial nerve, in spite of being completely involved in the jugular paraganglioma, you may find many a time the facial function intact. And that is so disastrous. When you open up the facial nerve, you will find involved, difficult to preserve, and the patient develops post-operative facial palsy, and then the onus goes upon you. So you have to have a complete consent of facial and lower cranial nerve paralysis in spite of normal facial nerve intact. Yes, if you want to know prognostically how are the chances of preserving the nerve, what you can do? Electroneuronography before. The facial electroneuronography shows less than 50% function. That means your nerve is gone. You cannot preserve it surgically, yet clinically it is intact. So prognostically, electroneuronography gives amazing information. Otherwise, it can involve you in medical legal problems. See?
Great.
So all those tumors which are going intracranially, in spite of being the lower cranial nerves looking clinically intact, are impossible to be preserved if you remove the tumor. That is very, very important to understand. So all cranial nerves go medially. So carotid here going, the facial nerve goes here, the jugular bulb is here, your sigmoid sinus is here, labyrinth is here. In the translabyrinthine approach, you keep the canal intact, and behind the canal, removing all bone, right from the middle fossa to the jugular bulb, from the sigmoid sinus. You go from here and reach angle. That is translabyrinthine approach. If you come from above, This is middle canal fossa approach. Nowadays, we do a lot of extended middle canal fossa. You can go right into the orbital apex to the extended middle canal fossa approach. Can involve orbital apex. Similarly, you can transpose the carotid artery in cases required where the tumor is deep to it. This is the carotid artery which is taking anterior turn. Now see, this part of the carotid has a periosteum. As it takes anterior turn becomes horizontal, that lacks the periosteum. So you have to be very careful in removing the tumor which are adherent to the wall. So in order to go anteriorly now, anteriorly means towards the horizontal petrous carotid, tumors going far anteriorly, you need to extend your approach by means of removal of the condyle. You have to stretch condyle below, remove it, and drill this greater wing of the sphenoid bone completely to follow this carotid artery towards the foramen lacerum, which we saw earlier in the morning. So you can remove this bone and go to the foramen lacerum, then to the cavernous sinus. So all paragangliomas, we have seen paragangliomas reaching the cavernous sinus, cholesteatoma occupying the sphenoid sinus and cavernous sinus. We have removed through all these lateral skull base approaches. Extended lateral skull base, infratemporal fossa, B and C are the approaches by means of which you can go right into the sphenoid. I can remove the tumor from the nasopharynx from here with the infratemporal fossa C approach by means of drilling the pterygoid from this side and go rightly into the nasopharynx. So there are so many approaches, according to the need. See, there is no single approach, which can be useful in all cases. According to the need, we should be able to extend, apply our approach, maybe endoscopic, open, transcranial, lateral skull base, which actually is the need according to the patient's benefit. Not that if somebody knows lateral skull base, pushing everywhere to the lateral skull base approach. If somebody is knowing endoscopic or any pathologies, you're trying to go endoscopic, that may not give a good result in every given situation. So this is, the primary overview. In the given time period, we have seen the anatomy of the temporal bone. See, the entire temporal bone is almost gone. There's nothing left in the temporal bone except if I remove. See, this is carotid, this is jugular. Now, if I remove this remnant of the labyrinth, this is transcochlear approach. Transcochlear means, see, the biggest exposure to the skull base. If I have any lateral skull base lesion, this gives the biggest exposure. From carotid to jugular to the middle fossa to the jugular bulb. Now, more than that, the Mario-san has described many extended transcochlear approaches. This is type 1. Type B involves, if the tumor involves far anteriorly towards the petroclival region or far anteriorly towards the involving the horizontal carotid artery, needing horizontal carotid control, you can combine this transcochlear with the infratemporal fossa B, that is known as modified transcochlear type B. If the tumor involves the middle canal fossa, you have to go superiorly, then you can involve this modified transcochlear with the middle fossa approach, that is modified transcochlear C, whatever. And then if it involves the suboccipital region, then you can involve this, combine this transcochlear with the, the suboccipital approach, the approach involving the vertebral artery. Vertebral artery is an important anatomy. Where is the vertebral artery? See, this is the transverse process of first cervical vertebra. Can you feel this?
Yes.
This is the transverse process through which the vertebral artery is running. See, vertebral artery is given off in the neck, lower part of the neck from the first part of the subclavian artery. Then it enters the transverse foramina of the various vertebra. And this is the first cervical vertebra. If I open up, through which the vertebral artery courses. So in all these infratemporal fossa approaches, see, you are not supposed to go more than 1 centimeter down beyond the temporal bone and 1 centimeter deep. That is the safe range. If you go below the temporal bone more than 1 centimeter down and deep, you can damage the carotid vertebral artery. So this is vertebral artery. I'm opening. See the transverse process. And this is the vertebral artery running through it.
No.
That's the vertebral artery. So there are various approaches to the, various parts. See the vertebral artery coming out. Can you see?
Beautiful. Yes, yes, beautiful.
Can you see this vessel?
Yes, Satish.
Yeah, absolutely. Super.
Absolutely.
In suboccipital approaches, what Mario Sana described, and this vertebral artery is the key. So for all this vertebral artery, see how it goes. This is coming from here, taking turn into this transverse process of the first cervical vertebra, then going behind. See this? It's going behind, and this is arching over the transverse process of first cervical vertebra. This is transverse process. Can you see this?
Yes.
This is the transverse process of. Can you see the whole course of vertebral artery?
Yes.
See how it is going behind.
Beautiful.
Huge vertebral artery. See this vertebral artery going through the transverse process, going above and arching over the transverse process of this. This posterior arch of the atlas. Can you see this posterior arch?
Yes.
Run above the posterior arch of the atlas, go behind, and then enter the foramen magnum over here. Here it enters the foramen magnum, and both side vertebral arteries joined together as at the vertebral basilar junction to form the basilar artery. Yes.
Basilar artery.
Yes.
So one side of the vertebral artery is usually more dominant than the other.
Now that is a very important point, Madam is right. See, one of the very important anatomy to identify the vertebral artery sometimes in this approach. See this vertebral artery here, it is crossed by a cervical nerve. C1. We call it C2, madam. Why C1? It is C1? Yes. Yes. So the nerve which crosses here is the C1. I have removed the bone, madam, so that's why we're not able to see that. The nerve crosses horizontally like this. That's an important landmark to identify the vertebral artery below this transverse process of C1. Below this transverse process. See this vertebral artery?
Yes.
Huge vertebral artery, and see it is not far off from above. See, this is the jugular foramen and this is the vertebral artery. This is the lower edge of the temporal bone where the digestic, this is digestic muscle. See this? So never go while this is digestic, never go more than 1 centimeter down and more than 1 centimeter deep. Otherwise, that's the biggest disaster you can think of. Vertebral artery gone means brain stem gone. Any other thing you want me to show, sir? At the time,
no, incredible, Satish. Wonderful dissection, and you've been talking continuously for the past 8 hours. So, thank you so much.
It's always a joy.
Ashim, do you want me to demonstrate anything else?
No.
From the panel?
Anything you want me to show, please.
No, thank you.
The vertebral artery.
You've been fantastic. Thank you.
The concept of some vertigo by the spondylitis, does it explain by seeing the vertebral artery something
No.
That's right.
Boss, if vertebral artery is involved, you're gone. Finish. Vertigo is too less.
Slight pressure of the vertebral artery will cause such disaster. It's unbelievable.
You know the famous cricketer Hughes.
Cricketer who died with
Hughes. Died because when the ball came, he turned and the ball hit the vertebral artery. This posterior arch of the atlas, the ball hit and it fractured and involved the vertebral artery. And after that, the new version of the helmets have come in covering the vertebral portion, suboccipital region. So all international cricketers are bound to wear those helmets covering the suboccipital.
That is true.
Okay, Satish. So I think we will end the session today. And thank you so much from the bottom of my heart on behalf of the SARC.
All thanks to one and only the big boss, the Dharambir Sethi.
No, thank you, Satish. Thank you so much.
Who has been the person who organized everything. And for me, whatever he says is always an order. There is no second thought, no question, nothing. He is the man whom I owe so many things in my life. And thank you, boss, for always keeping close to your heart and giving me opportunities. And it's always a learning opportunity to, whenever I am with you for any reason. Thank you so much.
I echo that sentiment completely, Sethi. I echo that sentiment completely. You have really shaped the thinking and the thought processes of endoscopic sinus surgery in India. And there is much that many of us owe you. So we owe you one, brother.
That's true.
Thank you.
You know, Ashay, I'm still learning, and I'm learning from Satish now. So the teacher has become the student now.
God bless.
Thank you so much. Thank you so much.
That's the most important. I mean, that's the biggest task of a good teacher, is to learn from his students.
Yes.
That's a hallmark of a great teacher, my friend.
And I also want to thank Dinesh Paul for organizing this, and it's really impressive that the dissection is being done in Jaipur, transmission is in Mumbai, and it's being beamed in Singapore here. It's very, very impressive. Thank you so much.
Boss,
thank you, Dinesh.
I have done more than 100 workshops with Dinesh, and he never fails.
Yes.
That's the kind of a guy. He is so committed, so competent, and always ready to help for any regions.
And Satish, most importantly, I want to thank JNU and Mrs. Bapna for their support and making this possible.
Right from the beginning, Madam is here with us for all the support. Big thanks to Madam and the entire JNU team. Even the director himself, Mr. Bakshi, came to see everything is in order. And we are grateful to him for giving this platform.
Please convey our appreciation to the university, and thank you so much.
Thank you, and thanks to the entire anatomy department here who have been, pivotal, phenomenal in this, help. Thank you so much.
Okay, so
Ashish, Rajiv Pachori boss.
Rajiv, thank you again. Good to see you.
Thank you, sir.
Thank you, sir. Thank you.
Haldipur sir, thank you. And thanks to the journalist, Professor Richard Harvey. And
yes, I think he has left for the airport. He wanted to be here, and he just left for the airport.
Madhuri Mehta, thank you.
Bye-bye.
Okay, I think we will terminate the session now. I'll call you later, Satish. Thank you.
Okay, boss. Thank you.
Thank you.